Good morning, dear colleagues and friends. So we are supposed to start at 10, and we are starting at 10. And hopefully our speakers and others will maintain the time so that we finish exactly at the time we are supposed to. So we always start at time, but somehow in the middle we always lose a lot of time because of overshooting. So we have a timer. To begin with, this is our 9th East Kolkata Doctors Group conference. It's a physicians conference, so we try to expand the horizons of discussion, not sticking only to diabetes. The next 10 years is going to belong to primordial prevention. As of now, we are doing secondary prevention. Patients coming to a chamber with diabetes, hypertension, dyslipidemia, we are trying to control those and prevent development of organ failures like CKD, liver failure, heart attacks, strokes, etc. But now we have molecules and strategies by which we can catch them early in the primordial prevention state or in the primary prevention state so that they do not develop this disease per se. So that's what we'll be focusing on. This is a prelude, this conference in the month of May. Please take note of our slide. Please take note of my first slide. I'll be giving you our website details. Everything will be flashed in it. This is East Kolkata, EKDG.in is our website. And you can also find all our program, this program itself being transmitted live now in YouTube, Instagram, and Facebook Live. And it will be there recorded. If you can go back home and you can go back to your sessions, you can see them. We also will have small snippets on those programs, which you can see. Next month onwards, in the month of May, we'll be doing dedicated workshops on obesity, how to tackle obesity, how to become obesity specialists, and how to have your own clinic and workshops, set up to look after your patients. This conference today will be dealing exclusively with obesity-related manifestations. For example, obesity, simple obesity, followed by obesity with type 2 diabetes, MASLD, previously called NFLD, CKD, heart failure, etc., etc. So I'll just have 5 slides to set the ball rolling before I hand over to my cardiologist colleague to take us through. So this is the era of primordial prevention. As I said, primordial prevention means patients who have simple obesity have not yet developed any comorbid conditions like hypertension, dyslipidemia, and that is the stage where we need to intervene. Unfortunately, these people do not consider themselves as disease, so they do not come to a chamber. So if tomorrow I open up an obesity clinic, how do I get my patients or how do my patients reach me? It's a public health problem. So we have to do programs in public through Rotary, through Lions Club, going through the clubs, going through schools and creating an awareness. Otherwise, unlike type 2 diabetes, obesity will not be tackled. The main culprit is ectopic fat accumulation. So we have fat in our system, but a lot of us have fat in the subcutaneous space. Now that's not bad. I will show in my subsequent presentation on non-pharmacological management of obesity of how to estimate or differentiate between the subcutaneous fat and visceral fat and then take a call. Because if you develop obesity and the fat is accumulating in your organs, for example in liver, you have fatty liver disease which then translates slowly into steatohepatitis and cirrhosis of liver even without alcohol. If it goes into your kidneys, you develop fibrotic changes, which ultimately leads to CKD. In brain, you start developing Alzheimer's or type 3 diabetes, that it is called, or we have dementia. Goes into your bloodstream, you develop dyslipidemia, excess fat goes into your heart, we develop heart attack and stroke. So somehow this influx of fat in the visceral tissue needs to be tackled early on. We are actually dealing with them after all those stages have been crossed. Patients have developed those disorders, and then we step in. Now, this is our target. Once we tell our patients with simple obesity or with type 2 diabetes, hypertension, dyslipidemia, who are obese, that you need to lose weight, we need to understand just a 2 or 3 kilogram weight loss probably means not much. 0 to 5% weight loss from baseline is good for control of sugar and hypertension. But if we have a patient who's pre-diabetic and obese, and we want to prevent that patient from converting into frank type 2 diabetes, they need a minimum of 5 to 10% weight loss. The 2025 ADA consensus statement says we need at least 7% weight loss from baseline to prevent MASLD or conversion to type 2 diabetes. And if you want to prevent cardiovascular outcomes and NASH, that is steatohepatitis, we need at least 10% weight loss from baseline. The existing SGLT2, GLP-1 are not capable of giving us more than 10% of weight loss from baseline. So we need something else, which will be discussed later on. And if we have a new term which has thrown into the public forum, mainly by Dr. Mohan, which is remission. Yes, there is a chance of type 2 diabetes remission. We have seen that temporarily happening with bariatric surgery, but for that you need at least a 15% weight loss from baseline. And there is significant reduction in CV mortality and preserved ejection fraction heart failure. So this is the spectrum we need to follow. Patient needs to be followed at every 3 months interval. These goals needs to be fulfilled. Very important, one of the most important factors why GLP-1 reduces heart attack and stroke, and why SGLT2 doesn't do that, and why, in spite of giving statins, till 2005-6, we had extremely good reduction in cardiovascular outcomes, and then we started, it's going up, is because this is the hierarchy. With GLP-1 agonists have the highest impact in reducing epicardial adipose tissue thickness, followed by SGLT2, followed by statins. And this is precisely why GLP-1 gives us those advantages. So these are the strategies for primordial and primary prevention. We need to assess for ectopic fat, and how do we do that? Anthropometry tells you about the total fat, doesn't tell you about visceral fat, but it is important. BMI, waist circumference. Now waist-hip ratio is gone. We have waist-height ratio, neck circumference, and quantitative we need to do body fat analysis. I will discuss it in the next topic. Annual FIB-4 score easily done with LFT and with your platelet count, and a stop bank questionnaire out there, only 8 questions. You ask them, more than 3 is equal to OSA. You need not do a sleep study. These are validated. And you can straight away start treating them for OSA. These are indirect measures of visceral adiposity. So I'll end here by saying that what we'll be discussing today in this conference are dietary modification, FLET diet, very low energy diet, how you can do it without a dietitian. We'll be discussing that. Exercise, preservation of lean muscle mass, pharmacotherapy, we'll be discussing semaglutide, we'll be discussing tirzepatide, and bariatric surgery. So with this, I want to end and hand over to Dr. Nirmala Chakraborty. Nirmala is our MC and will take us through for the rest of this program. Nirmala, I hand over to you.
So good morning, friends. At the outset, I welcome all of you to this very important meeting. You call it CME, you call it conference, whatever you want to call it, but we need to understand why we are here today. The whole day will be dedicated for some of the very, very important aspects which we are looking at today. And I think the most important part is the cardiometabolic, kidney and heart conditions that are being taken into account these days as far as different situations are concerned. And of course, liver is a part of the game. So possibly the metabolic milieu has evolved over time in such a manner that we need to understand how we should tackle a patient as far as their different complications or conditions. And as Shomik was saying, the primordial things to be taken care of, and which we often miss, we see patients in a later phase. Anyway, so a whole day of academic feast is in front of you. I think all of you will enjoy it and be free and come up with whatever queries which we will try to address to, so that in the clinical practice at the end of the day our patients are benefited. So with these small introductions which has already been done, we will be starting with managing the deadly duo of ACS and heart failure from, I think the Jayanto Chakraborty will be our chairperson. So may I request Dr. Chakraborty to come over to the podium and pick up from here. Thank you.
Enough introduction has been given by the Shomit and Nirmaloda. So without wasting time, I am going straight to the subject. The first topic is managing the deadly duo of ACS and heart failure by Dr. Shomik Chaudhary.
Thank you, sir. Good morning, everybody. Excellent words to start off the day with, and I would like to add one slight term to that. As Nimalu sir was saying, call it a conference or call it a CME. I would call it a good old-fashioned Sunday morning adda. We are Bengalis, of course. And I think in these kind of addas, we really get a lot of information that sometimes just banally reading articles will not get us. There are discussions that take place, there are thought processes that take place which really open up new vistas. Keeping that in mind, I would like to talk about something which is actually extremely relevant considering I am a cardiologist. I'm currently working in PLS. Discussing about the deadly combination of acute coronary syndrome with heart failure, and obviously there must be a link to diabetes and diabetic drugs that what we are discussing today. Why is this important? Because let me give you a perspective. When there is, say I'm at home, I get a call from my resident that there's a patient who's come in with MI. The first question I ask them is the patient in failure? Because that becomes an extremely important point at which the paths diverge. An ACS patient with failure and an ACS patient without failure is a significantly different patient, is a significantly prognostically different patient. So keeping that in mind, let's look at what the burden is. How do we keep the pipes clean? As I say, sometimes as a cardiologist, I'm a glorified plumber and electrician. Either I'm cleaning pipes or I'm repairing wires. I'm doing one of these two things most of the time. So how do I keep the pipes clean? How do I keep the pump running? How do I keep it pumping? And how do I prevent the heart failure secondary to MI? So looking at the burden of ACS with heart failure, do we have the pointer? Yeah, thanks. It'll be easier actually. Yeah, thank you. So yeah, looking at the burden, obviously heart failure is a much, much bigger burden because heart failure does not come only from ACS. We have multifactorial ways in which a patient can present with heart failure. ACS is a very big and probably a more dangerous according to the patient, because a patient is having a chest pain will come to you at 3 o'clock at night. A patient having an on and off shortness of breath with pedal edema will probably come to you after 3 months. So this is a reality. It's a truth that we see. So the ACS burden is actually much lesser. But if you look at this part which overlaps, that's about 3.6 lakh patients who will have ACS with heart failure, or vice versa sometimes. They are known heart failure patients who will have an ACS later. Now, this number is very, very important. During index MI, about 1/3, 37% patients will have heart failure concomitantly. Within a month, within a year to 5 years, almost 2/3 of patients will have some form of heart failure. To stop it from going to this number, preventive measures are extremely important. Secondary prevention, yes, this is not primordial. This is secondary prevention, but extremely important that we arrest the curve at this point. So primary PCI patients, and this is something that is a good and a bad thing together, I'll tell you why. Because there are times we get a patient, chest pain, within 2 hours, patient comes in, we do an excellent primary, LED was obstructed, we opened it up, we pat ourselves on the back, we do an echo is 38%. Our faces start to droop. What did we do? Didn't we save the heart? The initial post-primary STEMIs, almost 40% odd, will have a low EF because of the myocardial stunning. That's a reversible myocardial ischemia. It's not a true infarct. If we have ways to prevent this from going into chronic heart failure or going into a chronic infarction, a lot of these patients in 2 to 3 months will have an EF of more than 55%. That's what we have seen in reality, and that's very important for us to start the correct drugs at the correct time. Hence, the primary EF drop worries me. A EF drop which persists after 2 months worries me much more than that, to be very honest. If there is a heart failure associated, these are the numbers, almost 3 to 4 times higher risk of CV deaths and all-cause mortality. It's a no-brainer. A patient MI with heart failure is the highest risk patient for us. It's a patient we expect to have the highest mortality. What are some of the other comorbidities that really worsen the risk of heart failure in the MI patient? The worst is obstructive airway disease. Most of these patients are elderly. They have a concomitant COPDs, much higher risk of heart failure. CKD, multi-vessel disease, diabetics, and LAD. As I say, the anteroseptal MI patient presents with heart failure more often than not. The inferior wall MI patient, as we say, presents with shock and block. The BP is falling, the heart rate is dropping, but almost always you revascularize, they will recover very well. The anterior wall failure is a very scary proposition for us as well, because unless we save the myocardium in time, things tend to go really badly after that. So coming to this pathophysiology, during the hospitalization, what really matters, as I said, the myocardial stunning. This is not a true infarct, it's more like a stunned, hibernating myocardium. There is some amount of necrosis, not much, hopefully. That's what a primary PCI is for, to stop the necrosis. But a decompensation, as I said, a heart failure patient could be going into an acute coronary syndrome. So there's a decompensation. There's an early acute mitral regurgitation. Sometimes there is some amount of volume overload. I'm doing a difficult primary, patient has 200, 300 ml of dye goes in, that by itself, in a patient whose EFs drop to maybe 35, 40%, will produce the heart failure, rather than having a heart failure due to the MI per se. What's really scary is the late heart failure, because that is a scar formation. It's a cardiomyocyte death. There's a negative remodeling. So drugs that can prevent this negative remodeling as early as we can start actually give us the best results in improving long-term heart failure. So starting early and starting correctly becomes very important. Now the primary part, as I said, the plumbing must be good, the pipes must be kept clean. It's very important to identify the correct antithrombotic therapy. As per definition now, and this is a class 1B indication, there is no contraindication for ticagrelor as a first-line antithrombotic. Why do I say there is no contraindication? Because earlier, when the Plato data first came in, there was the initial AHA or ESC guidelines had one slightly differing view. They said if you are going in for early intervention, definitely go with ticagrelor. But if the patient is going to be thrombolized or not going for early intervention, probably go with other ones like clopidogrel or prasugrel. Prasugrel has tended to fall off the radar. But clopidogrel probably easier, available, all of those things, more data over time. But this has now pretty much been debunked. Regardless of your therapy, interventional, medical, thrombolytic, does not matter. Ticagrelor is now the recommended P2Y12 inhibitor. So starting with a 180 loading dose and a 90 BD, as we all know, very important to start off, obviously with aspirin along with it. Aspirin has been like an orphan drug for years, yet it still remains one of our first line antithrombotics. Along with that, the high-dose statins, looking at various other options that we have for LDL reduction, that's a discussion for another day. But starting ticagrelor right up front, as we say, upstream, is very important. In fact, in a lot of these patients, we start ticagrelor and we take up within 5, 10, 15 minutes for a primary. With clopidogrel, theoretically, to reach the actual dosing levels in the blood takes about 2 hours. Your primary should ideally end by that time. So starting ticagrelor is very important. There is one group of patients that is a question that I'm always asked. Say there is a MI, patient has a chest pain, he's 3 hours away from Calcutta, he has been loaded with clopidogrel and then sent for a primary. What is the guideline recommendation? Very clear, very unambiguous. If your patient has or has not received clopidogrel, does not matter. You reload the patient with ticagrelor. So the previous naivety of clopidogrel is irrelevant. If the patient, if it's an acute coronary syndrome, regardless of whether the patient has received or not, start ticagrelor in the loading dose. This is where ticagrelor really acts. It's a P2Y12 inhibitor. The famous ones obviously are clopidogrel, prasugrel, but ticagrelor and cangrelor. Cangrelor is very important, being the IV form, and sometimes it becomes important. Not often, rarely, but yes. Now, this is the data that's really amazing. If you look at CV deaths, MI, or all-cause deaths, ticagrelor shows significantly better outcomes. This was Plato data, which really was the game changer. We finally had a drug which was extremely potent. It was not a pro-drug, it was an active moiety, and it worked very fast. Probably within 10 to 15 minutes, you get the blood levels which are adequate. Now, reductions and dosing, this is a slightly, I won't say controversial, it's a bit of a theory changing or philosophy changing concept. Initiate 90 BD, continue 1 year, no doubt. Beyond 1 year, what do you do? There is data, there's a trial called Themis, and there's other trials also which show rather than stopping it completely, continue at 60 BD if there is a low bleeding risk and at least 2 risk factors. Diabetic, multivessel, more than 1 stent, stent length more than 60, bifurcation, CKD, all these are risk factors. So 2 or more of these continue at least 2 to 3 years more, but at 60 BD, not at 90 BD. The reductions in CV deaths persist, even up to 4 years. So this is one of the last couple of things about ticagrelor that we will be finalizing. There are 150 drugs probably available, but the data, the trials, the science, the outcomes, all of them have been with the innovator molecule. Practically speaking, I do not wish to play with the life of my patient. More importantly, I do not wish to play with my life playing with the life of the patient. So I would probably, and I do, at least for the first 3 to 6 months, without a doubt, I use the innovator. Beyond that, and finance is really not so much of a problem anymore. The cost factors have pretty much come close, the innovators and the generics. So it makes sense, it keeps you safe as well, apart from the patient, by giving the molecule that has been recommended by data. Now, coming to the other 2 drugs which are important, obviously statins, high dose, secondary prevention, Jupiter trial, rosuvastatin, 71% relative risk reduction in MACE events. So this is data which is, why is it not moving? Yeah, it did. Yeah, there's the one. More than 50% LDL reduction. Now there are more drugs coming in, of course. We have injectables. We have injectables of 2 weeks. We have injectables of 6 months coming in. A lot of those are definitely additives. But your primary drug to reduce LDL cholesterol levels, which still remain the milestone in ACS management or CCS management, is a statin, rosuvastatin, Jupiter, excellent results. Now, to keep the pump working, to reduce the heart failure, some of the basic data that we know, the ABC, look at those. Those I don't have to really talk to this August gathering here. What's important is the fact that initial period what you do is basically you're trying to maintain hemodynamics. So whether it's a vasodilators, if the hypertensive, or you might be requiring inotropes if the patient is hypotensive, vasopressors, morphine is required very often, reducing fluid overload, mechanical support sometimes. This is the initial management. However, the long-term management is actually what is going to prevent long-term chronic heart failure. The LV systolic dysfunction has to be reduced. So here, we know what are the 4 pillars. We have repeated them ad nauseatum. First pillar was a beta blocker. The second pillar was a RAS inhibitor. Initially ACE inhibitors, now obviously ARNI. The third pillar was an MRA. And the 4th pillar, which actually started becoming the biggest pillar of them all, is an SGLT2 inhibitor. Loop diuretics, ivabradine, they all are there as part, but they are not the primary pillars. So what's very important, and I will come to this one part, the initial conventional concept. Start with an ACE inhibitor ARB, wait up to 2 to 3 months, start with a beta blocker, wait up to 2 to 3 months, start with a MRA, wait, half of your patients have waited away. They're not there anymore. The earlier you start, the better is the benefits. So this is now called the rapid initiation. It's called the 4 in 4. Start with a beta blocker and SGLT2 ideally because they are metabolically probably the most safest at this point. Within 2 weeks, you should be able to get in an ARNI. I'll finish in a half a minute. Within 2 weeks, try to get in an ARNI at least. And within 2 weeks of that, try to get the MRA in. Now, these are not set in stone. You could start with the MRA before the ARNI. You could even be maybe an ARNI and SGLT2 first. But this has found to be the most logical and probably feasible. 4 in 4. Within 4 weeks, all 4 in. The earlier we start, the better results we are going to get with these patients. 4, 5, 6. Start all 4, 5 drugs. You're adding 6 years of life. There is significant outcome results. So just to summarize all of these things together, the only drug which has HFpEF, HFrEF, HF mid-range, which HF IMPEF, all the heart failures that have been terminalized, is an SGLT2 inhibitors. DAPA and EMPA, are they equals? Not really. Probably if there is a heart failure, when you look at the overall heart failure outcome data, DAPA has some amount of better results. Pure heart failure hospitalizations. So, but even if it's not available, even EMPA might work.
Please conclude.
Yes, sir. But to conclude, what you do upfront in keeping that pipe open, keeping the pump running is very important. But what you do beyond that as well, your job doesn't stop on the first day. Prevention of heart failure, starting the drugs early, is as important for a long-term prognosis. I think I'll pretty much conclude here today. Let's not waste more time. Thank you.
Thank you, Dr. Shomik,
Thank you, sir.
for your excellent talk. Please come here.
Thank you, sir.
I think question answer will be at the end of this session. Our next speaker is a CKD, first line after flow trials, SGLT, GLP or phenylalanine by Dr. Manik Katartuka. Yes, Dr. Manik.
Thank you, sir, and good morning. Again, after the brilliant presentation by Somik, the next problem in a diabetic patient, that the glowing problem is chronic kidney disease. Already diabetes has become a pandemic in our Asian countries, and with the growing numbers of diabetic patients, we are having a growing number of chronic kidney disease. The problem with chronic kidney disease is that CKD is not just a disease, it's a social burden. Because treatment of diabetes may be a drug therapy, but whenever a patient goes to an end-stage renal disease, it needs a significant institutional care, a long-term institutional care, and a significant financial burden to the family, patient, and the society. Just like a heart failure, chronic heart failure, chronic kidney disease is a significant burden already in a society, and all the physicians, all we see a significant increase in the number of chronic kidney disease. So preventing chronic kidney disease, if we have anything, it will be a significant contribution to the management of diabetes. We all know as the disease, the chronic kidney disease progresses, the mortality increases. Or if a diabetic patient without any kidney involvement had a long-term mortality rate have a 4.1% compared to a patient with albuminuria and significant EGFR reduction having a mortality of 47%. And to add on this, if the patient has a add-on cardiac morbidity, then this percentage may increase by 30 or to 50%. So preventing chronic kidney disease, we have another target, that the molecule or whatever the drugs we are using for the management of chronic kidney disease, it should be able to target both the things. It should prevent the kidney disease progression. It should have a cardiac benefit also, because kidneys and heart, we have seen that it has also works in a simultaneous fashion. So if we have to keep the kidneys healthy, we need a healthy heart also. So whatever the research we are going on for the last 10 years, and whatever the publications or whatever the recent advances in chronic kidney disease has, and all have been linked to the cardiac studies also. Already we have the, okay, first is the recommendation for diabetic kidney disease monitoring. We all know the monitoring, initially it was monitored by the serum creatinine level, but nowadays the urine protein or urine protein creatinine ratio or albumin creatinine ratio are growing high. Screening is one utmost important, we all know. But again, after screening, if we are not able to do anything or we are not able to provide anything a patient, then only screening will have no meaning to the patient. Because if we are not able, a patient come to me and I just say, yeah, you have albuminuria. But again, just you have albuminuria, so you are having an increased risk of chronic kidney disease or increased risk of achieving end-stage renal failure. But that doesn't help a patient and doesn't help to a physician. We need to do something with the albumin. And for last, I say 6 to 7 years, initially when we are student, we have the ACE inhibitors or ARB inhibitors, and that was the gold standard for last 25 years or 30 years. For last 25, 30 years, there was no major advancement in respect to the albuminuria for nephrological point of view. In 2017-18, there was a Carmelinas trial that was shown that linagliptin or DPP-4 inhibitors had some beneficial effect on the albuminuria and reduction in the eGFR slope. But that doesn't have any much cardiological or renal point of view. But in 2018-19, when the results of CANVAS trial, CREDENCE trial, and subsequently the DAPA-CKD comes, and that has shown importance of albuminuria protection. I'm not going to the pathophysiology. Till 2013-14, we don't have anything much more. From 2017, the SGLT2 inhibitors come, and then 2021-22, this non-steroidal mineralocorticoid receptors, and then followed by this GLP-1 agonist. And these three has changed the management of diabetic nephropathy in a great way. Initially, it was the single molecule, that was the ACE inhibitor, but again, now it has become a 4-pillar management like the heart failure management, already he had said. So in a cardiac, in a renal point of view, the 4 pillars are now ACE or ARB inhibitor, SGLT2 inhibitors, non-steroidal MRA, and GLP-1 agonist. RAS blockage, all we know from the different studies, that the collaborative study, renal study, IRMA study, identity, all has established that the ACE ARB has a definite role of cardiac and renal protection in a diabetic patient. But sadly, till now, we rarely see 100% coverage of ACE or ARB inhibitors in diabetes with hypertension patients. In most of the patients, they are on calcium channel blockers or other drugs, but we as a physician don't give ACE or ARB inhibitors in 100% patient. I understand there is a fear of increasing creatinine, there is an increased fear of hyperkalemia, but still most of the patients, I don't say most, not nearly 50% of the patients are not touched with ACE and ARB inhibitor till now. Even nephrologists are not able to prescribe in 100% patients. SGLT2 inhibitors, after the publication of CREDENCE and CANVAS trial, the first trial with the canagliflozin, it has shown a sea change in management of diabetic nephropathy. After ACE or ARB inhibitors, these SGLT2 inhibitors are the molecule that has shown a credible the credible evidences of reducing kidney disease progression, albuminuria reduction, and cardiac benefit also. Initially the canagliflozin, followed by the DAPA-CKD, and followed by the recent EMPA kidney trial. Initial trials where the kidney patients are having a, almost normal GFR with the albuminuria. Some patients are having more than 300 to up to 5,000 ACR, they have been included. And with the subsequent studies, EGFR till 25 has been included, and in all of the patients, in almost all of the patients, there have been these SGLT molecules are found to be safe without any significant side effects. And then almost up to the EGFR of 25, it has been found to be safe and effective also in reducing the EGFR reduction and albuminuria reduction. And subsequent studies below 20, EGFR of below 25 are now conducted, and even in the dialysis patient, these SGLT2 inhibitors are now being used for the benefit of the cardiac point. And with the use and huge use of SGLT2 inhibitors, now they have become the statins, like statins of the 21st century. And in almost every patient nowadays of diabetic and having some degree of cardiac or renal morbidity, we are using SGLT2 inhibitors. Maybe these SGLT2 inhibitors may be able to prevent this cardiac and renal morbidity in this kind of patients. So CREDENCE trial, DAPA-CKD and EMPA-Kidney trial, these are the 3 pillar study for SGLT2 inhibitors in kidney patients. And almost all the studies had shown a significant effect on cardiac and renal morbidity and mortalities. But we have to remember, in all the trial patients, every patient was in the AC or ARB inhibitors. So only using SGLT2 inhibitors may not help the patient as shown in the studies if you are not using ACE inhibitors or ARB to the patients. We have to keep in the mind that using only SGLT2 inhibitors may not give the patient that benefit that has been shown in the studies. So KDIGO recommendation, KDIGO is the society for guiding the nephrologist for the treatment of chronic kidney disease patients, and almost they have recommended to treating the patients with type 2 diabetes, CKD with EGFR plus minus 20 with SGLT2 inhibitors, and with the ACR of less than 200. Initially, the SGLT2 inhibitors were used in patients with albuminuria or significant albuminuria, but gradually we are shifting to non-albuminuric patients too, and these SGLT2 inhibitors are now you are using in a non-diabetic albuminuric patients also, and it has shown great kidney preservation effect in non-diabetic patients also. So despite using SGLT2 inhibitors and ACE inhibitors, there is a significant residual risk. There is a reduction in a risk, but there is a significant residual risk we can see in the graph. So we need to address this significant residual risk in the population who are having diabetes with diabetic kidney disease. And then we step into the non-steroidal mineralocorticoid receptor. Mineralocorticoid receptors are not a new molecule. It is used for last 50 years. And it has shown an excellent safety and cardiac protective effect. The molecules like spironolactone and lately the eplerenone has shown a significant cardiac benefit. They have an antihypertensive effect. They have a diuretic effect. But problem in chronic kidney disease patient, when we are talking to a chronic kidney disease patient, the problem is the hyperkalemia. This mineralocorticoid receptor, maybe the sexual side effect was there, gynecomastia, but for nephrological point of view, the important side effect was the hyperkalemia, incidence of hyperkalemia. So we are not optimally using the mineralocorticoid receptors. Some early studies of mineralocorticoid CVOT trials has shown that the mineralocorticoid receptors are effective in a renal protective effect. In a CVOT trial they have shown, but again the side effects were the hyperkalemia. So lately we have a non-steroidal mineralocorticoid receptor like finrenone. The advantage of finrenone is that the significant hyperkalemia is almost nil, and in the most of the studies it is ranging from 1% to 4%. But again, it lacks the diuretic or the antihypertensive action as the MRA. It is not that much of effective as a diuretics or antihypertensive. But the anti-inflammatory effect that was that has given the most cardiac and the renal benefit is preserved with the finrenone. I should say that is higher than the MRA in finrenone group because they have a more more affinity to the mineralocorticoid receptors and very less significant hyperkalemia effect, and it is well tolerated. So it becomes a great molecule for nephrologists along with the SGLT2 inhibitors. And the datas, so we have a great datas. There is a two study, FIDILO-DKD and FIGARO-DKD. FIDILO-DKD is a large trial, nearly 14,000 patients included in both the arms, nearly 6,000 in each arm. Results were promising. Again, all the patients, that 13,000 patients who have received non-steroidal Finrenone have received AC or ARB inhibitors simultaneously. So without AC or ARB inhibitors, the effect of Finrenone is unknown. So again, per se, Finrenone is a great molecule in cardiac and renal benefit, but again, it has to be used with AC or ARB inhibitors. The results of FIDILO study, they had shown the renal benefit, but I want to highlight kidney failure reduction and sustained reduction in 40% was the higher. FIGARO-DKD, it's a mainly cardiac trial which has shown a renal benefit. And if you combine the both FIGARO and FIDILO study, the significant reduction in cardiac and renal, I'm not going detail. This slide is just to showing the NNT number in the last line, the number needed to treat. In Credence trial, the number needed to treat was 22. For FIDILO-DKD, it was 29. And for the DAPA-CKD, it was the 19. So SGLT2 may be the lower NNT number compared to the FIDILO-DKD trial. Now the question comes, if we are able to combine both non-steroidal with the non-steroidal mineralocorticoid receptors with the SGLT2 inhibitors. No large clinical trials are available till now. Confidence trial has been planned. It has been published. That only the planning stage has been published. The results are not out. The works are going on. Finrenone with EMPA, Finrenone alone and EMPA alone, and the results will be interesting to see. And the last molecule is the GLP-1 agonist. Again, GLP-1 agonist is not a new molecule. It is in practice for last 10 to 15 years. Most of the trials that have been done with the GLP-1 agonist are with the cardiac studies, CVOT trials. And again, just like MRA or SGLT2 inhibitors, most of the CVOT trials has showed benefit with the GLP-1, cardiac renal benefit with the GLP-1. And that has led to the largest trial with the GLP for the kidney patient was the FLOW trial. FLOW trial, again, it is a significant, they have taken a significant renal patient that lower GFR till 25.
Please conclude.
Yes, sir. Just 25 eGFR they have taken, and they have taken a significant amount of proteinuric patient, and that has all again shown a great benefit. But it was again to mention that the patients were all 95% patients were AC inhibitors and ARB inhibitors, and that has been done with the semaglutide, that is subcutaneous semaglutide, not with the oral semaglutide. So for a practicing nephrologist, two obstruction, one is the subcutaneous dose. We all know that from the initial period, the patients are very reluctant to do a subcutaneous, and another thing is the price. And another third point is it is not as well as tolerated as SGLT2 or Finrenone. We have seen the GI side effects are significant. But the important thing is the NNT, the number needed to treat with semaglutide in FLOW trial was 20. It is the lowest among all the SGLT2, Finrenone and the GLP-1. So GLP-1 a promising molecule having a significant kidney benefit. And it will be interesting to see how the patients behave with simultaneous use of AC inhibitor, ARB inhibitor, and semaglutide and non-steroidal inhibitors.
Thank you, Manik, for your. Now to summarize the two topics, there is an international study called Network Meta-Analysis, which has studied 18 RCTs of around 51,000 patients, and it has shown that the GLP-1 and the SGL2 Finrenone, among these, the SGL2 is on the top because it has addressed all the composite outcomes like MACE, composite renal outcome, the heart failure, hospitalization, all-cause death, and the cardiovascular death. So SGLT2 is the first, and the other two, the finerenone and the GLP-1, it has addressed only the three composite outcome of the first three, like MACE, renal outcome, and the heart failure hospitalization. And regarding Shomik, he has nicely pointed out the four pillars of the heart failure treatment. The first is ARB or ARNI, second is the beta blocker, third is the mineralocorticosteroid blocker, and fourth is the SGLT2 inhibitor. This should be the take-home message. And another message to all the young. So go on austerity and don't have a non-restrained lifestyle, because then Shomik will put you into all the blockers and inhibitors in future. Thank you. Now the paper is open to question and answer.
Sir, can I come in one thing what you just said, sir? I think what sir said, absolutely. SGLT2, if you look at the network meta-analysis, and even if you look at personally, I think what we are using, SGLT2s would be ranking much higher than, in usage at least, than GLP-1s or finerenone. One of the key reasons why that has been is because of the fact that when Emperor Preserved or DAPA-HF data came out, SGLT2s went beyond the diabetic group. They became significantly opened out for the non-diabetic population as well. Hopefully with the fine arts data that's already available for finerenone and the SOUL data that's available, the top line data is available for GLP-1s right now. Hopefully in the future, GLP-1s and finerenone will go beyond the diabetic group. Once that happens, I think the use will increase exponentially, because even we started using SGLT2 significantly once the non-diabetic population opened up. So I think that's one important area that's remaining for these two drugs.
Yes, Shomik is very much optimistic, because now the GDMT, that means the guideline-directed medical therapy for heart failure, has included SGLT2 in non-diabetic patients.
That's one is absolutely.
Okay, if there is no question and answer. Oh, okay. Yes.
Thank you very much, Dr. Chakraborty. So you have rightly said, Dr. Chaudhary, sorry, that you have rightly said that ticagrelor should be given. But most of our practice with clopidogrel, so far, the things are being changed. So taking a situation, a patient has been seen by a physician, a good physician, and he thought he should go for PCI. And he has given the full dose of ticagrelor, so 180, your loading dose, and on top of your aspirin and statin. And he sent the patient, thought that it would reach within 1 hour to the nearest. But unfortunately, that hospital could not provide. So he has to move 3.5 hours or 4 hours, reach to you. Say, so what is your plan? Would you like to give another dose of 180 or go to 90 ticagrelor?
Sir, if the patient, here I will take two scenarios. The first one I spoke about in my presentation. I would definitely recommend whoever is seeing first, especially if it's slightly in the peripheral regions, where it takes time for the patient to come to the PCI center, to definitely load with clopidogrel first. The upstream, there will be benefits once the antithrombotic. In fact, there are quite a few patients, I'm sure all of you are conversant with the concept of MINOCA. MINOCA stands for a myocardial infarction with non-obstructive coronary arteries. We actually see it quite often in the younger patients. There will be a classic ST elevation, say anteroceptal leads. You do a quick echo before going in, EF's about 45-50% is RWMA. But once we take the shot, everything looks clean inside. So what happened? The initial antiplatelet loading actually improves the clot. Whatever clot, there's a spontaneous recanalization that takes place. So definitely load the patient. By the time the patient reaches us, if it has been loaded with ticagrelor, we are fine with it. If it has not, these days almost always we reload it with ticagrelor. But that does not mean we shouldn't load it with clopidogrel right in the beginning. Because that time period, that 3, 4, 5 hours where the patient takes to come to us, that antithrombotic therapy might be life and death at that point. So yes, load, probably we will reload. That would be the best way to go about it.
Now we are ending the session due to the constraint of time. Now give a big hand to Manik and Shomik.
Thank you, the chair and both the speakers. Now we are into a very interesting and important session where we will be discussing MASLD, formerly known as NAFLD, obstructive sleep apnea, polycystic ovarian disease, and of course the pediatric obesity, which is coming up very thick and fast and is not often discussed in a lot of forums. So may I ask Dr. Binayak Sinha to come up as chair in this particular session. We have a lot of speakers to talk to. So Binayak, take over the chair, please.
Good morning, ladies and gentlemen. Welcome to the EKDGCon. Many of you asked me what is EKDG. EKDG is a group of doctors which got together to form an organization to spread medical knowledge, not only to doctors, but also to spread medical awareness and knowledge amongst physicians, amongst surgeons, amongst gynecologists, and others as well. Now, strangely, it's always been Shomit and me who have been the face of East Kolkata Diabetes Group, but we do actually have strong members of this organization who have kept this organization afloat and made this such a successful podium. Now, let me introduce you to some of the other members of this organization, and let me start by calling up on stage Dr. Sandip Chakraborty, who's obviously doesn't need too much of introduction, but is obviously a very renowned laparoscopic surgeon who is here today. He will be talking about experiences in surgery with obese people as well as bariatric surgery. We also have with us Dr. Sujata Dotto, a well-known gynecologist and obstetrician. She has a specific interest in various aspects of gynecology, particularly robotics. Sujata, welcome. We have Dr. Shomita Ghoshal Singhel, who's also a gynecologist, and she has a professed interest in obesity-associated diseases affecting women, as well as polycystic ovarian syndrome. Welcome, Shomita. And not to forget Dr. Anjana Kaur, a pediatrician who takes an interest in pediatric obesity. Welcome, Anjana. We have left the best for last, I would say, and I would say that Shomit, obviously, please come to the podium. You obviously are the architect of this program. Where is Shomit? Okay, so we'll wait for Shomit to come. And as I said, we've left the best for last, and I will welcome on stage somebody who's not really a member of East Kolkata Diabetes Group, but is an integral part of East Kolkata Diabetes Group family and has always come and helped us out, giving us a wealth of knowledge in his preferred field of respiratory medicine. Sumit Sengupta, please come on stage. We will be discussing various aspects of respiratory medicine and obesity with Dr. Sumit Sengupta. Without wasting any more time, I will go directly to where it all starts off, primordial obesity, pediatrics. Anjana, tell me, how big is the burden of pediatric obesity in our country, and why do you think that is happening?
Pediatric obesity is on the rise in adolescents and in children, and it is a drastic rise, and the main causes are, of course, sedentary lifestyle, food, easy available of, heavily sweetened food, sedentary lifestyle, screen time, very important for children, which is increased by leaps and bounds, and unhealthy eating habits in families, which overall makes a difference, because if the family eats well, the children do better.
The Swiggy and Zomato problem.
Swiggy and Zomato.
And of course, I think one other thing you will agree with me is that, the sport has shifted from the green fields to the blue screens.
That's what I said. The screen time, whatever way it is, has increased so much that it's made lifestyle sedentary for children. They don't do physical activities, regular physical activities. Families don't encourage that. It's not that they don't encourage that, it's not possible. Parents are not always available. There aren't enough fields for the children to run around. Schools don't have that kind of environment at times, so it's difficult.
What can we as a medical body try and do to try and help these children?
We have to increase their physical activity, healthy eating, education for the whole family, and if schools can give them the impetus that you have to eat healthy and the play time is increased. These are the simple things. Of course, it's a multi-pronged approach. You can't do just one thing and expect it to get better.
So I'll move away from you for the moment because I'll move on to the diseases. If somebody can just find Shumit and ask him to come up on stage, please. We will go to you, Shumit. There is a problem with obesity and the diseases it causes. And one of the main diseases that we see in our population is Bhishon Nag Take, snoring. Is that OSA?
No, not at all. You see, the problem is that whether you consider snoring per se as a disease, I don't know, but it can be very difficult for people in a situation. However, it is, let's say, a first step of people getting obstructive sleep apnea, OSA, and that is a major problem. Current estimates, about 1 billion people on earth have OSA. Now, that's not to say all of them should be treated or can be treated. For obese patients, it's probably 50 to 60% of them. If you're talking BMI more than 30, it gets higher and higher as the BMI goes up. Where it becomes a disease, and it's actually become too easy to diagnose OSA. Somebody can do a sleep study. If you just write sleep study, somebody will do it at home and you will look at it. It's absolutely the wrong thing to do, because it's not about the AHI at all. There are sort of levels of things which you need to go. Sleepiness being very easy. You've got sleepy OSA, you've got non-sleepy OSA, you've got insomniac OSAs. So treatment is different for all of them, outcomes are different. Then you have various levels of pathophysiology, where you talk about obviously the anatomical parts, then you have muscle responses, then you have loop gain, it's called, basically brain problems with hyperventilation response, and finally you have arousal threshold. So if you take three phenotypes, if you will, of sleepy, non-sleepy, normal, sleepy, insomnia, and normal, they all have OSA, and you factor in all these pathophysiologies, you have three, 20 different varieties of OSA in various people. And then you come to the comorbidities. So one of the things which very important here is that comorbidities, in essence, determine what happens in the long term to an OSA patient. It's a chicken and egg situation. So there are people without obesity who have OSA, but more importantly, as we've heard all through the morning, cardiovascular risk factors are what make or break the long-term prognosis of OSA. But the one thing I would like to underline is it is not a casual thing. You look at AHI, you ask for a sleep study, I'm not sleeping well, I'm snoring, AHI, start CPAP. That is absolutely the wrong thing to do. It's a separate subspecialty of respiratory medicine, sleep, and if you're interested, anybody can be sent to, should be sent to a person who specializes in sleep medicine. Apart from the very obvious person who's dropping off to sleep and is obese and has got an AHI which is in hundreds, the rest of the people need proper thorough assessment, not just home sleep study just done like that.
Okay, so we'll come to the management and we'll discuss who should be going for CPAP in a minute, but I think we should still focus on the diseases that get caused by obesity. Welcome on stage, Shomit. We also have Dr. Debashish Dotto, who's a very integral part of our organization. He's a hepatologist. Unfortunately, he couldn't be here, but Shomit takes a professed interest in metabolic associated steatohepatitis. So Shomit, How big is MASLD, and do you think it's only attributable to obesity?
I don't think so, because it depends how you are assessing obesity. So, just standing on the weighing scale might be deceiving. We are the thin fat phenotype. So, I think it's extremely important that we should check the waist circumference. If possible, as I'll be showing, we probably need to do the body fat analyzer to find out the visceral adiposity. Very, very easy to do. We see a lot of patients coming with those bunch of reports. LFT is there, but just make use of the platelet count. Any platelet count less than 150, even if your SGOT-PT is normal, rest assured you're dealing with some degree of advanced fibrosis. So I think a fibroscan must be done. FIB score more than 1.3, very easy to do, it's just an app. And the prevalence is pretty alarming. It's more than 53 to 54%.
Do you want to share the kind of data that we generated at IdeaCon 2024 amongst physicians?
Yeah. So there are two data, real life data I want to share with you. One was between Apollo Chennai, Fortis Kolkata, and our center. We pulled the data and we found FIB4 has a very poor sensitivity. It has high specificity, but very poor sensitivity in detecting. So if I just look at a FIB4, I'll miss a lot of early in FLD and mainly steatohepatitis. I think it's time that if you really find someone who is obese, and now in female, if the SGPT is more than 19, in male, if it is more than 23, you're supposed to go ahead with the assessment of, rather the area guideline says every single type 2 diabetic patient must undergo an assessment for an FLD. It's a call because we are asked that more than 1.3, then you go for a fibroscan. I see a larger requirement of fibroscan.
But then fibroscan is quite an expensive tool, isn't it?
So I'll come back to what Sumita was saying. Not only expensive, is operator dependent. The results can be, go haywire depending on who's operating and which probe they're using. I would like to focus more on the CAP score than on the LSM value. A CAP score more than 238 has significant steatosis. Start treating them aggressively before they go into a LSM more than 8 kilopascal. I think we have to deal more with the CAP score. I see a lot of patients marginally elevated SGOT-PT. You see a FIB score less than 8, and we have a tendency to say, oh, you're fine, go home. No. If you look at the CAP score, they have not yet developed fibrosis. This is the ideal candidate that you have to catch. They have significant steatohepatitis.
So catch them young.
Yes.
Catch them young. That's the point. So we'll move from the medical side of things to the surgical side of things. We have Dr. Shondeep Chakraborty here with us. So Shondeep, tell us, what are the challenges of treating a surgical patient who has obesity?
The first thing, I'm sorry. Yeah. The first problem we face in our clinical practice is to motivate somebody who is 140 kilograms with a height of 5 feet 4 inches to actually motivate the people the option of bariatric surgery.
So Shondeep, I'll stop you for a second. I just want to know, how difficult is it to operate on just an obese patient? You're not doing bariatric surgery, a simple, say, lap chole.
Yeah, there is technical difficulties to access, like the first access. We normally we go subumbilical or the supraumbilical, but it is very difficult to get into the peritoneal cavity with the varus needle. Even the open technique is very difficult, very tedious. So we normally go for the obese patient on the Palmer's point, that is the left hypochondrium about 2 centimeters below the costal arch at mid-clavicular line. So that is the safest thing. And there the fat content is less. So that's how we access. The first access is most important.
Okay.
Without injuring any viscera.
Yeah, so that was my first question to you, because my next question I'll go to Sujata. Because Sujata, tell me, you have a pregnant woman who's really obese, really 140 kilos. How do you deliver, whether it by cesarean section or by normal delivery? I don't know. What do gynecologists do? What do obstetricians do?
Yeah, we are obviously daunted when we are presented with somebody with that sort of weight. And as Shondeep said, there are lots of technical problems. When we have an obese woman coming to us already pregnant, we can't do anything about the weight because pregnancy is not a time when you can use weight losing medication, because a moderate weight gain, even in obese patients, is required for good fetal outcome and for pregnancy to progress. So whatever needs to be done about the weight has to have happened a long time before they get pregnant. And the counseling is important, medication, newer medications, innovation, whatever it is, has to be done before. And if the newer molecules like semaglutide, etc., have to be used, they have to stop at least 2 months prior to the patient getting pregnant, because we don't know what fetal exposure to these newer medication would do. Having said that, once you get a pregnant lady who's already come to you with a baby in her tummy, you have to have specialized equipment in order to be able to assess them properly. So you need the wide bore cuff to measure their blood pressure, because we know that these patients have a much higher incidence of pregnancy-induced hypertension, of preeclampsia, which can then affect the growth of the baby. You can get intrauterine growth restriction. You have to do, you have to do a glucose tolerance test to check for diabetes, which can make the baby macrosomic. So to assess the baby's well-being, you need a very skilled operator who will be doing ultrasounds. Because of the patient habitus and the layers of fat that the ultrasound waves have to go through, often congenital abnormalities, which are very common in obese patients, can be missed. The results that we get for Down syndrome screening, it's called NIPT, where cell-free fetal fraction can be measured from the mother's blood to see if the baby's got Down syndrome. The results of that can be erroneous as well. So we have a multitude of problems in monitoring them, in diagnosing problems, and of course, once you've got through the pregnancy, then delivery is also a challenge, because we know that pregnant patients who are obese have dysfunctional labor, and they have a higher incidence of cesarean section. But if you have to do a cesarean section, you need a special table to be able to accommodate that 140 kilos. You need good, strong operators who will be able to dive through the fat and get to the baby and get it out. These patients have a higher incidence of surgical site infection, often diabetic, higher incidence of postpartum hemorrhage, of clots in the leg and lung, DVT. So you must give them prophylaxis with a DVT pump and Clexane as applicable. So these are, in short, all of the problems that we face when patients come in obese patients come in pregnant.
Right, so we'll move directly from the obese patient coming in who's pregnant. Shomita, you deal with a lot of obese patients who come in, who you treat to try and get them to lose weight and then tell them to get pregnant. What is your preferred drug?
So I would start from Dr. Kaur. What she said, that these days the children are getting obese because of lifestyle. So these children, they become adult girls and then gradually passing through the adolescence. During that period also, they are not conscious about their lifestyle. They ultimately come up to us with polycystic ovaries with obesity. So the challenge for us with the polycystic ovary patient, we know, is that they will have menstrual irregularities, they will have facial hair, they will have difficulty in conceiving. So as for menstrual irregularities and hair growth are concerned, we can manage with, say, our progesterones, we can manage with our laser techniques, all the beautiful skin clinics coming up. So that is fine. The next problem which comes is that these polycystic patients gradually keep gaining weight and then they land up with subfertility. They find it difficult to conceive because their eggs are not responding to the normal ovulation inductions, probably because of a baseline insulin resistance. Now, how do we manage the baseline insulin resistance? The first and the foremost treatment for a baseline insulin resistance would always be a lifestyle modification where we would expect them to lose at least 5 kgs from their present weight and even taking care of the diet they are on. But unfortunately, most of my patients, they find it difficult to lose that 5 kgs also. And they do tell us that they are doing all the best they can. Then the role of medication comes in for us. But again, the lifestyle modification is the foremost thing, and that has to continue whatever medication we come up with. So the first thing which came up with us was the metformin, which did give us promising results in taking care of the insulin resistance, but weight loss, not to that an extent. But yes, we were getting good response to the people who are not responding to ovulation induction after adding metformin to their regime.
So I'll just stop you there for a second, Shumita. So I think the message out here as far as metformin is concerned, it's not for everybody. It is only for people who are failing on ovulation induction. It is in them that you start on metformin. And
Not exactly, Binayakda. We are actually using metformin for some patients who are obese and polycystic and who still don't have regular cycles.
Right.
I do give them metformin and
Okay.
I do see good results in them also.
okay.
But then the problem with metformin remains the same, the acidity problem. But somehow it's a dose-dependent side effect, and when patients continue taking, it sorts out. Now we are looking for this new molecule, the GLP-1 agonist, that's the semaglutide. With semaglutide coming in the market, the first thing which we thought that should we use it for the polycystic ovaries. So the question is that we do not have the guidelines or the authority from the medical drugs that we can use it for polycystic, but as an off-label drug, we may try to use semaglutide. Now the catch questions over here are, now if a patient on metformin conceives, then actually it's not a problem because we know it doesn't have any teratogenic effect and it can be continued during pregnancy. But for semaglutide, we don't have that record. So if a patient conceives happily with my semaglutide, she loses weight, things looks perfectly good, she conceives, but yes, that question in my mind, whether it has had any teratogenic effect, we don't have an answer to it. We would definitely stop it the moment she conceives. As of now, we do not have enough data to convince that we should continue this. We are still at the thing, but as an offline medication, I think we should think considering this medication for patients who are finding it difficult to lose weight and also to conceive. That is what I would say, because GLP-1 looks like a very promising drug in helping us to reduce insulin resistance and also a good weight loss.
So I think that's perfect, and it's a very perfect summary of the usage of semaglutide. I would suggest you read a paper by Ghoshal et al., which has been published quite recently on the usage of GLP-1 receptor in PCOS. So, but just one little thing, the guidelines which are coming out now, Monash University has come up with this guideline. I'm sure all of you have seen it. This PCOS guideline is now starting to say you can use semaglutide in management of obesity in PCOS. So it's the first time that it's being mentioned in the guidelines. This is the Australian guidelines, which is being taken up by the Europeans as well.
Yeah, I wanted to reiterate the use in people, in obese girls who can potentially fall pregnant if they're sexually active. The recommendation is that they use contraception as well at the same time.
Right, right.
And so finish off the semaglutide or these newer molecules, continue to use contraception for further 2 months before you get pregnant. Because of the risks, we don't know whether it's teratogenic or not. If it so happens that people are careless and they do get pregnant, then there's a special register where you're supposed to inform them so they can follow up these pregnancies to see what the outcome is in such patients.
Right. Anjana, I'll come to you because we're talking of drugs now. What about drugs in the pediatric population?
Only thing is semaglutide, 2.4 milligrams once weekly, approved by FDA, not available in India at the moment. Hopefully by this sometime towards the middle of the year, a few months down the line, we should get something. And then maybe
but that's for teenagers, not
that's for 12 years and above.
12 years and above. So we have hope for the children as well coming up with, I think we're seeing quite a bit of pediatric obesity. I don't know, Shrutinatha, do you manage pediatric obesity or not? You do. So I think a lot of people who are managing pediatric obesity are seeing a complete outburst of obesity.
But you also have to think of other things along with it. It's not just the drug. Some amount of lifestyle intervention is required, not just the drug.
Sure. I think lifestyle followed by medications is coming into play. So we'll move away from the surgeons and the pediatricians for a bit and come to Shumita. So somebody has come, you're assessing them for OSA. Now, who gets a CPAP machine?
If the patient is sleepy during the daytime, they get CPAP. Now, as a rule, nowadays I at least give a month to 2 months of trial on higher. That's easily done, doable. The reason is that some people do not tolerate it, and you buy a 65,000 rupees machine and then ultimately it's the doorstop. But if you are sleepy, the people who respond, it's magical. Their life is changed. Their daytime concentration, their activities, their general demeanor is changed, and they come and tell me, I will never go without the CPAP anywhere. Okay. The problem is with the less sleepy patients, where as we discussed, the endotypes are totally different. There is non-sleepy but normal patient, and there's the insomnia patient. So here we give a trial of CPAP. If they get better, fine. If they don't, we start trying, fiddling with various things which might help. These are not FDA approved, let's put it that way, but there is evidence that certain subgroups will respond to certain treatments. One of the things, this loop gain thing, the brain thing, acetazolamide, very simple treatment, and it's recommended in obesity hypoventilation, but it can also work in OSA. There are ways of trying to measure it. They are very complex and expensive, but trial of therapy sometimes work. It's very innocuous and it's very cheap. There is evidence for very specific non-benzodiazepine sedatives in the insomnia patients, where the arousal threshold is thing. So it's a complex thing, but I would not get them to buy a machine until they are happy, I am happy, and then instead go buy them. If they are not happy with the CPAP, then we start thinking other things, and we try various things, maybe get a level 1 PSG in a lab and see what's going on really. And sometimes it's very difficult to make out because patients' perception of their problem and usually the spouse's perception of their problem is like hugely different. So we don't know what. So we sometimes have to do objective testing with MSLTs to see actually how sleepy is the patient during the daytime. So, but these are expensive tests. The first thing we do, significant OSA, we treat. Now, when I say significant OSA, without sleepiness, 5 to 15 is not an indication for treatment unless there is specific other things. 5 to 15 moderate OSA, there is good evidence. If you're not symptomatic, it does not alter cardiovascular outcomes. Absolutely written in stone.
I thought
now.
there was some evidence that it worsens cardiovascular outcomes.
Well, yeah, there is one subgroup of patients. Well, it's very interesting as you put it. Whatever doesn't kill you makes you stronger. So in a ST elevation MI trial, they checked for OSA and they put people on CPAP. Now patients who had OSA had a better outcome than patients who didn't have OSA. Unbelievable. It's called ischemic preconditioning. Well, that's a theory anyway. So, and their brains and their hearts are used to hypoxia, that's why. But that's not a reason for not treating OSA, but it's certainly something, it's very complex. And certainly some patients will actually have increased arousals if the pathophysiology is not just anatomical, then it is. And it's a complex thing. Some of the treatments, even apart from CPAP, when they work like magic. So one needs to go through with, but the first thing is sleepy, severe OSA, higher CPAP, doing well, buy it. Very simple. That much is clear. Now, sleepy, severe, non-sleepy, severe OSA, definitely CPAP trial has to be given. Moderate, you can do lifestyle and then wait for a bit and repeat the sleep study in 6 months or 1 year. So the thing that, you must treat all OSA with a CPAP, that's nonsense. Absolute nonsense, proven beyond doubt. And in fact, in America, insurance will not cover you unless you've got severe OSA or severe sleep disturbance. Individually, which bit of what pathophysiology is causing your OSA, that needs to be teased out, and there are certain tablets or pharmacological treatments we can sort out, and some patients do have a fantastic response to those treatments, but they are very, very selective. It's not to be used generically like that.
Right. So we'll move on to, but the mainstay of treatment, as everybody seems to be coming out, is that we need to lose weight. And I think Shomit showed a very interesting slide of how much you gain reducing hyperglycemia, hypertension, how you reduce coronary artery disease, how you reduce NAFLD. And I think since we've got a little bit of a focus on NAFLD, I think we will bring Shondip Da into the picture. See, Shondip Da, today the only treatment without GLP-1 receptor agonist, the only treatment that we have in this part of the world at this point of time is actually oral semaglutide. Injection tirzepatide has just come in, so we're still testing the waters. The only treatment which can cause a more than 15% body weight loss is bariatric surgery. What are the challenges you face getting patients to have bariatric surgery?
I'm the very odd person out here at the August gathering. As I must emphasize, bariatric surgery has gone the incidence of bariatric surgery has gone up worldwide. Even in India, it has gone up. And the reason, you have to understand, what does the bariatric surgery do? If you look at the GLP-1 axis and the glycemic control, the basic concept is the more distal you deliver the nutrients, it more increases the GLP-1 level. It has been categorically, several papers, a lot of research studies gone. So the basic thing is the distal, more distal, you have to get the nutrients so that there is increased GLP-1 and that increases the insulin secretion and that the glycemic control, if I'm not wrong.
Right.
Yeah. So the major challenge is here, the guidelines say in the Western countries is if it is BMI more than 40, you go ahead with the surgery. Even the insurance covers that. And if the BMI is above 35 with the metabolic syndromes like OSA, hypertension, and diabetes, you go for bariatric surgery. In India, it is slightly modified. It's 5 units if you have to go down, like, if it is 35 and 30. So this is very important. As you know, the India, I don't know whether still it's a capital of diabetic disease in our country, and the numbers are overwhelming. So I don't know how to convince people for bariatric surgery. As you can know, I have got quite a few patients who are off anti-diabetic, off antihypertensive, and completely got rid of OSA. 140 kilos in 2 years, now he is 72. So he's still under my follow-up. So there are quite a few patients, they're off medicines. So that has to be emphasized. I think this is very important point. I have to give the awareness what bariatric surgery can achieve. I think that's my message.
I think that that's a very important message that you give, that bariatric surgery still remains a part of our armamentarium, and it's a very good treatment modality in spite of what we have today. But I'll come to you, Shomit. Our focus, you are...
Can I just
sure.
take off on a point on that? So it's very interesting what he said. As regards OSA after bariatric surgery.
If you're going to have a war, I'll set...
No, it's not a war. It's not a war at all. I absolutely agree with Shundipda. So the interesting thing is what I was saying is that obesity effectively, it decreases the space. So it's an anatomical problem causing OSA. Now, with bariatric surgery, the people who respond by 15%, 20%, you would expect if it was a unimodal disease, that every patient with OSA would recover, have no OSA after bariatric surgery. It doesn't happen. About 60% no OSA, 20% no change, 30% improve, but
not.
Yeah. So the OSA bit of it, it is not just obesity. That's what I was trying to say. It's got multiple things going on, even in the obese patient.
Yeah.
So you need to figure out what's happening before jumping in.
Sure.
Sorry, I just jumped in there.
Shomit, you are supposed to be filling in for Dr. Debashish Dotto today, so we focus on MASLD. So tell us, as of now, the evidence with the anti-diabetic drugs that we have, SGLT2 inhibitors, GLP, dual agonists, and triple agonists. Triple agonists still not licensed for use anywhere in the world. How would you grade these 4 drugs in MASLD?
Okay, so I think we might have a MASLD in a non-diabetic patient.
No, I'm talking about diabetes.
Just diabetes. So in diabetes, we have to segregate into 2 halves. So you have type 2 diabetes, diagnosed MASLD. So one is we have anti-diabetic agents which can help in reducing the stage of MASLD, but mostly they have to be between F0 to F3. If you go to F3 and F4, most of these drugs do not have much benefit. So these are diabetic drugs with additional benefit. So there you can use SGLT2, but the data is quite weak from the biopsy studies. Pioglitazone has good data, followed by we have the GLP-1, and now tirzepatide has very good data. And directly from the liver perspective is resmetirom. It's the only drug which is approved for the treatment of fibrosis. I don't think it's available in India as of now.
They're coming in, I think, Shodhina, they're coming.
They're coming soon, it's not there. So it's basically weight loss through whichever mechanism. GLP-1 and the latest tirzepatide, I think, are excellent agents. GLP-1, you have to remember, we yet to get the 3 milligrams liraglutide, but I am hearing the approval will be quite soon. So we'll have our biosimilar GLP-1 which with 3 milligrams. Lira has very good data. Lean study, we have excellent data.
That's even with 1.8.
Yes, semaglutide, Rybelsus is excellent. Semaglutide, we have excellent data. I think it's New Strong is the person who did that and have fantastic data. Tirzepatide has also good data. So we have molecules, entire range from cheap to expensive, and entire range of weight loss that you can look at. But that's the main thing. Weight loss has to be there, and 7% weight loss from baseline is now the ADA recommendation that you have to achieve.
Right. So to 7% weight loss, we'll take one comment from each one of the panelists, and then we'll end the session. Anjana, your last word on obesity in children.
Please increase physical activity, reduce sugary food, and reduce screen time. That should start it off. It should give a kickstart.
And to the adolescent girl?
Yeah, I think there should be more awareness to everyone that weight gain is a problem all throughout the life, and it should be controlled in whatever way they can, right from the beginning, right from the scratch.
Okay. Sujata, somebody planning to get pregnant?
A 5 to 10% weight loss prior to pregnancy will optimize all the pregnancy outcomes as well as help them to get pregnant, because it removes anovulatory infertility by improving ovulation.
Shondipda, everybody for bariatric surgery?
Well, you have to be very selective, because, I never prescribe bariatric surgery to a patient who is non-motivating, who is not going to change his or her lifestyle.
Motivation.
So that's very important. I normally ask my patients who has come for the bariatric surgery that you please stay on the liquid diet for 1 month and come back to me. Liquid diet, yes, that works, because that softens the liver. Because when we operate obese of BMI of 40, you can imagine what's his liver condition. We usually ask, normally that's my protocol, I ask to take low-fat milk whenever he or she is hungry, all day. And believe me, somebody has turned out to be lost 10 kilos, from 140 to become 130. Then she's motivated to have the surgery. And she had it. And she's off medicines.
That piece of advice would convince most people to come in for bariatric surgery.
No, not really. But you have to understand the mechanism.
Sure.
You can be off anti-diabetic, you can be off antihypertensive, it can be off CPAP.
Absolutely.
I've got examples, quite a few.
Sure.
Thank you.
Okay, so Shobit.
First, I'll leave.
Yeah, sure. Shobit, your last word on obesity.
Very, very easy way to assess for visceral fat, do a FIB4 and a fibroscan. Because the gold standard is DEXA or MRI, which is not a standard of care, but let us not forget to do a simple FIB score and a stop bang, I'll say. 2 ways of finding out the visceral adiposity. I'll go with Anjana. I have a paper with my colleagues from Saudi Arabia and UAE on screen time. It is there, the least looked upon paper. No one thinks it's important. It's extremely important to reduce screen time, to reduce metabolic syndrome.
Okay. Shumita, your last word.
1 billion people have OSA. It's easily treatable to a large extent. However, apart from the very barn door patients, they should be looked at by a specialist. Do not treat numbers. Thank you.
Thank you everybody for being here. I think we've had a wonderful panel on various aspects of obesity, various aspects of surgical obesity, pregnancy, respiratory medicine, MSLD. Thank you to the panelists. Thank you East Kolkata Diabetes Group. And most importantly, ladies and gentlemen, thank you very much. Thank you for being such a wonderful opera audience. Thank you. Yeah.
Actually, patients with antipsychotic drugs, they are often overweight and not motivated. What is the suggestion about bariatric surgery in those patients?
Antipsychotics.
Antipsychotics. Well, yes, they need more counseling because, you know, if you don't change your lifestyle, somebody who has got an addiction for the soft drinks and alcohol, you have to change your lifestyle. You can't have a bariatric surgery and, you know, have thumbs up or Coke, you know, you can't because you will have dumping. You will have a lot of problems, you know, if you take those sugary drinks after bariatric surgery. So you have to change your lifestyle. And antipsychotics, yes, you can have, yeah.
So we'll end this session out here with an announcement. All those of you who have registered for the Medical Legal Ethics Workshop, that is starting now. You can make your way there if you are registered for it. It is only open to registrants. So thank you very much again and have a very nice day. Enjoy the conference.
Medical Ethics Workshop is going on the Harmony 1, just beside the reception. There is a lift, M floor, Harmony 1. So there are a couple of registration are left. So if anyone over here, please attend over there. It is already started.
So we have been having a very exciting and comprehensive kind of part of the seminar this long. Now we will be talking on SOUL trial. This has been in the air for pretty long time, and as far as the recently, you know, SOUL has been come up in the ACC maybe a month back or so. And after the Pioneer and Sustain, this is the first superiority trial. And we were all looking at it, how does it impact on type 2 diabetes management. We have none other than Dr. Sotinath Mukherjee to take to the chair, and he will introduce the speaker also.
Good morning. So Dr. Binaksina doesn't need any introduction to this audience. Without wasting any further time, let's listen to Dr. Sinha on his interpretation of the SOUL study and its clinical implications. Over to you, Binak.
Thank you, Shutinat. May I take your permission to just announce that there are a couple of slots available for the medical legal workshop. So if any one or two of you want to proceed to Harmony Hall, you can go to the Harmony Hall for the medical legal workshop, while the rest of you can listen to me speaking about the SOUL of type 2 diabetes management. This is my disclosure slide. So we know that diabetes is something that happens with a multitude of other diseases accompanying it. The metabolic factors like type 2 diabetes and obesity are associated with dyslipidemia and hypertension, and all these conspire to lead to chronic kidney disease, heart disease, liver disease, as well as retina disease and peripheral vascular disease. So indeed, the treatment algorithm should include reduction of blood glucose, controlling of blood pressure, controlling of lipids, reduction of body weight, as well as monitoring for renal health and reduction of cardiovascular events. So we are looking here at semaglutide and trying to see what semaglutide does to a variety of things that happen inside the body of a diabetes, including the heart and the kidney. And the basis of this is the publication of the SOUL trial. I'm sure all of you know about the SOUL trial, but let me just reiterate the SOUL trial for you. So this is on the CKM initiator, so metabolic dysfunction, which is glycemia and body weight. So the trials with semaglutide have taken place in multiple trials, the pioneer trials, 19 clinical pharmacology trial, 1 phase 2 trial, 12 phase 3 trial, and 1 phase 3B trial, which has exposed about 7,000 patients to semaglutide, and 7 out of 10 of these patients achieved a HbA1c of less than 7%. So if you look at this, the maximum amount of HbA1c reduction that has been attained by oral semaglutide when you compare it to competitors is about 1.5%. Its nearest competitor is another GLP-1 receptor analog, which reached a HbA1c reduction of 0.9%. Associate that with a 5 kilogram weight loss compared to its most active competitor, which is dulaglutide, of 3.5 milligrams, whereas semaglutide oral managed to reach 5 milligram. What is interesting to note is in people who were just naive to any other medications, and just if you compare semaglutide to placebo, in people who were just taking semaglutide and had a high HbA1c, you attained a HbA1c reduction of almost 3% when you used it versus placebo. And this is in people who were naive to any other medications and had an HbA1c of more than 9%. So this is massive HbA1c reduction, something that you can see only with insulin. But insulin causes weight gain. This causes a weight reduction of up to 5 kilograms on average. Now, what about kidney disease? What does semaglutide do to the kidneys? There is a lot of mechanisms by which it improves renal hemodynamics. It can improve anti-albuminuria. And if you look at the retrospective study in obese diabetic patients, there was a definite improvement of eGFR in patients who took semaglutide and a reduction of urine ACR of about 50% in people who were on semaglutide. This is, of course, a retrospective study. This has been seen in all the subgroup analysis of all the GLP-1 receptor studies that they do improve eGFR and they do improve urine ACR, but this is a retrospective study with semaglutide. Now, what about CVD events? And this is basically the focus of our talk today, and we are going to be talking about the SOUL trial, which was conducted to prove CV benefit with oral semaglutide in type 2 diabetes. It was a randomized, double-blinded, parallel group, placebo-controlled trial, and they had about 10,000 patients, of whom 800 were from India, who were exposed to the treatment till the endpoints were met, and they were followed up thereafter also for 5 weeks. So this is 5 years and 2 months. And the primary objective was to demonstrate that oral semaglutide lowers the 3-point MACE versus placebo. Interesting key inclusion criteria: people more than 50 years of age with diabetes who had good to bad control, but they all had one thing. They had established CVD in the form of coronary artery disease, cerebrovascular disease, peripheral vascular disease, or chronic kidney disease. But if they had had a MI, stroke, or hospitalization within the last 2 months, they were excluded. Naturally, they were unstable. And if they were about to have a procedure, they were excluded. And if they'd had some GLP-1 earlier, it would definitely become a bias. Therefore, they were excluded as well. And people with grade 4 heart failure were taken off the list. So this is the baseline characteristics: 71% males and 30% females, age of 66 years, elderly group. So 8% HbA1c was mean. Obese people with diabetes, which was quite long duration, 15 years of diabetes. Interestingly, you find a heavy representation from Asia. You find about a quarter of the patients who were there from Asia. And a large number of these people had hypertension, which you will know is a very high risk for developing heart disease. Also, you see that largely they had established heart disease or strokes or heart failure or peripheral vascular disease. And interestingly, 4 out of 10 of these patients that were there had chronic kidney disease which was established, and indeed about 3% had very severe kidney disease. But also you will notice that about a quarter of them had moderate to severe kidney impairment, which was basically, a eGFR of less than 30. They were on, what is interesting again here is large number of them were on RAS blockades and lipid lowering drugs. So they were on standard of care. They were having treatment which was already recommended, so they were not on suboptimal treatment. Interestingly, small number of people now you see are on sulfonylureas and DPP-4 inhibitors. This has fallen out of favor in the Western world completely. And you see increasing usage of SGLT2 inhibitors. This is the first trial which is done on top of a pre-existing SGLT2 inhibitor therapy. Roughly about a quarter of the patients were on SGLT2 inhibitors. And the results were pretty dramatic. Within about the first 6 months, you find that oral semaglutide starts to reduce the risk of MACE. MACE, as you know, is CV-related death, non-fatal MI, and non-fatal stroke. And this graph continues to separate over a 54-week period, which leads to a 14% reduction of MACE, which is statistically highly significant, with far less events in the semaglutide arm and than compared to placebo. The number needed to treat to prevent any of these events from taking place is 50. So if you treat 50 patients, one of them will actually have less chance of a stroke, MI, or even death. Interestingly, I thought I would add this as a tidbit, and please don't think that I'm trying to blow our own trumpet. So this is something that we had published 1 year down the line, 1 year ago. And we had looked at previous studies of GLP-1 receptor analogs, and we had predicted that this study will be terminated early at about 3.7 years. It was terminated at 3.8 years. Our study looks at, I think we said that we would terminate at 3.78 years. The study got terminated at 3.8 years. And we had predicted a significant reduction in MACE. It came down to 14% in the actual study, whereas our prediction had said it would be a 17% reduction of MACE. So I think mathematical models in the future might provide a more accurate and cost-effective blueprint for conducting future cardiovascular outcome trials. And I think this is the first time we have managed to show it in a mathematical model. So all these things came down. 26% of non-fatal MI was the main driving force. As you can see, the MI is statistically significant, but all the other things, including CV death and non-fatal stroke, were on the right side. This was consistent in all subgroups, whether you look at age, sex, eGFR, or HbA1c. What is interesting, in people who had a high HbA1c, they benefited more, and also people from Asia, which includes Western Asia, Eastern Asia, and every other place, also showed a degree of greater improvement. And also the secondary outcomes, which included CV-related death, kidney disease, and other things like GFR and chronic kidney replacement, these things were also reduced, though this did not reach statistical significance. The semaglutide improvement appears to reduce risk of MACE regardless of baseline SGLT2 inhibitor use, and this is to the tune of 11%. And again, if you look at people who were on no baseline SGLT2, this is 16%, so you can make out that there's no difference. The safety profile was similar to other GLP-1 receptor analog trials. You can see that there is lesser number of events of GI disorders in placebo arm, but more GI events in the arm which use semaglutide. There was no difference in infections or cardiac disorders, and any kind of adverse events leading to discontinuation were more common with semaglutide, as you can expect, because these drugs do cause a lot of GI symptoms. To summarize, therefore, we can now say from the results of the SOUL trial, we now have an oral GLP-1 receptor analog, and we can safely say that oral semaglutide, we all know, is a powerful glucose-lowering agent with an effect on body weight reduction, CV risk factor reduction, pleiotropic benefits, and reduces the risk of hypoglycemia. Thank you very much for listening to me.
Thank you, Binak. You finished in half the time allotted to you. Thank you once again. So the talk is now open for questions and comments. Eye problems associated with semaglutide.
So I think, first of all, let me just reiterate that Novo Nordisk is actually doing a study called the FOCUS. And I think they have now stopped recruiting to look at any kind of eye problems with semaglutide. So we will know the results of that very soon. There is an increased, there has been reports of an increased optic neuropathy. It's called NION in some studies. These are all not randomized controlled trials, but studies of databases which seem to indicate that there is an increased risk of NION. Now, the point I'd like to make is NION is a very, 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 very rare disease. And whether you can attribute this development of NION just to semaglutide or just diabetes itself is very difficult to say, and only I think a randomized controlled trial will tell us what the result is. As of now, no signal to worry about. I think all of us in this room have been using a lot of semaglutide. Have you had any problems with the eyes? Shotinath, you?
No, not NION.
You've seen worsening of retinopathy.
Yeah.
But
that I have.
That's, you can't say whether it was the drug or whether it was the disease.
Absolutely. Maybe the effect of rapid glycemic control.
Yeah.
So that's also under follow-up, those patients. So it's better to have a retina opinion before you start your patient on any of these agents.
Yeah, absolutely. I would agree with you on that.
Yeah. So any other question?
What is NION? It's ON is optic neuropathy. It's
non-ischemic.
Non-ischemic optic.
This is
non-arteritic ischemic optic.
Non-arteritic ischemic.
Nirmalodda.
Our knowledge from soul and also flow, do you think the differential perspective of SGLT2 and GLP-1 as far as kidney diseases is concerned is getting closer?
I think so, yes. I think, given the choice, I think for the first time we are starting to see that there is benefit. In fact, if you just take a step back, and if I may be permitted, if you look at the 2.4 milligram of semaglutide data, the heart failure data is impressive. The treatment is on top of SGLT2 inhibitors, and there is still benefit in heart failure reduction. So I think the space that was created for SGLT2 inhibitors is shrinking to the point that I think GLP will overtake them. But then there's the problem with cost.
And if I may add, as far as the renal outcomes are concerned, if you add a GLP-1 on top of an SGLT2,
right.
The interesting point to look out for would be whether the initial dip in eGFR that you see on addition of SGLT2 is mitigated with a concomitant use of GLP-1 receptor agonist, which is not yet known.
Yeah, very interesting thought. Very interesting thought.
Okay, so if there are no more questions, can I have a couple for you? Simple things. Firstly, patients on DPP-4 inhibitors in the SOUL study, were they taken off?
Yes, they were taken off.
The second is, what was the discontinuation rate?
I can't remember, but it was a pretty high discontinuation rate, and I think you're bringing that. I think 23%, if I am not mistaken, 23%.
And finally, the data you present, are they efficacy estimates or treatment estimates?
These are treatment estimates.
Okay, so per protocol analysis data.
Yes.
Okay. Thank you. I have no further questions. Thank you for the
so
presentation
much,
once again.
Thank you.
Over to the organizers. Or I'll be speaking, I don't know. I'll be speaking. I think.
So the soul has been taken care of, and I think along with that, time has also been taken care of. The missing link has been taken care of. Now we are in a very interesting topic. Dr. Dibyendu Bhattacharya. Yeah, sir. Please take the chair. And we have two eminent speakers here. I think the speakers will be introduced and then the subjects as well.
Good.
So thank you, EKDG committee and organizers for providing me the opportunity to session the two very important sessions of this conference with two very elegant speakers. I think speakers did not to give any introduction. Professor Shatinath is the master of the masters, and next is Shomit Ghoshal. A very important topic, obesity. Obesity definition, obesity category in the new guideline has been changed, and that we will hear from Professor Shatinath. After that, our second speaker, Dr. Shomit Ghoshal. So, Dr. Shatinath, please, without any further delay.
Thank you for the kind words. Is Samit around? Oh. I thought otherwise I may have to cover your talk as well. Okay, so, and the topic is interesting. Are we all obese? As per the latest Indian obesity consensus document, anyone with a BMI more than 23 should be defined as obese without there being a category called overweight. Is there anyone in this audience with a BMI of less than 23? I don't see anyone. Dr. Mondol may be the only one, yes. And I presumed so. So if we take 23 as the cutoff to define obesity, so 100% of us. He's an outlier. Dr. Mondol is an outlier. So we are all obese. That's the thing I'm going to walk you through over the next 15 minutes or so. The only person in this meeting I know of who has been maintaining a BMI below 19 is, with his permission, I've taken his permission, he is Smito Broto of USV. His current BMI is 18.9, and when he passed out from South Point School, it was 18.5. So just on the borderline of being defined as a lean individual. Right? Now the problem is, why do you need such consensus guidelines? You need consensus for issues where you don't really have a strong evidence base. No RCT, no systematic review, and you want to come up with a treatment guideline, so you fall back upon something which is called a Delphi consensus. In a moment I will take you to what a Delphi consensus is, but here are the problems. Obesity is still defined by bigness. One who looks obese or looks fat is fat, right? So if that is the concept, so that's a morphometric concept. It doesn't tell you anything about the underlying pathophysiology. The second thing is, if you categorize obesity based on scoring systems, you don't really define it as a disease. Unlike your hypothyroidism or Cushing's syndrome, that's a disease. You go to the doctor, you have a diagnosis, and you get treated. You go to your physician with a diagnosis of obesity. So what's the implication? If the physician writes obesity as a diagnosis on the prescription, or for that matter, metabolic syndrome as a diagnosis, in the US of A, the medications will not be reimbursed by the insurers. So they are not recognized as a syndrome. So the crux is, you have to identify people with obesity, regardless of BMI, who have significant organ dysfunction and might benefit from treatment. So the whole idea is to identify those people. Now BMI, if you take the Western cutoff, would miss many Indian patients with pathological or metabolically unhealthy obesity, and that's why the idea is to bring the BMI cut points lower to catch those people. If you have access to other anthropometric parameters like your waist circumference, waist to hip ratio, or waist to height ratio, or even better, a body composition analysis, then you can reliably identify people with pathologically, metabolically unhealthy obesity. But in clinical practice, that's a challenge. So BMI is easily done. So everybody calculates the BMI. So we want to see if by lowering the cutoff BMI, you can catch those people with metabolically unhealthy obesity. So this I have alluded to already. So if you have a diagnosis of obesity, your prescription is not covered by insurance. So you have to have something else. Obesity with comorbidity, obesity plus. Now this is notionally a wrong concept. Somebody is having metabolically unhealthy obesity, doesn't have hypothyroid, doesn't have hypertension, diabetes, and the prescription is not covered by insurance. Unfair, right? So the idea is to define obesity, which is a pathological obesity, as a clinically definable condition, so that you go about treating it, and the insurers also cover the treatment-related expenses, and the public health authorities, they take cognizance of this fact and takes appropriate measures to reduce the burden of pathological obesity in the community. So there is disagreement, as you can see. This is from the latest Lancet Obesity Commission Consensus Building Conference. So how many of you in the audience feel that obesity is a disease? About, I would say, 40%. Excellent. In this consensus, where world experts on obesity, they participated, 70% initially thought that obesity is not a disease. Only 30% felt obesity is a disease. So there is still a controversy. When you have a controversy, and you need to fall back upon something called a Delphi consensus. See, what's the problem with a BMI-based diagnosis? The athlete, the boxer on your left, he has a BMI of 35. Is he obese? No, he is not. Because if you do his body composition analysis, you will see that his body fat is 18%, 25% being the upper cutoff. So he is not obese. Look at the right. The lady and the gentleman, they both have obesity. If you go by BMI, look at the lady. She's a javelin thrower or maybe a shot putter. Is she obese? No. She doesn't have a pathological obesity. So she is a fit, fat woman. Right, so for her, we do not need any intervention. On the other hand, look at the gentleman, truncal obesity with a similar BMI. So he would qualify for aggressive interventions. This has been reiterated time and again. Yudkin and Yajnik both having a BMI less than 23. Yudkin's body fat is 9%. Yajnik's body fat is 22%. So Indians have a higher body fat regardless of their BMI. So if you go just by BMI and try to diagnose obesity, you will miss many cases, right? So that's the whole idea behind lowering the BMI cutoff. So this is the current definition. Normal BMI for Asian populations, 18.5 to 22.9. But anybody having a BMI above 23, is he or she pathological, harboring a disease? The answer is no. So you have to categorize, right? Waist circumference defines obesity better, regardless of BMI, cutoff for women being 80 centimeters and men being 90. So how the Indian obesity consensus was built up? As I said before, using the Delphi technique, Those who are not familiar with this technique, let me walk you through very quickly. So you can see the high priestess there sitting on a tripod. She is Pythia. She is sitting on a platform from beneath which a toxic fume used to emanate. This toxic fume used to make her go into a state of trance. So what happens when you are into a trance? Apni bhulbhal bokte paren, right? So many things she used to say was under the influence of a trance. So many things were rubbish. But those rubbish things are important. Why they are important? You see, people are kneeling in front of her. They want to listen to her opinion regarding some conflicts in the community. And she is surrounded by the priests who form the committee. So when you have this Indian obesity consensus, there is a Pythia. When you have the Maselty consensus, Kenneth Kusi, Orlando, he is the Pythia. So there are 50 people around, and whatever he says is taken as a gospel. It is not, right? So you have to take it with a pinch of salt. So consensus documents, Delphi consensus documents are not sacrosanct. You have to exercise your own judgment. And you can see a stone over there, which is the Greeks, ancient Greeks used to consider the navel of the earth or the center of the universe, that stone. And so beside that, the Pythia used to come and deliver her sermons. Now, very interesting, Pythia's prophecies, though often ambiguous, were taken very seriously. They influenced decisions about war, peace, agriculture, and other important matters. But these were not RCTs, just somebody's opinion. So Oracle of Delphi played a significant role in Greek culture and religion, while Pythia's pronouncements were vague. Many a time, they were vague pronouncements. But priests and interpreters often played a role in translating them into actionable advice, right? So that's the problem. And here we have a Delphi consensus document. So you have BMI more than 23. On the left, you have stage 1 obesity, not associated with any comorbidity here. So these people are not metabolically unhealthy. But they may have a body fat around 20-25%, and you have to keep a watch on them, right? On the right, you have stage 2 obesity, more than 23 BMI. Do you start treating them? No. You do their anthropometry and find out whether they have truncal obesity, or do a DEXA to see if they have a body fat exceeding 25% for men, 38% for women, and then if they have associated comorbidity. So excess body fat, associated comorbidity. Then you think about treating them, right? So it's actually a small portion of the entire population. So these have been discussed. Lancet Commission, clinical obesity and preclinical obesity. Basically, in this consensus also, they divided people based on BMI less than 25, more than 25, less than 25, more than 25. Then clinical obesity means associated with organ dysfunction, and preclinical obesity not associated with organ dysfunction, just like our BMI stage 1 obesity, okay? This has been discussed. So what do you mean when you say organ dysfunction associated with obesity? So these are the 12 conditions, and you are all familiar with them. So obesity associated with any of these would constitute obesity with organ dysfunction and needs intervention. So to summarize, obesity definition, previously heavily reliant on BMI, now incorporates anthropometric measurements. Current definitions distinguish between metabolically healthy and unhealthy obesity. In stage 1 obesity, clinicians should focus on advising on diet, exercise, and lifestyle modifications. Obesity stage 2 and beyond, means pathological obesity, like I said before, if associated with evidence of organ dysfunction, warrant a more aggressive approach. This is a book which we have edited recently. The book is expensive, but there are chapters on metabolically healthy, unhealthy obesity, low BMI obesity. So you can, if you're interested, you can buy those chapters. They cost around $32 to $35 a piece, each chapter. So the chapters are actually purchasable. With this, I will stop and thank you for attention.
Thank you, Dr. Shatinath, for finishing in time. I call the second speaker. Dr. Shatinath, please here, and we will take the questions after the second speech is over. Dr. Somit Ghoshal, I think he does not need any introduction, and he will talk on a very interesting and very pertinent topic, that is the non-pharmacological treatment of obesity. I think in the conference room, maximum number of us are probably treating with non-pharmacological treatment, because this GLP-1 is probably beyond the scope of almost maximum of our practice area. We are not using this injectable GLP-1 absolutely due to the cost. So non-pharmacological treatment, I think, is most important for all of us to hear from Dr. Samit. Start, please, Samit.
Thank you, Dibenduda. The least talk about topic and where you don't get any sponsors. I thought Abbott will sponsor me, but they're directly selling their product in the shops, so they're not interested in the topic. Non-pharmacological management, if you have smartphone in this room, please raise your hand, those who have smartphone. I'll ask all of you to download one app with which, without the requirement of a dietitian, you can give your patient a low-calorie or a flat diet. So I'll go through that in a moment. All of us do not have the luxury of having a dietitian along with us. We have to do the diet and exercise and therapeutic part all by ourselves. So I'll just go through some simple tips that we can follow. Change karo ki kare. Okay, my first question, which is the most effective strategy for weight loss. If I have to choose between the two, how many would you say it's dietary modification? Please a show of hands, thank you. And how many of you would say it's exercise? Okay. The American Heart Association and Physical Activity says you cannot lose weight with exercise. Why? Because in order to lose 368 kilocalories in a day, you need to jog for 30 minutes, which is equivalent to 2 biscuits. Just remember the next time you have 2 biscuits with your, that is equivalent with jogging for 30 minutes. Now, if I need, the recommendation for weight loss is at least 800 kilocalories deficit from your existing diet. So that means you need to jog at 8 kilometers per hour for continuous 3 hours in a day. Now just think whether how practical or feasible that is. So all the association says exercise is important for maintaining lean muscle mass, because whatever we'll be discussing about weight loss has a predominant side effect in the loss of lean muscle mass, and that has a problem. So exercise in the form of resistance training is extremely important in maintaining the arms and the limbs, because they are extremely important. They're the dustbin of the body. Now, it is again a very common place when our patient comes to us, and we have the luxury of a dietitian in saying, you need to go to a dietitian and create a diet chart. What do we do? Suppose this is the patient, 59 years of age, Mr. X, diabetic for 5 years on metformin, linagliptin. BMI is 29, walks as suggested by ADA, 30 minutes per day, every day in the week. HbA1c 8.2 has OSA. Now I need these patients to lose weight non-pharmacologically. What will I write and send to a dietitian? 1200 kilocalories diet. Can we have a show of hand? Okay, 1600, 1800, and 800. Okay. So the problem is none of them are right answers. And I'll tell you why. This is the reason I asked, do you have a smartphone? Those who have Google Play, please download the Calculator Harris-Benedict. It is free of cost. Those who have Apple phone, please download Harris-Benedict equation. If you download that in your app, I'll teach you what to do in formulating an adequate calorie-restricted diet for your patient. So this is the thing you need to download free of cost. This is how it will look like once you download it. You have to just put in a few parameters, which you normally occur during the consultation. Age, height, weight. This is the only thing we need to know. Activity factor, which is this. If it is 1.2, means patient is confined to bed. 1.3 is my patient here, 30 minutes walking per day. 1 hour exercise per day is 1.4 to 1.5, and very heavy activities, like marathon runners, it is 1.75. In this patient, it is 1.3 because the patient walks for 30 minutes per day. Ignore stress factor, it has been deleted now, let it remain 1. Click calculate and you will get a value which is called BEE. What is BEE? We talk about it a lot. Basal metabolic rate is also called basal energy expenditure. But what we are interested in is the total energy expenditure. So when we are doing practically nothing, walking around, doing our daily activities, having our normal food, we are actually burning this amount of energy. Now you can use your ChatGPT. I have forgotten using Google for the last 1 year. I only use Grok 3. You can use ChatGPT, Deep Dive. We have lots of things. And you can put on your Siri or you can type and ask your patient to say what he or she eats from morning to night, and you'll have the calorie in front of you. You can subtract the calorie and you'll find what is the excess amount of calorie which is going into the system. So here, this is equation. We need not remember. The Harris-Benedict app is going to do all for you. Total energy expenditure is BMR, which is given by the app, plus exercise. We rarely lose more than 300 or 400 calories per day with exercise. This is important. NEAT, which is non-exercise activity thermogenesis, which is daily walking, climbing, gardening, non-exercise activities that we do, which now cannot be directly calculated, but can be assumed from the BE, basal energy expenditure. This is important. I, for the last 2 months, did a meal replacement diet. My weight went up to 80 kilograms, and I was more than 25 in my BMI. In 2 months, I've lost 6 kilograms. I'm now 23.6 by doing meal replacement therapy. Based on these calculations, no drugs. I've lost 6 kilograms in two months just by doing that. But what I did mistake was I stopped eating. I just had dinner. So I didn't eat for 2 months. There was no breakfast or lunch. I used to have a cup of coffee and 1 meal replacement. I lost all my muscle. In every single CME, people used to come and say, you have fantastic biceps, this and that. I lost everything. I started developing sarcopenia. Why? You need to eat more proteins to lose weight. Because if you have 30% of protein in your food, the body has to work to burn the protein. So your total energy expenditure goes up by 15%. So stopping food doesn't work. You have to eat more protein to have more TEE, so that with the same amount of calorie going into your system, you lose weight and you become more healthy. That's a mistake I did. So this is the calculation, remember? Now with this person now, in the calculator we got the TEE. We took a history and we found that he is consuming around 2,200 kilocalories, so there is 122 kilocalories excess going into the system. Now from here, I have to make him go to a deficit of 600 to 800 kilocalories. That is what my dietitian needs to know, or that is what my dietitian should do. So you see, this is the kilocalorie. If this patient can go from 2,200 to 1,278, the patient will start losing weight from 3rd week. And we need to assess the patient after 3 months, how the patient is doing. This is the structured approach to weight loss. Let me tell you 2 things. If you want to become a certified obesity treatment specialist, you can do the SCOPE certification online. It's 60 pounds, and they will certify you after you finish the course. I have done my SCOPE certification. And there are a lot of things to learn, from that certification. Now, first thing we need to do, as Shotinath said, probably are less than 23 and more than 23 is too simplistic. This is much better. It's called the Edmonton Obesity staging system. This part red is the safe zone. Beyond this part, you need dietary therapy and exercise. Stage 3-4 is a very, very dangerous state where there's significant comorbidity. Patient finds difficult to climb stairs. Patients have OSA, have osteoarthritis, and patients also have bad control of diet. You might have obese patients who are struggling with high dose of insulin. You won't be able to achieve those endpoints until the patient starts losing weight. This is where pharmacotherapy with lifestyle modification comes in. So this is extremely important to stage our patients. Having staged our patient, we need to do body fat assessment. As we know that DEXA and MRI are gold standard. Again, it is extremely, it's not yet standard of care, it's expensive. And if I run a clinic, how can I buy an MRI or a DEXA? It can't happen. So what you can use is, I use the HbF 375, which is the Omron machine. It costs 8,500 rupees. Your clinic can buy, you can buy it. It's a fantastic body fat estimator with just 3 to 4% error rate compared to DEXA. So it's very, very close to DEXA. So for example, this is my recent data. My weight 75.4, BMI is 23.9. This is my total body fat percentage that I think Shotinath was talking about. I'll be very happy looking at my BMI, but look at my body fat percentage. It is very high. Now, why is it high? Is it high because of my visceral adiposity, which I can't see, or my subcutaneous adiposity, which I can measure? So here is my visceral adiposity, 10.5. Again, I have this thing, which is not bad. Less than 10 is ideal, but 10.5 is not that bad. So I have more of a subcutaneous fat than visceral fat. And as I told you, in the zeal of losing weight, my skeletal muscle percentage is 30.1, which should be more than 33. I have lost my muscle mass. So actually, I'm very happy I've lost weight, but I've become very weak, and my muscle strength has gone down. So this has to be taken into account. So first strategy is take a weight, BMI, waist circumference. Waist-hip ratio is now being gradually replaced by waist-height ratio. Neck circumference and body fat analysis. Target a deficit between 500 to 800 kilocalories depending upon your patients. What is the baseline calorie intake? Now, the types of diet, how to do it. After assessing our patient, we need to do something. The most effective way of losing weight is called the VLET diet or very low energy diet. It's also called the ketogenic diet. Very difficult to follow, but it can be used for a temporary period and can be switched over to low calorie diet for maintenance. Otherwise, you'll just switch off to a normal mode and gain all your weight. It is 800 kilocalories. So you don't go into those calculations. You flatly put your patients on 800 kilocalories. You can expect 15% of weight loss within 6 months. 2 meal replacements can be done, which means formula feed. 6 scoops with 300 ml of water, like Ensure D and many others are there. They are the formula feed. Contraindication should not be tried on those on sulfonylurea insulin, on warfarin, or have organ dysfunction or pregnancy. Much easier to do and maintain is low-calorie diet, which is mildly ketogenic, which is minus 600 kilocalories from existing diet. To do that, we need to do all those calculations that I showed you. Total carb intake should be less than 50%, protein should be 30%, fat should be as less as possible. This will give you a 5 to 6 kgs weight loss over 2 years. Maybe not sufficient for achieving those 10% weight loss for cardiovascular benefit, might require the help of pharmacotherapy temporarily. But they are good in improvement of glycemic control and dyslipidemia. For individuals who are really struggling, you can go for an intermittent 5-2 diet, which means 5 days have normal diet, 2 days go for a VLET diet or a low-calorie diet. They're equally effective as a low-calorie diet. This is the point. All these strategies, whether it is pharmacotherapy or it is lifestyle, does fail. So you see the VLET diet is the best strategy, better than even orlistat, sibutramine. But look here, after 6 months, it starts going up. So the struggle is motivating our patient. Again, if you have the luxury of having a clinical psychologist, that's ideal, because a lot of depression and other psychological factors play a very important role here. So to conclude, we must change our management strategy for chronic disorders from secondary prevention to primordial and primary prevention. So someone who has obesity and has a bad family history, doesn't want to develop diabetes, hypertension, lose weight, they don't come to us. We have to find a strategy to bring them to our chamber. Those who are obese and developed hypertension and diabetes, how do you prevent them from developing MI and stroke? We can go for reversal. Insulin plus medications, bariatric surgery we have seen, they are off insulin and medications. So we can target reversal with the modern pharmacotherapy and VLET diet. Dietary modification is essential, low-cost strategy can be achieved if the patient is motivated to do so. Look at this, US data. They have the pharmacotherapy available even way before. It's launched just now in India, just 1 month. But they had it long time back. But in spite of that, 86% of adults with type 2 diabetes receive pharmacotherapy, but only 2% received in the USA. Remember, it's a reimbursable market, and only 2% are receiving a pharmacotherapy. Pharmacotherapy is going to work very well, GLP-1, because there are 9 hormones which works on satiety. One, obviously, is T3, which is being developed now. The other 8 are very well taken care of by most of these drugs. But remember, the game changer would be setmelanotide, because these drugs are working downstream after you develop. This is a genetic disorder, obesity. It's only 10% is contributed by junk food. You'll be surprised. That's what the data says. It's a genetic disorder, an epigenetic disorder, and the genetic component, which is the MC4, knockoff in the brain, is only taken care of by setmelanotide. Is already approved by FDA EMA, so it's going to be a game changer. This is where it works. This is the entire thing. How different molecules work in different levels. There is a fat, hypothalamic set point here. That set point needs to be taken care of. Now that switch is here, MC4, R receptor. Now the MC4 receptor is switched off. We need to switch it on. How do we do that? This is the only drug which will do. As of now, this is remaining as it is. We are taking care of the ancillary defects. This is our paper. Second review is going on in the journal Obesity, where we had done a Bayesian network meta-analysis of all the GLP-1 3 milligrams liraglutide and the tirzepatide, as well as the triple agonist. The reviewers said we do not want a separation between semaglutide and tirzepatide. Show us what happens between diabetic and non-diabetic. So this is the second review. Diabetic responds 50% less compared to the non-diabetic individuals. So whenever we have our diabetic patients with obesity and same group who are non-obese, the expectations, we must understand diet plays 10 times more important role in the diabetic population. If we do not complement with effective low-calorie diet, we will not get the results that we tell our patient that this molecule gives us. And motivation is extremely important. Is my patient motivated to lose weight? Because if you're not, whether it's quitting smoking or alcohol, if you're not willing to do so, you cannot induce a weight loss or anything else for a demotivated patient. So thank you very much.
Thank you, both the speakers, for finishing in time. Please, Sumit, take your chair. So I think there are many questions in your mind. Two speakers are here, all are masters regarding the management of obesity, non-pharmacological as well as pharmacological, and what we are doing in our practice. I think you should at least participate and share your experience.
I have a question to Dr. Shomit Ghoshal. Do you consider a component of impulse control disorder in the causation of obesity? And how do you propose to deal with the component of impulse control disorder, means compulsive eating, in the management of obesity? That would, I think, also be a part of lifestyle modification.
I agree with you, Nilanjan. We only are concerned and we only read medical papers. But there are a lot of people doing basic science works in Harvard and other universities, and there were 4 types of obesity they described. One is the brain obesity, one is the gut obesity, and there are 2 more obesities. One of them is the psychological obesity. Now, these drugs actually have no impact on psychological obesity. So if we do not, count, I have seen one patient, I've seen tirzepatide, I have already, I'm going to the 5 milligrams now, I have a sizable number who have been on 2. There's a fantastic response after the first, second dose. But there's 1 or 2 patients I have seen that absolutely nothing has happened. Now they're on 5 million, nothing. They have actually gained Then I found out they have a lot of psychological issues and are on a lot of antipsychotic drugs, which actually causes weight gain, which is, hindsight, I see it was a defect on my part of history taking. That I'm counseling my patient, I'm overboard, new drug, start, you lose weight. I forgot to take the important history that there is some other trigger which is countering the entire effect of it. This patient will not benefit unless the part you're saying is taken care of primarily. Am I right, Nashutinath?
If I may add, what I do in my practice, if a patient is on olanzapine or risperidone and obese and needs one GLP-1, I request the patient to ask the patient to go back to the psychiatrist and put a note. Can this patient be taken off this medication and switched over to quetiapine or aripiprazole, just like that? And many of the psychiatrists, they agree. They change the medication and that does the trick. Thank you.
So, Tinath, if they don't agree, do we change the psychiatrist?
In fact, actually, I do ask them to take a second opinion. Thank you.
Any more question? If there is no question, then we are concluding the session. Thank you both the speakers. And I will hand over to Nirmala.
Thank you once again, the chair and the speakers. We are now having an interesting session with injectable semaglutide 2.4 milligram, which I understand has not yet been available here, but we are shortly going to get it. A lot of trials are being done, including STEP group of trials. I think Nilanjan is there, Dr. Nilanjan Sengupta, who will chair this session, and you please introduce the speaker.
A very good morning to, or good afternoon to you all. At the outset, I thank Dr. Shomit Ghoshal, Dr. Binaksina, and EKDG for inviting me out here to a wonderful conference. And it's a packed hall in a Sunday morning. That's really encouraging. And we have heard about one of the neglected aspects of obesity management, that is therapeutic lifestyle change. I do still hold the view that therapeutic lifestyle change is the sheet anchor or the cornerstone of management of obesity, unlike diabetes, where therapeutic lifestyle change and pharmacotherapy go hand in hand. But so far as obesity is concerned, I still do believe that therapeutic lifestyle change is the cornerstone or sheet anchor of management. But now, to help therapeutic lifestyle change, we have very exciting developments in the pharmacotherapeutic fields in the form of injectable incretins, be it semaglutide, be it the dual agonist in tirzepatide, or in years to come, triple agonists like retatrutide, and so on. So I think we are just a step ahead in seeing the launch of injectable semaglutide exclusively for the management of obesity, to expand the anti-obesity therapeutic armamentarium. This is we are used to using oral semaglutide for diabetes, but injectable semaglutide solely for obesity is still a new and uncharted territory for most of us. And to make us familiar with this exciting development, we have none other than a very bright speaker in Dr. Arundhati Dasgupta, I think, who is also like me, coming from another obesity conference from the northern part of the city, to enlighten us now on injectable semaglutide. The stage is yours.
Thank you so much, sir. And thank you to EKDG for inviting me over. And indeed, it's heartening to see a full house on a Sunday morning. But before I start off with my talk proper, we were talking about a sponsored talk, because it is a pharmacology. We'll be talking about pharmacology. I'd just like to ask you, how many of you treat obesity, and how many of you have been frustrated while treating obesity? Could we have a show of hands? So the others are happy with their treatment of obesity, with whatever was available till now. Because I, for one, I'll raise my hand strong and high, because when we got our obese patients, and we could see that they could be metabolically healthy or unhealthy, but they were really struggling. And we sent them to the dietitian, who put them on a diet chart. Very honestly speaking, a low-calorie diet or a VLT is not practically possible to continue for a very long time. In a research setting, that's all right. But Sharadin is 600 kilocalorie. How many of us can sustain for a very long time? For a certain period of time, it's okay. So you send them to the dietitian and you tell them, Nana, exercise korte habe, this and that. And you know they're trying, they're really trying, they're putting in their effort. But they come back to you and your heart sinks, because till some time back, because you really know that you do not have much to offer to them when they're trying everything and they're failing. I remember a patient who had told me, ma'am, it's like as if I'm trying to climb a mountain and someone is pulling me down. And that has actually stayed with me, because that's true. It's not that all of them are demotivated. They're quite motivated. They're exercising. They're maintaining a diet as far as feasible. And what did we have in our hands? Orlistat, which really works in very few category of people. So you were there. You were telling them again and again. They are frustrated. You were frustrated till some time back, when pharmacologically, we got molecules. We are on the verge of getting some others, which gave us hope that in those who are failing with lifestyle, this is not taking away any importance of lifestyle, but in those who are failing, you have something to offer to them. Yes, the molecule that we're going to talk about is expensive, but there are people who can't afford it. And there are people who can afford things, but they still are not reaching there. So ladies and gentlemen, we'll talk about semaglutide 2.4 milligram today and how can we step up care. Sorry. Back. Move, all right. So first thing is that we need to understand is obesity is not about calorie in and calorie out. Kototuku khelen and kototuku exercise kulen, you wish it was. But just now we heard about how the classification of obesity has changed and how we are talking about, the brain obesity, the gut obesity, and the brain actually has a very, very strong role to play. So when you're talking about obesity, it's about an amalgamation of so many factors: genetics, epigenetics, biological, psychological, social health, environmental, medications that the patient is on, and it is an interplay of all these complex factors that is causing obesity. So you cannot just simplify it as calorie in, calorie out, which is why we have been failing with the lifestyle for such a long time. So there are many paths that are leading on to obesity. And as we understand about the role of the brain, we now know that there are centers of the brain which are controlling our hunger. There is the hedonic center, there's the homeostatic center, and there are so many other molecules. There's the orexogenic center, which controls your satiety, the anorexigenic centers, the PYY, the NPY, the AGRP. You're talking about a number of molecules that are coming out from the gut-brain hypothesis, the GLP-1, the OXM, the amylin, the ghrelin, the inulin. So it's a very, very complex thing. Just last week, I was giving a talk on the gut-brain hypothesis, and I realized there is so much to obesity when it comes to the gut, leave alone all the other things that we know about, not hormones. We are simply talking about gut microbes. Even they seem to have a very strong role in terms of what's happening in terms of obesity. So basically, obesity is about a lot of things. So we need molecules which are able to control, which are able to act on those areas so as to be able to control the satiety, the orexogenic area, the anorexigenic area. So we know also about the neurotransmitters, the dopamine, the opioid, the cannabinoids, and why a lot of people who are on antipsychotics, we've been having discussions there, have really struggled to cope with obesity. That has a lot to do with the serotonin, the dopamine, and a lot of other neurotransmitters that have a role in the control of obesity. So basically talking about the brain here, because we'll be talking about this molecule which has an action on the brain. So this basically the three areas, the executive, the hedonic, and the homeostatic area. Now when you're talking about, this is just what we spoke about, the lifestyle interventions, I'm not going through this. This is what the tug of war basically is, right? It's about calories and activity trying to fight with metabolism, with the hormones, with the fullness hormones, the hunger hormones, very simplified diagram, but it is telling us so much. So if we have to fight, the pull on this side has to be really strong from the weight loss side. So how do you pull it? You have to bring one of the players from there. You have to attack one strong player from the other end. So when you're doing it, that is where this molecule, Wegovy 2.4 milligram, comes in. This is semaglutide. Semaglutide, as we know, we've had oral for quite some time now. It's a GLP-1 receptor agonist that's working on the key areas of the brain that is helping control hunger and craving. Because this is the GLP-1, this is it's an analog to the human GLP-1, that is there in our body, 94% analogy is there. And basically what it is doing is it is acting on by direct activation of the hypothalamus. It is acting on by direct activation on the hindbrain through its action, in terms of the gut hormone. And this analog it's basically working on these key areas, working on the homeostatic regulation of appetite control, working on the hedonic regulation, and thereby increasing the satiety, making the patient feel full, less hungry, reducing the cravings, and also the preferences for certain kind of food. We have data now, research data telling us the GLP-1 not only is decreasing the cravings, it's also decreasing on the kind of craving that it is having, the kind of food that, the higher energy kind of food that would tend to cause more weight gain. So it's also acting specifically on that part of your brain which is regulating, when you see a food item and you have that interest in having that food, you have that will to take that piece of food, your GLP-1 is kind of regulating that interest that is generated. So it's working at a very micro level. So what have we seen in terms of trials? We've had a number of trials. We've had step 1, where they looked at weight management. Step 2 was where they looked at this molecule in type 2 diabetes. Step 3 was combining it with intensive behavioral therapy. Step 4 was looking at sustained use, whether you stop it after a while and you continue using it, what is the difference? And step 5 then looked into the long-term weight management. Step 6 was specifically in a certain group of patients, East Asians. Step 7 again in China, Brazil, Korea, and Hong Kong. Step 8 was head-to-head with liraglutide. Step 9 was with obesity and osteoarthritis. And step 10 was obesity and prediabetes. We've also had SELECT, where obesity and cardiovascular outcomes were looked into in non-diabetic individual, and the STEP HFpEF and the HFpEF DM, and the ESSENCE, where you're looking into the data with MASH. So around 8 million people have been prescribed therapies containing semaglutide worldwide ever since it has been launched, and there are certain STEP trials which are still on. Now, when you look at what data do we have from India, thankfully nowadays we're at least getting some data from India with the newer molecules. Earlier we had to completely rely on Western data, but we have had some amount of participation from our Indian patients in step 1, in step 2, in terms of the injectable, and also in SELECT, as you can see, and some of them in the HFpEF DM, which is going on. We've had data with the oral in terms of sustain, in flow, in focus, and also in semaglutide, the oral semaglutide. So we'll talk about step 1, just trying to understand the role of semaglutide in obesity and overweight per se. So here we had around 1961 participants. They were more than 30, they had a BMI of more than 30 or more than 27 with comorbidities, and who had a kind of stable body weight for more than 90 days, HbA1c being less than 6.5. So you can see that initially they were started off at the dose of 0.25 milligram, and every 4 weeks it was stepped up. So 0.5, 0.25, 0.5, 1, 1.7, and up to the final dose of 2.4 after a period of 16 weeks. So the basic objective was to look at the effect of the use of semaglutide 2.4 versus placebo in terms of body weight, cardiovascular risk factors, glucose metabolism, and other factors related to body weight. And also, of course, to look at the safety and the tolerability of semaglutide 2.4 versus placebo. So the primary endpoint was the percentage of weight loss, and also 5% weight loss were considered as responders. That is clinically significant weight loss. When you have at least 5% weight loss, that is considered clinically significant. So that was taken into account. And then they looked at 10%, 15% weight loss, and the other parameters like SF36 and all. We'll take a look at the results. So what was seen is that over a period of time, now you can see that the action started gradually and as it came down, and it continued to come down over a period of 68 weeks. We can see data till 68 weeks here. So there was a total 16.9% reduction in the total weight from 0 to 68. So if somebody had started off with, say, a weight of 100, so there would be a reduction of around 17 kgs after the usage of semaglutide 2.4. What is important is that not everybody is going to lose the same amount, right? So let us look at how many people lost at least clinically significant weight, that is like more than 5%. That number was 92%. So 92% lost more than 5% as compared to placebo. You can see the numbers are very different. More than 10%, at least 10 kg, say in a 100 kg person, that's also around 75%. So if 3/4 of your patients are losing more than 10% of the body weight which they started off, that's significant. More than 15% was to the tune of around 55, and more than 20%, which is immensely significant. Certainly, that was, again, 34.8%, almost 35%. So what you're saying is that out of every 3 patients that you're treating, 1 patient is going to lose more than 20% of weight. And that kind of weight loss has not been seen with anything else apart from tirzepatide and bariatric surgery. 20% weight loss is huge. We cannot, in almost none of our patients have I ever got a 20% weight loss with only lifestyle management. I at least have not been able to manage that bit. Maybe 5%, 7%, 10% best. But 20% weight loss in 1 in 3 patients, that speaks volumes. That's like immense weight loss. So when you're looking at the other parameters, you're looking at the waist circumference, you can see minus 15.2, blood pressure minus 7.1, and there is an assessment score that is known as SF36 that evaluates the effect that it has on your functional ability. So there are various aspects of looking at SF36. They looked at the physical functioning score there, and they did see a major improvement of 2.56%. The others, in terms of HbA1c, remember these were non-diabetics, but their HbA1c also came down by minus 0.5%, diastolic by minus 3, and CRP, which is again a marker of inflammation in obesity, and a significant one at that, came down by 58%. If we take a look at step 4, now this is about maintaining Wegovy 2.4 milligram versus treatment withdrawal. So you can see as compared to there was this run-in period, and then it was taken off in one arm and it was continued in the other arm. And the key endpoints were almost similar. This is just looking at the change in body weight at week 20. Now, interestingly, the baseline characteristics, I read through this once more because I think this is the first study with a molecule where I've seen a female representation of 79%. This is like, wow. Anyway, talking about the other things, the mean body weight was 107 and the mean BMI was 38.4. Now, what happened? In the participants who continued the usage of 2.4, you could see that further on, there was a loss of 18.2% from week 0 to week 68, whereas in those who stopped, you can see there was a 6.9% increase from week 20 to week 68. That bit of increase was there was the difference, overall difference in that 2 categories, which continued and which did not continue. So more than 20% was seen in 1 in 3 patients, and if it was continued, even after 20 weeks, the results persisted. Then is there long-term maintenance? Supposing you're getting a weight loss, does it stay or does it come back? So that is what step 5 looked at. They looked at, they compared it along with the lifestyle intervention, and the key primary point was at week 104. You tried to look at what was the change in weight and the 5% reduction in weight loss. So those who continued with Wegovy, you can see over a period of 2 years, 104 weeks, the weight loss persisted, and 16.7% reduction was seen further on, as they continued, and there was 0.6% reduction, from week 0 to 0.68. So again, step 4-5 told us that this is a weight loss that is going to persist if you're going to continue. It's not going to, get over or plateau over a period in time. Then we had SELECT. Now, SELECT is one of the largest cardiovascular trials that have been done, and around 490 patients were taken from India. A total of 17,000 patients from more than 40 countries over a 40-month period of follow-up was studied. So this is basically a non-diabetic population. This is an overweight population or an obesity population, and they had CVD. And this is an anti-obesity medication looking into the MACE reduction in this non-diabetic population with obesity or overweight. So what did SELECT tell us? SELECT, as you can see, the graph separating the arms of the placebo arm and the Wegovy arm starting separating quite early, and the gap increasing further on as it is going on to week 48, thereby telling us that there was a 20% reduction in the risk of MACE. So semaglutide now being the only ESC recommended obesity medication that should be considered or could be considered in patients with overweight or obesity with CAD without diabetes to reduce CV mortality, MI or stroke. So this is again what the SELECT told us, a 19% reduction in risk of all-cause death, a 22% reduction in the risk of developing kidney disease. That again is an area which is, has really come up with the SELECT trial data, that the kidney disease-wise also there was, improvement in terms of ACR, there was improvement in terms of GFR, and a 73% reduction in the risk of developing diabetes in that overweight population. So again, in the SELECT trial 2, the weight loss that was initiated with Wegovy was sustained over a period of 4 years. So when we look at step 1, 4 and 5, the 3 trials that we looked into, and we look into the safety profile. Indeed, you have to look at the safety profile of any molecule. You cannot just be overexcited about a molecule which is causing weight loss and not look at the safety profile. So remember, we have immense data now today with semaglutide, and most of the data that has come in has not given us serious concerns about any major side effects. GI side effects we know we expected, mostly mild to moderate and transient, but in some people it did lead to discontinuation. You can see there, the 4.5 versus 0.8 and others. It was there, but it was not very significant in any of these 1, 4 and 5 trials. So thereby this is what it stands at. You start off with 0.25 for 4 weeks, observe GI side effects, observe the effects, then you go on to 0.5, 1, 1.7, and ultimately to the maintenance dose of 2.4. And this is like a stepwise 4-weekly escalation. And this is basically done to, you do not go over to the higher dose immediately, just to reduce the side effects and help the patient get aligned with this therapy. And so that brings us to the summary. It is semaglutide 2.4 is suitable for adult patients with a BMI of more than 27 with one comorbidity at least, or more than 30 regardless of comorbidity, and the data we have till now tells us about more than 20% loss in 1 in 3 patients over a period of 104 weeks, which has been sustained for a period of more than 4 years. And now the SELECT trial telling us about the 20% significant MACE reduction. So indeed it appears that we have a lot of hope for people who can afford, certainly for people who can afford in that category, diabetic or non-diabetic. We have hope for the obese patients in terms of weight loss and in terms of cardiovascular benefits. Thank you so much.
Thank you for your very comprehensive talk on a vast topic, because so many studies have already been conducted with injectable semaglutide. Now, my first question to you to start the discussion, you said even in non-diabetic individuals, there was a 0.5 percentage point reduction in glycated hemoglobin, which is quite impressive.
Yes,
Means to qualify any drug to have anti-diabetic properties, if it crosses 0.3 percentage points, we qualify that as an anti-diabetic drug.
Absolutely.
My concern is that with lifestyle modification and having this Wegovy, what was the prevalence of hypoglycemia? Was it significantly more than placebo?
Are we talking about step 1 where we had non-diabetic individuals?
I'm talking non-diabetic individuals.
So in the list of the side effect profile, hypoglycemia was not majorly mentioned, sir. So I believe it, when I looked at the side effect profile, and we've mentioned it there also, hypoglycemia was not mentioned as a major side effect that was seen in the step 1 trial.
So it was not clinically and statistically significant.
I think we can understand it why, because of the mechanism of action of semaglutide. We would not generally expect hypoglycemia in the non-diabetic population.
So aligned to other incretins as we use along in diabetes, also along with other agents, and maybe in non-diabetic individuals.
Absolutely,
right.
sir.
So the floor is now open for questioning. Yes. Please go to the mic and.
Madam, comparing between the tirzepatide and semaglutide, which one is better? They say that tirzepatide gives the more weight loss compared to semaglutide.
There's no head-to-head trial, but still,
We do
what's
not
your
have
opinion?
any head-to-head trials, sir. As of now, it'll not really be possible to say it based on assumptions. Data with both are very good.
Now, particularly, I just attended Monjaro's.
You have another session
Yes,
just
sir.
after this. You can again attend.
That they claim
So
No.
was there any study to fall back on their claims, sir? We cannot, because we have to remember, whenever we are comparing two molecules and we are comparing two studies, we need to look at the patient population studied, we need to look at the baseline BMI, we need to look at the comorbidity studied. So I am not aware of any study which has looked into a direct comparison of tirzepatide and semaglutide per se. Personally speaking, I am happy that we have two molecules in our hand today which are showing us significant effect. And that's a step forward from where we were just about, say, 3-4 years back. So, personally speaking, I think we'll be happy to use both. We can leave. We will wait for some time for more data to come in with the real-world use of these molecules. Then we might be able to have better data to be able to talk about the comparisons.
Actually, what we can say from tirzepatide data and trials, tirzepatide is definitely superior to even the highest dose of liraglutide, because that's what it has been compared with.
Yes, sir.
But not with semaglutide for obvious reasons. We'll not be having any head-to-head trial as of now. But theoretically, dual GLP and GIP-1 agonism is expected to cause less of nausea with tirzepatide. Mind you, this is theoretical, but then nausea was there in all the tirzepatide trials too, and that's why they also recommend a gradual, dose escalation. Theoretically, GIP agonism can cause glucagon stimulation in the face of hypoglycemia. That's why theoretically chances of hypoglycemia may be claimed to be less, and that's what I asked Arundhati, but even the semaglutide trials didn't show any increased risk of hypoglycemia.
Yes.
And their best weight reduction was 23% or so, and here it's 20%. I think that is maybe a hair splitting, but of course the proof of the pudding would be in eating. And another thing, at least what I feel, tirzepatide in India should be available in a pen. So that way when Wegovy would be coming with a flex pen, that they score. So these are small points, but what Arundhati has said, both are excellent molecules, and there is an exciting hope for the patients with obesity. Any other question? Because this is a new product, there would be questions. We also don't know not much about that. Yeah.
They have done the trial over 15 milligram tirzepatide with the 1 milligram of
That's what I said.
Not with the injectable.
Highest dose of liraglutide or others, yeah.
Arundhati, two questions. One is on step 9, where osteoarthritis is being taken care of. There are some studies being done now to look at the effect of semaglutide with calcitonin effect.
Sir, right.
So this is something which I think very interesting, because it is not the weight of the torso only, but there are some other factors maybe. Your thought on that. And secondly, pre-diabetic to normoglycemia, there are in step 10, as you know.
Yes, sir.
So how long you should think that semaglutide should be continued in pre-diabetics to make them normoglycemic, and once they become normoglycemic, do you want to stop it to see whether they become again pre-diabetic? Is there any data exist?
So I'll take the second question first, sir. Because basically these are not people whom you're treating for pre-diabetes. These are people who you're treating for obesity. So in pre-diabetics, and you're seeing as a reduction, with the reduction in weight, you're also getting this benefit of. So I don't think once the patients become, from the pre-diabetic to the normoglycemic range, you're going to stop it. Because we've seen that once you stop it, the maintenance, that is a concern with both tirzepatide and semaglutide. We can see effects are there very well maintained till the time you're continuing. Once you stop it, the results are going to go back, not maybe from where you started, but there's going to be an uphill there. So I think personally, I'm using either of these molecules, semaglutide here, I will not stop when the patient becomes normoglycemic, because that is not the end point that we're looking at. Basically, you're looking at weight loss, and when you attain a certain amount of weight loss, you would want to keep the molecule there, if feasible, to maintain the weight over a period of, as has been seen over a period of 4 years, you could be maintaining that weight, and while you're maintaining that weight, you would be expected to maintain the other parameters also. And sir, as you said regarding the osteoarthritis, indeed, there's a lot of discussion about the other role of semaglutide, apart from what is happening because of weight loss and the effect on osteoarthritis, the role on calcitonin that is coming up, and that will be an interesting area of knowledge for us too, to understand about the interaction between GLP-1 and calcitonin and how it affects osteoarthritis. And yesterday also I think we were having a discussion on this, and I was also thinking at that point in time that maybe we might be able to discover better other avenues of this treatment if it indeed does have a role on calcitonin, on other modalities of treatment also.
So, yeah, sure.
Just a comment that we will be having the results of these two molecules head-to-head in some time. The top lines are out, and perhaps a 13.7% weight reduction with the semaglutide higher doses, vis-a-vis a 20.2% weight reduction with the tirzepatide molecule, SURMOUNT 5. Top lines are just out.
So, yeah. So I think we had a very engrossing discussion on injectable semaglutide, that is a drug of the near future for the management of obesity. So I thank Arundhati for her excellent deliberations and thank the audience for your interest and active intervention. Over to the organizers for the next session, which I understand will be discussing tirzepatide.
Thank you, sir.
So thank you again, the chair and the speaker. Now we are going to have tirzepatide, as already been mentioned. And I think Dr. Shomit Ghoshal, yes, he will be the chair, and he will introduce individual speakers. We have 3 speakers here, and we'll have a overall discussion on tirzepatide, as I understand. Over to Shomit.
Thank you, Nirmalada. So this is the one the drug we'll talk about. There are 2 molecules which is going to hit the market. One has already hit the market, which is tirzepatide, and we are expecting 2.4 milligrams semaglutide in the month of probably July. Now, how to use them? These are expensive product, good product, but probably not meant for all people. So how do we identify who are the right people? Whom should we use it? Whom should we not use it? So I'll call Somabrata, because before going into the product, we need a prelude. We need to find out what exactly is wrong. We have been discussing from morning about how bad ectopic fat is, but I think to take us through, Somabrata, over to you.
Well, since hunger pangs are on in most of us, it will be easier for all of us to understand what's the pleasure of eating. But before going into the topic proper, I would like to thank the organizers, Dr. Ghoshal and Dr. Sinha and all the other members of EKDG for having me out here, and also to the fantastic audience who have kept this hall full on a Sunday morning. Well, the science of obesity, it has been discussed and dissected. But as you know, our pharma industry friends, although we know the name of the molecule, they come up to us every month just to reiterate. So my job is just that, reiterating what has been already told, but maybe with a different form of slides and with a few different terminologies. So I have been contracted by Eli Lilly for this session, but I have no direct conflict of interest with regards to this talk. So the science behind obesity, a brief recap. This is what we all have heard. Neuronal and hormonal communications modulate food energy and energy expenditure. If we look at the mesolimbic system, That's the hedonic pleasure of eating, where we want to eat, where we like to eat. For example, I, for myself, face a terrible situation when I am confronted with ice creams. So I cannot resist myself, despite whatever be the morning weight check. So there, as one of my earlier speakers was telling, it directs about the type of food also, this hedonic pleasure. Well, I am not that much excited when I see a Golgappa on the street. I can avoid and I can go. But when it comes to ice creams, maybe there are people, they come and say, one of my urologist colleagues said, when I pass Balaram Mullik, it really drags me in. So it's about sweets. So the type of food about which this center is strongly acting is also a matter of discussion. Then you have the homeostatic eating, the satiety, the appetite, the energy expenditure, and the prefrontal cortex, which regulates the executive function. That's the self-regulation and inhibitory control. So for me, when it comes to Golgappa, this action really suppresses the mesolimbic system. But when it comes to ice cream, the mesolimbic system seems to overpower the prefrontal cortex. And you know about the hormones, the intestines, the GLP-1, the CCK, the PYY, the OXMs and the GIPs. You have got the leptins, the amylins, the insulin, and you have all the ghrelins, which is the hunger hormone. So this is the hunger hormone, and all the others which are secreted from the intestines, adipose tissue and pancreas are the satiety hormones. Adipocyte dysfunction is a key driver of related complications. Healthy individuals display normal adipocytes. In obesity, what happens is the adipocytes not only increase in size but also in numbers. The adipocyte dysfunction, contributes to accumulation of lipids in ectopic and visceral fat depots. Well, you have heard about epicardial fat, the pericardial fat, the hepatic pancreatic fat, and also there are fat deposits in the renal sinuses, the intermuscular radius, and you have got the retroperitoneal, the omental, and the mesenteric fat. You also have enlarged and dysfunctional adipocytes which lead to local and systemic inflammation, and insulin resistance really goes up. The inflammatory cells such as the macrophages, the cytokines, they secrete interleukin-6, TNF-alpha, MCP-1, and inflammation and insulin resistance, they really step it up due to their action. So what is excess adiposity? We have listened to many, the ongoing debates of how to define obesity or excess adiposity, which is a key component of obesity disease. Now, AACE tells that an adiposity-based chronic disease or obesity. South Safis declares that obesity is a chronic, relapsing, multifaceted, multisystemic endocrine disease which needs timely and sustained attention at a clinical as well as a public health level. And what does ESI say? That's Endocrine Society of India. Obesity is a chronic, relapsing, progressive disease. Of course, chronic, relapsing because it doesn't go off. Once you are off the drugs, you're off the lifestyle, 90% tend to regain all that weight back in 5 years of time. Defined by excessive adiposity that may impair health. So, that's the concept of healthy obesity or metabolically healthy obesity, as some say. These are the factors which have already been discussed. the epigenetic and the genetic factors, the environmental, the physiological factors, the behavioral and the socio-cultural factors. Maintaining weight loss is definitely challenging. Body's compensatory mechanisms favor weight regain. Following weight loss, what happens is there's a decrease in the energy expenditure and there's an increased hunger and decreased satiety. And these are the mechanisms which tilt the scales in favor of weight regain. Following weight reduction, most is regained in time. So this is a study from Australia to the left-hand side of your screen, where the weight changes of men and postmenopausal women in between BMI 27 to 40 in Australia, they showed that the follow-up period from the end of the weight loss program at week 10, the weight loss program ends here, to week 62, that's for 1 year, participants regained approximately 5 to 6 kg on average, and the p-value was statistically significant. 29 long-term US studies were looked into by Anderson, and they said that the percentage of weight loss, maintenance and reduced weight at 5 years were significantly lower than the values at 3 years. 79% of the weight loss were regained by the end of 5 years. So if you have lost 10 kg of weight, you would expect to regain 8 kgs over a 5-year time, and that's from analysis of 29 long-term US studies. So this asserts that lifestyle modifications, including dietary changes, alone are insufficient for maintaining weight loss that can be supported by scientific evidence. So following weight loss, what happens? Hormonal changes that persist for 12 months, they promote weight regain. Leptin is low, ghrelin goes high, PYY gets low, GIP is on the up, amylin and CCK are down. And these promote weight regain. And reducing appetite is one important issue. Pancreatic polypeptide goes up. So why? Because the body produces more hunger-promoting hormones, that's the ghrelin and GIP, and reduces the satiety hormones. These changes resettle or restate the satiety center and drive hunger and weight regain. The increased drive to eat and decreased energy expenditure resulting from weight reduction create a perfect physiological storm for weight regain. And this is why many of our patients do come back and they say that despite us trying to the maximum, we haven't been able to maintain the lost weight. So what are the obesity-related complications? This also is a known thing. They are the 3 M's of obesity: metabolic, mental and mechanical. So mechanical issues are osteoarthritis, pain, esophageal reflux, obstructive sleep apnea, hypoventilation, urinary incontinence, pseudotumor cerebri, lymph or lipidemia, thrombosis, plantar fasciitis and hyperkeratosis plantaris. If you go to the metabolic components, you get nutritional deficiencies, insulin resistance going up, increased chances of type 2 diabetes, dyslipidemia, hypertension, gout, steatohepatitis, gallbladder disease, polycystic ovaries, infertility, and also the increased incidence of cancer. In the mental issues, you have got distorted self-image, mood swings, anxiety, attention deficits, sleep disorders, personality, sleep disturbances, I should say, personality changes, addiction, psychotic behavior, and cognition defects do also occur. So what are the treatment guidelines and recommendations? Guidelines recommend that obesity should be treated to therapeutic goals. The European Association for the Study of Obesity framework recommends developing therapeutic goals based on severity and stage of disease, while considering prevention of further weight gain and obesity-related complications. This should be followed by a relevant intensification as needed. The ACE guidelines recommend that weight loss goals should be individualized based on medical history and presence of comorbidities and complications. Interventions should be determined based on the degree of weight loss required to treat obesity-related complications. According to the ADA and EASD consensus report, in type 2 diabetes, a higher magnitude of weight loss leads to better outcomes. We all know this from the direct trial. 5 to 10% yields metabolic improvement, 10 to 15% or more may have a disease-modifying effect and lead to temporary remission. So people with type 2 diabetes can especially benefit from early aggressive treatment. Damage caused by type 2 diabetes presents early compared to the ongoing lifelong benefits of early aggressive treatment. So early intervention with respect to weight in type 2 diabetes is critical. So this is the recommendations on screening, diagnosis and assessment, the obesity algorithm. The common recommendation: assess for the presence of obesity by determining the following parameters and categorizing based on the threshold values: BMI 18.5 to 24.9, that's normal weight. It's somewhat different in us, as you have already. Different waist circumference for Asian population. For us, it's the waist circumference. Graded cutoff is 90 for men and 80 for women. Common recommendations: thoroughly assess overweight, obesity patients with medical history, physical examination and relevant lab test. The Edmonton Obesity Scale comes into pertinence if you do this. And also you have to really look at the other lab parameters. Reversing obesity may improve or prevent significant obesity-related complications, and these are the complications that might improve. Here I would like to make a correction. 0 to 5% is perhaps not true. It is 2 to 5%. Because your A is not going to improve if you do not lose weight at all. The hyperglycemia. So 0% is not the A cutoff. It is based on another trial, and that trial really looked at 2 to 5% and not 0 to 5%. Obesity and type 2 diabetes cross-connect. So these are the factors which affect islet function. Expanding white adipose tissue, it increases the non-esterified fatty acid levels and pancreas, beta cell dysfunctions, and that causes insulin increased secretion. In the liver, the pro-inflammatory cytokines increase lipid accumulation and lipogenesis, and the skeletal muscle also there is increased lipid accumulation, decreased glucose uptake and glucose oxidation. So it again has got other factors like nutrient composition, the microbiomes, the maternal obesity and diabetes, and the birth weight, and the medications and the pollution. This is the case of two patients. Patient X presented in 2020, 45-year-old male. He was 110 kgs, blood pressure 135/85, waist circumference 115. Other comorbidities were hypertension and dyslipidemia. And then he again presented in 2025. Now he has gained 10 kgs more of weight, blood pressure has gone higher up, waist circumference still 5 centimeter more, hypertension, dyslipidemia, added on is diabetes. So in 2020, you would have perhaps looked at pharmacotherapy to control his hypertension and dyslipidemia, and also lifestyle modification and maybe orlistat to prevent the risk for type 2 diabetes development by taking care of obesity. And in 2025, when you have to take care of him, you have pharmacotherapy for obesity and type 2 diabetes and lifestyle interventions. So as to reduce the glycemic levels, body weight and complications. But what happens is that the treatment cost really goes up. So if you take a upstream approach, so the weight control can take care of your type 2 diabetes, hyperlipidemia, hypertension, coronary artery disease, OSA syndrome, MASLD and osteoarthritis. So early weight loss for type 2 diabetes reduces risk of type 2 diabetes in pre-diabetes. that is the progression from pre-diabetes to diabetes, is reduced, and achieving A1C targets of less than 7 has been shown to reduce microvascular complications of type 2 diabetes. So if you use an upstream approach of controlling weight, you could benefit from a large aspect in preventing the onset of type 2 diabetes. And really what we know is, one more slide please. So key takeaway points: type 2 diabetes and obesity are chronic, multifactorial diseases. Dysfunctional adipocytes contributed significantly to obesity-related complications such as insulin resistance, cardiovascular disease, and inflammation. Early treatment of obesity can help to prevent and reduce the risk of type 2 diabetes and associated complication. Implementing targeted strategies in obesity treatment can help mitigate complications and improve overall health outcomes for individuals struggling with excessive obesity. Successful weight management involves addressing not only biological factors but also psychological and lifestyle components, highlighting the importance of personalized intervention plans. Thank you so very much for your kind attention.
Thank you, Shomo. We'll take the question and answer later on. Now in sequence, let's not talk about type 2 diabetes first. Let's talk about simple obesity. So to talk about tirzepatide in addressing obesity, especially the SURMOUNT trials, I'd like to invite Dr. Amitabh Ashur. Amitabh, please take the stage and take us through how this medicine is helpful in people with simple obesity. And as a reminder, in view of West Bengal Medical Council, now the 30 CME credit points required. We have 3.5 credit point. The certificates are ready. So after the program, please collect it from our EKDG desk. We'll hand it over to you. Thank you.
So at the outset, thank you Shamit-da, thank you EKDGCon for giving me this opportunity, and thank you Eli Lilly. This is a sponsored session and I have been professionally hired from Eli Lilly for this session. So my job will be to present you with data from SURMOUNT trials, particularly SURMOUNT 1 and 4, how this new molecule, which is a dual agonist of GLP-1 and GIP, tirzepatide, can be helpful for our patients of obesity. This is the disclaimer about which I was telling you. So Mounjaro addresses some important biological adaptation of obesity. It's basically a GIP and GLP-1 receptor dual agonist. Just a second, there's some problem I think. Slide 3, slide 4, somehow slide 8 is coming. Okay. So Mounjaro is GIP and GLP-1 receptor dual agonist. By being a dual agonist, causing a dual agonism of GIP and GLP-1, it reduces appetite and calorie intake by increasing the feeling of satiety and decreasing feelings of hunger. It also reduces the intensity of craving and preferences for high sugar foods and high fat diet. The GIP receptor agonism, particularly at the level of adipocyte, leads to enhanced glucose uptake, and it also modulates the lipid uptake and lipolysis by binding to human adipocytes and activating the GIP-1 receptor. Through combined action of the GIP and GLP-1 receptor, Mounjaro lowers the body weight, resulting in greater fat mass loss than the lean mass loss. Mounjaro as a weight management was evaluated in robust clinical trial program involving some 5,000 participants. As you can see, the group of trials, SURMOUNT 1, SURMOUNT 2, SURMOUNT 3, SURMOUNT 4. In SURMOUNT 1, there was no active comparator. The tirzepatide was compared to placebo. So was in SURMOUNT 2. SURMOUNT 1 was in patients with obesity or overweight. SURMOUNT 2 was in patients with obesity, overweight, and type 2 diabetes. SURMOUNT 3 was compared to placebo with an intensive lifestyle program. Here also adults with obesity or overweight were taken, and in SURMOUNT 4, basically SURMOUNT 4 trial was done to see the response of drug once it is switched off. So it's very a common question which come to us, that how long we need to take the drug. So what will happen after stopping the drug? That answer came from the SURMOUNT 4 trial. So I will be discussing the SURMOUNT 1 and SURMOUNT 4 in particular. To begin with the SURMOUNT 1 trial, SURMOUNT-1 trial investigated role of tirzepatide 5, 10 and 15 milligram compared to placebo in adults with overweight or obesity with complication, but mind you, excluding diabetes. So none of them were having diabetes. Patients, this was a randomized double-blind placebo-controlled trial which was done across roughly 120 centers in 9 countries, in which around 2,500 patients participated. All of them were started with tirzepatide 2.5 milligram or placebo, and then up titrated to 5 milligram. One arm continued with 5 milligram, another arm it was up titrated to 10 milligram, and in the another arm, in the third arm actually, it was 15 milligram. So the co-primary outcome was mainly seen in those who were receiving tirzepatide 10 or 15 milligram. The predefined co-primary outcome was composite of percentage change in body weight from baseline at week 72 and percentage of population with weight reduction of more than 5% at week 72. So powerful weight reduction was seen, and importantly as soon as 4 weeks, and this weight reduction continued through 72 weeks with tirzepatide. So you see, percentage of body weight reduction compared to placebo was very, very significant. Up to 16% weight reduction was seen with just tirzepatide 5 milligram at the end of 72 weeks. And this was up to 22% in those who actually continued tirzepatide 15 milligram for 72 weeks. Also, patients with obesity experienced significant weight loss across all doses of tirzepatide. So as I mentioned, the average weight reduction, if you see by quantum of weight reduction, was approximately 16 kg in those who received tirzepatide 5 milligram, and it was around 24 kg for those who received tirzepatide 15 milligram. So at 10 milligram, it was around 22 kgs at the end of 72 weeks. Majority of patients with obesity achieved more than 10% weight reduction with tirzepatide 5 milligram. So if you see that patients, the percentage of patients who could show more than 5% weight reduction with tirzepatide was up to 90% with tirzepatide 5 milligram, and it was as high as 96% with tirzepatide 15 milligram. So you can comfortably say that 9 out of 10 patients who received tirzepatide 5 milligram could achieve more than 5% weight reduction, and you could also say that up to 75% of patients who received tirzepatide 5 milligram actually did show weight reduction of more than 10%. So as you know, clinically meaningful weight reduction start at 5%. So once a patient start losing 5%, as my previous speaker has already said, we start getting benefit, and benefits such as reversal of liver fibrosis in MASLD, etc. start when the patient loses 10% of body weight. In like pre-diabetes or diabetes reversal, or reversal is not a right word, remission also starts. Percentage probability starts once a patient loses more than 10% of body weight. So 10% reduction of body weight is highly significant. Now, more than 50% of participants actually crossed 20% weight loss barrier with tirzepatide, those who received 15 milligram. So 8 out of 10 patients who received 15 milligram tirzepatide actually could manage to lose more than 15% body weight. And 2 out of 3 patients, that is approximately 75%, rather 66%, could achieve more than 20% weight reduction with tirzepatide 15 milligram. So patients with obesity on tirzepatide experienced not just weight reduction, but also improved body composition. Treatment with tirzepatide was accompanied by greater reduction in the fat mass than in lean body mass, leading to an improvement in the body composition compared to placebo at the end of 72 weeks. This reduction was seen in total fat mass, in particular the visceral adiposity. So most of the total weight loss was attributable to reduction in the fat tissue, and that to visceral adiposity. By this I don't mean that there is no muscle loss, there will be some of it, but then majority will be from the fat mass only. So also we see a significant change in waist circumference, which is also a surrogate marker, kind of a cardiovascular risk marker. And we know that only weight or BMI does not matter, waist circumference also matter independently. So at 15 milligram tirzepatide dose, the waist circumference reduction was up to 19%, it's a humongous figure. But even if we talk about 5 milligram dose, even with tirzepatide 5 milligram, the waist circumference at the end of 72-week, reduction in waist circumference was up to 14%. That's also, I think, very, very significant. Also, apart from all this weight, BMI and waist circumference, we also see a lot of other changes. Systolic blood pressure came down by approximately 8 millimeter Hg, I think mainly because of the weight which came down. Diastolic blood pressure by approximately 5 millimeter Hg. Triglyceride reduction was seen up to 30%. HDL cholesterol went up by around 8% and LDL cholesterol came down by around 8%. Now, coming to a very, very common question which all of us encounter in our clinical practice. What happens if you discontinue Mounjaro? Because it's a costly molecule that at some point of time it has to be discontinued practically, although theoretically you can always argue that let us continue it because obesity is a disease and all, but that doesn't happen practically. So this SURMOUNT 4 was comparing the maximally tolerated dose of Mounjaro, which can be either 10 or 15 milligram. In this trial setting it was like that. So Mounjaro 10 or 15 based on which is the maximally tolerated dose for which particular patient was compared to placebo in participants with obesity or overweight with obesity related complication, but again mind you non-diabetic. So in this trial actually Mounjaro was started again like all other trial at 2.5 milligram. And then gradually on every 4 weeks, the dose was up titrated from 2.5 to 5, 7.5, 10, 12.5 like that. Subsequently, at the end of 20 weeks, they were divided into 10 or 15 milligram Mounjaro based on the tolerability of the patient. And then at 36 weeks, and it was continued from 20 to 36 weeks at the MTD, that is maximally tolerated dose. Now, what happened at 36 weeks? At 36 weeks, what happens is the patients were stopped on Mounjaro. In one arm, the Mounjaro was continued at maximally tolerated dose, 10 or 15 milligram, and in the placebo arm, it was actually stopped and replaced with placebo. So this particular trial then continued from 36 to 88 weeks. So from 36 to 88 week, the active arm received Mounjaro 10 or 15 milligram, whichever is the maximally tolerated dose for that patient, and the placebo arm received a placebo. Now, it was again a multi-center randomized double-blind trial with 800 patients. The primary endpoint was percentage of change in body weight from week 36 to week 88. So, after the first phase was over. Now, in this trial, it was shown that till week 36, the patient lost approximately 21% of their body weight at Mounjaro maximally tolerated dose. As you know, from 20 to 36 weeks, they were on the maximally tolerated dose. Now, this is quite expected and this we already know. Now, what happened after stopping Mounjaro in the placebo arm and continuing Mounjaro in the active arm? So, active arm was continued till 36 to 88 weeks and patients continued to lose weight. And at the end of 88 weeks, we saw that those who were on Mounjaro maximally tolerated dose, they had lost 26% of their body weight. Now, the placebo arm started regaining the body weight. But then how much they regained? At the end of 88 weeks, when the trial was stopped, the weight, a lot of weight was regained, but then still, those patients who were on placebo still were 10% less in their body weight from the baseline body weight at which they started. So the message is, even after discontinuation of Mounjaro, patients do regain body weight, but at the end of 88 weeks, the regaining process is not full, and the patients still have at least 10% body weight reduction from the baseline body weight from where they started. Now, we do not know what happened after 88 weeks because the trial was stopped after that. So, more than 7 out of 10 participants achieved more than 20% weight reduction in Mounjaro arm, those who were on maximally tolerated dose of Mounjaro, and 50% of patients could actually achieve more than 25% body weight reduction at the end of 88 weeks. That's a huge figure because more than 25% body weight reduction was earlier seen only with the bariatric surgery. Now, the message is, what could our imaginary patient Anjali could benefit or what she can gain out of the SURMOUNT data? Now, if Anjali takes tirzepatide in addition to reduced calorie diet and increased physical activity, she could potentially attain a weight reduction as early as 4 weeks. She can achieve significant and sustained weight loss of up to an average of 22%, and she can experience improvement in her cardiometabolic profile. Now, adverse effect, just like any other GLP-1 analog, the SURMOUNT-1 trial showed that tirzepatide also has some adverse effect, which were mostly GI in nature, like nausea, vomiting, diarrhea. They are the most common adverse effect. They are usually mild and they are usually limited, mild to moderate and limited. Gastrointestinal adverse effect primarily occur at the time of dose escalation. Okay, and the percentage of probability is around 24% for nausea, 25 to 18% for diarrhea, and somewhat around 16% for constipation and 8% for dyspepsia. Usually, this does not require drug discontinuation. Drug discontinuation is seen. So drug discontinuation rate is actually low. Drug discontinuation is seen in less than 5% of patients. Just a second, my slide somewhere went. Oh. Only 2-3 slides are there. এখান থেকে খুলে দাও, ম্যানুয়ালি খুলে দাও না, ম্যানুয়ালি খুলে দাও না। দু তিনটেই আছে। হ্যাঁ, ও স্লাইড চেঞ্জ হবে এখান থেকে, এখানে তো ডিসপ্লেতে আসছে না। ওকে, ইউ গিভ দ্য নেক্সট স্লাইড। ইটস নট রানিং ইন দ্য কম্পিউটার। ও এইটা, এইটা, দিস ওয়ান, ওকে। হ্যাঁ, এই অঞ্জলিটা খুলে দাও। হ্যাঁ, ওপেন করো। ওকে, ঠিক আছে। দাঁড়াও দাঁড়াও, এখানেই থাকো, এগোচ্ছে না তো। So okay, so I was at a discontinuation rate. হবে? The discontinuation rate is usually less than 5% in case of Mounjaro because of the GI side effect, and mostly that is because of GI side effect only. Discontinuation is not usually because of any other reason. In the trial, at least discontinuation was not because of the cost. So to summarize, tirzepatide significantly reduces body weight by an average of 16% with 5 milligram and 22% with 15 milligram. Improvement was demonstrated in cardiometabolic parameters in terms of blood pressure, weight, waist circumference, triglyceride and HDL cholesterol. And the most common adverse effect was GI, and that was mild to moderate, usually self-limiting. Thank you.
Thank you, Amitabh. Thank you very much. Now I'd like to call Dr. Sanjay Shah to take us through the same molecule in type 2 diabetic patients with obesity.
Okay, can I have my slides, please? Thank you very much to EKDGCon for inviting me. Thank you, Lily, for sponsoring it. And it's great to see Shomit in person after a long time. হচ্ছে না নাকি রে? কি এক্সটেম্পো বলে দিতে হবে? বলে দিই, এক্সটেম্পো একা হবে না, তোকে এখানে দাঁড়াতে হবে। We can just discuss. Sanjay Shah. So that's me a few years back, okay? And that's what I'm going to talk about, Surpass. We're going to look at how Mounjaro is going to perhaps chart a new course in the management of diabetes. And you've heard from Amitabh that weight reduction is also reasonably well with this molecule. So that's my disclaimer, as I've already mentioned, sponsored by Lilly. And I think Mounjaro at present has 2 indications where you can use it. On your left, you can see Mounjaro can be used, okay, as monotherapy in addition to lifestyle changes, so diet and exercise to improve glycemic control in adults with type 2 diabetes. And on your right, it's the chronic weight management, patients with a BMI of more than 30 and patients with BMI of more than 27 with a comorbidity, obesity-related comorbidity, then you can prescribe Mounjaro. Let's look at what it can do beyond glycemic control. Obviously, we'll focus on glycemic control as well. Now, according to the ADA and the EASD consensus report, and we've also heard a lot about type 2 diabetes, the damage occurs fairly early on. In fact, you start getting complications even before diabetes occurs, macrovascular complications. And early aggressive treatment perhaps is the name of the game. Okay? If we can do that, that would benefit a lot of our patients. So people with type 2 diabetes can especially benefit from early aggressive treatment. And on your left, how do we do that? Essentially, it is the obesity epidemic which is driving the diabetes epidemic. So if we can manage to help patients lose weight, and I think we've heard of the last few years, perhaps even a decade, how losing weight by 5 to 10% will help improve metabolic parameters, and anything more than 10% up to 15% would perhaps have disease-modifying effect and lead to remission of perhaps diabetes. So introducing Mounjaro, or once weekly, first-in-class GIP and GLP-1 receptor agonist. The molecule is only a single molecule which has essentially 2 ends largely. It is based on the native GIP sequence, and its receptor activity is very similar to the GIP receptor novo in terms of the native GIP hormone. And the GLP-1 receptor activity is a little bit lower compared to the native GLP-1 hormone. And the half-life, the mean half-life is about 5 days, so you can perhaps use the drug once a week. It has to be injected, so it's an injectable, and no dose adjustment is required for Mounjaro for patients with kidney disease or liver disease. Now, they've looked at, Eli Lilly has looked at the effect of Mounjaro through a comprehensive development program, looking at using this in different stages of type 2 diabetes. So patients with a duration of diabetes, perhaps about 5 years at one end to about 13 years at the other end. Okay, and what they have looked at or compared is, they've compared it against placebo. They've also compared it against semaglutide, which is Surpass-2, which we're going to talk more about. And then you compare it with insulin degludec, Surpass-3, glargine, Surpass-4, and in Surpass-5, they've actually added to basal insulin, which was glargine. So over here, it is comparing against glargine. This is on top of glargine, that is Surpass-5. So these are the studies that they have done from Surpass-1 to Surpass-5, and we'll look at how effective an anti-diabetic agent it is in terms of hemoglobin A1C reduction. And as I mentioned, if we could actually have a drug which addresses the obesity epidemic as well, which Dr. Amitabh Sur perhaps highlighted quite nicely, the effects of Mounjaro on in obesity as well. So body weight reductions across studies. So here you are. This is the placebo with a baseline A1C of nearly 8%. Okay, it manages to lower A1C by nearly 1.9 or 2%. So that's a very significant reduction in A1C. And in SURPASS-2, when you compare that to semaglutide 1 milligram, which is the top dose in terms of diabetes management, even the lowest dose of Mounjaro beats semaglutide. Okay, so you have a minus 2.1% roughly for 5 milligrams of Mounjaro, 2.37% for the same drug for 10 milligrams, and 2.46 for 15 milligrams. So tirzepatide actually fares better compared to semaglutide 1 milligram. Okay, so the lowest dose of tirzepatide does it as well. When you compare it to insulin degludec in SURPASS-3, you have again a very significant effect. In SURPASS-4, again a significant effect. This is versus glargine. And then on top of glargine as a basal insulin, again you have a very significant hemoglobin A1C reduction of upwards of 2%, even with the smallest dose of tirzepatide 5 milligrams. What about weight? So we've looked at hemoglobin A1C. This is what happens to weight. So this is the mean weight change from baseline. So this is in kilograms. It's not in percentage terms. It's in kilograms with patients with a BMI of about 31.9. Now 31.9 BMI would be roughly for an Indian patient 5 foot 7 inches, maybe it's just upwards of 90 kilograms, so 95 kilograms. So you would lose about 7 kilograms in weight with 5 milligram tirzepatide, and with 15 milligrams you will lose about 9.5 kilograms in weight. In SURPASS-2, compared to semaglutide, which helps you to lose about 6 kilograms in weight, 5 milligrams of tirzepatide beats it, so it is better. It lowers your body weight by nearly 7.8 kilograms, and the maximum dose of tirzepatide, 15 milligrams, roughly gives you double the weight loss. So while semaglutide 1 milligrams gives you 6 kilograms of weight loss, this one will give you 12 kilograms, upwards of 12 kilogram weight loss compared to semaglutide. With degludec, it's no-brainer really. You get weight gain with insulin. You get a significant weight loss with essentially tirzepatide. Similarly, with glargine as well, significant weight loss. And on top of glargine, when you use basically tirzepatide, again, you get a significant weight loss. So as Dr. Soor showed you very nicely, in terms of weight reduction of up to 16% or even 22%, diabetes patients don't lose that kind of weight because it becomes difficult for them to lose that kind of weight, but you do get a roughly 10% to 15% weight loss with the use of tirzepatide in patients with diabetes. So across SURPASS studies, if you look at a baseline BMI of less than 27 kilogram per meter square, you would still get a significant more than 5.6 kilo or 6 kilogram weight loss with the use of tirzepatide, and against placebo there with respect to SURPASS-2 semaglutide. So it is a better in terms of weight loss, 5.2 and 6.1. And so forth with respect to versus degludec, with versus glargine, and was on top of glargine as well. So whatever the BMI may be, slightly lower or fairly high BMI on right-hand side, BMI of more than 27 kilograms. So if you have a BMI which is higher, you do get more significant weight loss. Okay, so you get more significant weight loss with the use of tirzepatide in this group of patients as well, which is heartening to know because that's exactly what we want clinically for our patients with type 2 diabetes who are overweight. So superior hemoglobin A1C and weight reduction with Mounjaro versus semaglutide 1 milligram. This is essentially SURPASS-2, which I was perhaps mentioning. We'll look at it a little bit more detail. So 4 arms, okay, 5 milligram Monjaro, 10 milligram Monjaro, 15 milligram Monjaro, and semaglutide 1 milligram. So the 4 arms, and essentially basically the overall mean baseline A1C was 8.3%. The diabetes duration was upwards of 8.5 years, and a BMI baseline of 34 kilogram per meter square. And the primary endpoint was looking at mean change in A1C from baseline to week 40. And what did it show? What it showed was 5 milligram tirzepatide did better than semaglutide 1 milligram. So you get a significant reduction in A1C, and the higher dose of tirzepatide, you even had a much higher reduction in hemoglobin A1C. And look at the baseline A1C, 8.28, so roughly 8.3%. So 8.3% A1C, you can actually appreciate the reduction in A1C of about 2 or 2.5% with the use of tirzepatide, almost approaching sort of pre-diabetes or even patients in the non-diabetic range, the A1C. So you can achieve that. So all 3 doses of Monjaro led to a superior mean A1C reduction versus semaglutide 1 milligram. And this is how quickly it can do that, as you can see here. Okay, the solid lines are essentially tirzepatide. The broken dashed lines are essentially semaglutide. So Monjaro delivered significant A1C reductions from baseline over 40 weeks, with reductions observed as early as 4 weeks, that continued throughout the 40 weeks with the use of tirzepatide. What about the ability of tirzepatide in terms of achieving a reduction in A1C? Less than 7, less than 6.5, and less than 5%, 5.7. So this is almost normoglycemia. That's say the pre-diabetes, and that's say diabetes, if you look at it that way. And you can actually appreciate that compared to 1 milligram semaglutide, more patients would achieve an A1C of less than 7% with tirzepatide. Similarly, with an A1C of less than 6.5, and also in the non-diabetic range, you have an hemoglobin A1C of less than 5.7% in nearly 30% of your patients, okay, with 5 milligram tirzepatide, and nearly 50% of patients with 15 milligrams of tirzepatide. So a very effective molecule in terms of A1C reduction. And A1C reductions, if you compare it with the baseline A1Cs of less than 8.5, up to between 1.6 to 2% reduction in A1C. And if you have a higher A1C, and that is true for most anti-diabetic drugs, you even have much more pronounced effect in terms of hemoglobin A1C reduction. So every dose of Monjaro effectively lowered A1C, whether the baseline values was above or below an A1C of 8.5%. Superior weight reductions also was seen when you compare it with semaglutide. As you can see, 6.2 here, 7.8 with the lowest dose of Monjaro or tirzepatide. And you can have almost double the weight loss with 15 milligrams, the maximum dose. So all 3 doses of Monjaro led to superior weight loss, with Monjaro 15 milligrams delivering double the weight reduction of semaglutide 1 milligram in this study. What about Monjaro? Also provided weight loss compared with semaglutide 1 milligram. The mean weight change from baseline to 40 weeks, as you can see, the dashed lines being semaglutide, and the solid lines are largely, this is tirzepatide, and you can appreciate that Monjaro delivered significant weight reductions from baseline over 40 weeks, with reductions observed as early as 4 weeks that did not plateau over the study. So there was more to go, did not basically plateau. So you have to appreciate that perhaps these patients may even lose further weight as time went by. So more patients achieved a weight loss of more than 5% or more than 10%, more than 15% versus basically semaglutide 1 milligram. So compared to semaglutide 1 milligram, where only 58% patients lost more than 5% body weight, with 5 milligrams, that is the lowest dose of tirzepatide, 69% of them, and for 15 milligram, the maximum dose, 86%. 10% weight loss, there you are, those numbers are flashing on your screen, and with 15% weight loss. And that's the kind of weight loss we are talking about, remission of diabetes. And a large number of people with an A1C of less than 5.7%, as you saw in previous slides. So they were non-diabetic range. You could actually manage to do that with the tirzepatide as part of therapy. So SURPASS-2, this is Mounjaro versus semaglutide add-on to metformin is the study. And you can see that Mounjaro, 15 milligrams, helped nearly 3 times the number of patients achieve a composite endpoint of an A1C of less than 6.5, a weight loss of more than 10%, and no clinically significant or severe hypoglycemia. And the definition of hypoglycemia actually was less than 54 milligrams, okay? So this is the clinically significant hypoglycemia is what they largely talk about. Additional measures beyond A1C and weight, as we have seen with so many other GLP-1 receptor agonists as well. Reduction in triglycerides, again, more significantly reduced with the use of tirzepatide compared to semaglutide, as you can see. Okay, so fairly effective in lowering triglyceride levels, very effective again in terms of waist circumference. Okay, compared to baseline. So that is semaglutide for you, 5.6 centimeters. Even the lowest dose of tirzepatide in this study, 5 milligrams, okay, showed more waist, sort of waist circumference reduction, and with 15 centimeters, you had much more significant. So Mounjaro led to reductions in waist circumference. Perhaps it's a measure of a reduction of visceral fat, okay, waist circumference reduction. So again, something which we'd like to see in our patients when we use drugs to perhaps protect them from diabetes and diabetes-related complications. So you have a very powerful molecule in tirzepatide, no doubt about it. Nothing has been as good as it has in the past, okay, in terms of attaining weight reduction and in attaining hemoglobin A1C reduction. But with power, we need to also perhaps be reassured that it is reasonably safe, okay? Because with great power comes great responsibility. So it's a responsible thing to do. Okay, does this drug, or is this drug reasonably safe or not? And if you look at safety, there you are in terms of, because it's a GLP-1, it's an incretin-based therapy, GLP-1 GIP sort of analog. The GI symptoms are maximum. All GI-related adverse events are largely, these are the most important side effects: nausea, diarrhea, vomiting, dyspepsia, decreased appetite. That's perhaps it's the effect rather than a side effect, but anyway, constipation, abdominal pain. But if you compare with semaglutide, it's reasonably very similar, okay, reasonably very similar. So no huge difference, because these are both incretin-based therapies really. The discontinuation due to adverse events, again, slightly high with Mounjaro, more effective, but nothing alarming, as I would say. So most cases of nausea, vomiting, and diarrhea occurred during the dose escalation period in all groups that were used. And similar to perhaps semaglutide, Mounjaro 5, 10, or 15 milligrams, it takes a good few weeks, perhaps 15 weeks or 20 weeks, before the side effects of nausea or GI symptoms settle down. And it's true even for tirzepatide, as you can compare it with semaglutide. And the incidence of hypoglycemia, again, not alarming, but a hypoglycemia of less than 54, which I was mentioning. So severe hypoglycemia where somebody needs to rescue a patient. If you look at it, very sort of, just the one reported here, again, that was basically later suggested that perhaps that should not be counted, but you can appreciate that the hypoglycemia risk is very few and far between with respect to the use of tirzepatide in patients with type 2 diabetes. So in conclusion, from the SURPASS-2 study, in people with type 2 diabetes inadequately controlled on metformin monotherapy, once weekly tirzepatide, which is a dual GIP-GLP-1 receptor agonist, demonstrated superior and clinically meaningful improvements in glycemic control, significant reduction in body weight, an achievement of A1C reflecting normal glycemia in up to 51% of the participants. That's huge. Low risk of hypoglycemia, severe hypoglycemia, we should say, and faster time to glycemic and weight loss targets compared to semaglutide 1 milligram. So in summary, Mounjaro, based on the results of the 3 clinical trials, first and only approved single molecule GLP-1 GIP receptor agonist. If your baseline A1C is high, it can lower A1Cs by 2.6%, and it has the ability to help your patient lose up to 12.9 kilograms, so roughly about 13 or 14% weight loss. With those few words, I think I'll stop here. Thank you for your patient hearing.
Thank you, Sanjay. Have a seat. Can Shomobrata and Amitabh come up, please? Any questions, please? So I'll take a question. Before that, Shomobrata, the patient has come to you, ideal candidate. I had a similar patient last week, and I said to this lady, and she said, "Ore baba, pujor age to amar sona dana kena hoye jabe." I obviously refused after listening 17,000 per month. So how do you sell this wonderful benefits to the patient, taking into consideration the cost which is there at the back of the mind?
Well, I only discuss it with patients who perceive their obesity as a challenge. If they are mentally not acceptable, they do not accept, আমি তো বেশ আছি, গোলগাল আছি, শুকিয়ে শুকিয়ে যাচ্ছি না. That sort of a patient will not buy this. Those who are motivated have failed due to the paucity of drugs we had in our armamentarium, maybe was having orlistat unendingly. Those are the people whom I try and motivate. Of course, people with diabetes, I do add the flavor of HbA1c reduction. And once a week, rather than an insulin every day, yes, for some people who are corporate patients, is acceptable.
Yes, please.
I have 2 questions. First question is to Dr. Amitabh. What is the percentage of non-responders in tirzepatide? And second question is the issue of colonic ischemia in elderly patients, which is popping up and leading to ischemic colitis. As these molecules are new, very new, we haven't been using it. The safety norms are much more important while using this. So can you please tell us about the data?
Percentage of non-responder as per data at 5 milligram, it is less than 10%. And at 10 milligram, it is less than 3% actually non-responders. And regarding colonic ischemia, I'm not aware of this. I think
From whatever little I understand, it's few and far between really, but like any clinic, yeah. So as far as a clinician, you as a clinician are concerned, you need to be aware of it while treating your patient. But I wouldn't perhaps consider this molecule to be responsible for that disease, but maybe as a clinical judgment, you may have to relook at what therapies you want to give.
So there's 2 questions, I think. One, do you have a history of thyroid cancer? Do you have a past history of pancreatitis? Just like GLP-1, these are the 2 simple questions you need to ask before starting. Sanjay, is it fair to compare a 15 milligrams with a 1 milligram semaglutide? Because the one which is going to be launched is 2.4 milligram.
Yeah, I mean, is it fair? Well, everything is fair in love and war, okay? And this is war, technically speaking, Lilly versus Novo. That's how it is. Now, the fact remains in terms of the cost of care, which matters. So to my individual patient, as you asked Shomobrata quite rightly, will the 15 milligrams be value for money? And will the 2.4 milligram of Wegovy be value for money? Which one will be cheaper?
from whatever little I have understood, sort of multinational companies, I think there won't be much of a difference between the two, I would have thought. So it's take your call in terms of what works best for your patient. Really.
So any questions from the audience? Yes. Mike is there.
On this one remark that because it is a dual agonist, it does have an advantage of less hypoglycemia and other side effects. So tirzepatide does have a better advantage over that.
I mean, logically speaking, you're right. But again, in terms of what Sumit was trying to ask earlier on, because it's a molecule which perhaps got discovered later, perhaps it was more expensive to make as well. Because as time goes by, when you...
Another thing I wanted to ask, in the slides which I see, that the triglyceride value is coming down, the HDL is going up. HDL going up by any medicine is very rare. So does semaglutide have the same effect?
I think so. Semaglutide also has the same effect, but with tirzepatide, the effect is a little bit more. How does that translate to cardiovascular outcomes? Semaglutide has managed to show from the sustained 6 studies. I think they still have to show us if tirzepatide can do the same.
So from physiology point of view, GLP-1 has a GIP with it. GIP is predominantly an energy disposing factor. So you burn more energy, so you are supposed to get more improvement on those parameters. And that's one point of it. Amitabh, important point is, we have noticed from the data there is a discrepancy in the weight loss between those who are diabetic and non-diabetic. So for example, we are saying that here is a 5 milligram, 10 milligrams of tirzepatide, and this is the amount of weight loss that I'm expecting. But we are seeing a difference in diabetic and type 2 diabetic. So do you think our communication should reflect the same?
Yes, sir, probably yes. We should inform patient about that. The weight reduction in diabetes is less compared to those who are non-diabetic. One reason might be because of the drugs which the patient of diabetes are getting, which might be partially offsetting the effect of the molecule. That may be one of the reasons.
So we'd love more questions if you have, and please come back after lunch. We have a short session. We have 2 or 3 speakers, one from Guwahati. We need to respect their time also. But Sunday, I know I cannot force anyone. I don't like going out on Sundays, but if you can stay back, we'll be happy. And with one more question, there is a lot of flash in the newspaper and a lot of people are asking us about another Lilly product, orforglipron. It is oral and probably having a bioavailability better than the oral semaglutide. Now, apart from that, the Indian biosimilar companies have already approved for 3 milligrams of liraglutide, which probably will come in a few weeks' time. How do you see the picture of 3 milligram liraglutide vis-a-vis 2 months down the line, 2.4 Wegovy, vis-a-vis the one we have, Mounjaro? You have all the 3 now. How do you choose between them? Cost, if, as Sanjay say, cost, then majority will land up with 3 milligrams of liraglutide, but it's daily and probably will have a lesser impact. So how
I would just go back for a minute to your first, the question that you asked, Sanjay, that whether 1 milligram is fair or not. I think these trials, when they were started, semaglutide 2.4 was not approved for obesity, so it was not compared. But they have a Surmount 5 going on in Australia, the top lines of which have come out. I am not allowed to talk about it. So in a few days' time, we would also know head-to-head Wegovy versus, and it's A plus B versus only A. So you know the results perhaps in the deep of your mind. And I would say, I would say the Indian generics would flourish and perhaps the sales of the MNC would come down in the coming days. And not only that, March next year, perhaps the semaglutide also is going in for LOE, and it's not dose dependent. So you are going to have generic SEMA at 0.255, 1 and 1.7 and 2.4 coming in.
But I have a different take. Even if a low-cost generic comes into the market, the whole segment is going to grow. So even the MNC cell is going to grow. It's not going to go down.
Yeah, so my take, Sumit, is...
But one thing I'll tell you, I'm so happy today because the GLP-1 based therapy has surpassed the SGLT2, basically now. But we couldn't put the medicine on board because of cost factor, as you said, and side effects. Today I'm happy that I have a GLP-1 at the cost of an insulin to an oral GLP-1 to one which is GLP-G, I can give the entire spectrum. Probably most of your patient can now be on some form of GLP-1. So it's good to have generics.
So what I would say
sorry,
is...
biosimilars, not generic. Yeah.
What I would like to say is, at the end of it all, science wins. And GLP-1 physiology and the science behind GLP-1 has truly basically changed the way we look at diabetes and manage diabetes as well. So that's how.
So that's post-lunch, we'll be looking at how to marry insulin with a GLP-1, because once weekly, Kargi Sema and others are supposed to come. So thank you very much. A big round of applause for our panelists and the speakers. And hopefully see you after lunch. I'll be here.
দেখ তবুও যায়নি গো
I'm really thankful. I'm seeing a lot of people have stayed back after lunch. And one of our panelists have come, moderate is ready. 2 of the panelists are in the gate. We will not wait for 3 o'clock. We'll start early so that we'll leave you early. So just bear with us for 5 more minutes. They're just entering.
So welcome back to our seminar after the lunch. The first topic that we are going to discuss now is CKD and SGLT2. I think Dr. Binayak is there to chair this session. This is a very important session because we have been learning a lot of GLP-1 receptor agonist and dual agonist and all, but now is the time for coming back to SGLT2 inhibitor.
Thank you, Nirmala. I think that's a perfect way of introducing the situation because I think we are all much more comfortable using SGLT2 inhibitors than we are with GLP-1 analogs. And SGLT2 inhibitors maintain a huge place in the management of diabetes and its complication, as well as some role in the management of obesity. So, without further ado, it's my pleasure and privilege to welcome on this stage Dr. Dilip Kumar, consultant cardiologist. His CV is like, shining CV, as you can say. We also have Dr. Debmalo Shannal, close friend, colleague, and a brilliant endocrinologist. And as you can see, his CV almost falls off the screen. It's so large and so wonderful. We will also wait the arrival of Dr. Jayanto Basu. Again, Dr. Jayanto Basu doesn't need any introduction. He's probably the senior most nephrologist of the city, and I'm sure we will be having him on stage within a few minutes. So can we please have the slide, please? Okay, we'll move on. We'll maybe come to the case in a little while from now, but let's start off with Debmalo. One of the biggest things that we face while we see patients with diabetes is the concern for kidney disease. And I think this is real both for the patient as well as the physician. What is your strategy and what do you think is a well-defined strategy for screening for diabetic kidney disease?
That's very important because we see a lot of patients coming to us at pretty late stages, stage 3, stage 4 CKD when they are first detected. We have seen so many patients hospitalized with hypoglycemia with undetected advanced CKD. So it should be a dictum that for type 2 diabetes patients, we need to do screening from the word go when they are coming for just right after detection only. Because we need to do it with a creatinine along with an eGFR, and we need to also have the urine routine. I would also say a urine routine as well as ACR as well. And if the ACR is abnormal, we need to screen for the 2 at least, so that 2 out of 3 are abnormal. But at the same point of time, depending on the level of CKD, we may need to do more intensive follow-up depending on the level. With regards to type 1 diabetes, because they do not generally remain undetected, so for them it's after 5 years of detection we start the screening procedure, and that should be done at least once a year. The number of times we need to repeat these tests depend on the level of CKD, which is dictated not only by the eGFR, by the current KDIGO classification, it is also actually based on the ACR as well as the eGFR. So the worse is the GFR and the higher is the albuminuria, the more frequently we need to monitor as well. So that's very important because more important.
It's a nice little heat chart which has been published by
that's very important as well. And whenever we are diagnosing as well, we need to have that CKD, whether it is G2, G3, A, B, and also the albuminuria stage A1, A2, A3. If that is there, we will also be able to know what is the shift, and we can demonstrate that to the patient as well.
So I'll just give you some numbers, Debmalo. The reason why I'm giving you these numbers is just so that you can tell the audience what phase of renal disease this person would be. This person has a EGFR calculated on the mobile phone app of 38, and his urinary ACR is about 375 milligrams per gram. So what group would he fall into?
So, if you calculate the GFR based on the GFR level, the CKD stage, it would be G3B. I would say the worst stage is G5 when the GFR is below 15. 15 to 30 is G4. Between above that, we go up to 60, it's G3. G3B is from 45 to 30. So this person falls at G3B. When it comes to albuminuria, below 30 is A1, A2 is 30 to 299, and from 300 onwards it's A3, which was previously known as macroalbuminuria and microalbuminuria. So that's very important. So another reason why it is also very important is when we are choosing therapy at the beginning or when we are even adjusting medications, because a lot of diabetes medications, including SGLT2, depend on the GFR category as well.
Right. So I think that's a very clear understanding that, you need to classify kidney disease early, and the best ways of doing it is creatinine, and then use your phone app to calculate the EGFR, document it, document the urine ACR, and as the Mallo said, we must screen for diabetic kidney disease every...
Only few caveats for the urine ACR, urinary infection. That's why I generally do a urine routine to rule out any urinary infection, and would repeat it especially if the glucose is very uncontrolled and the blood pressure is very uncontrolled.
Okay. Now, Dr. Dilip Kumar, you obviously see people who have really advanced a little bit more, and these are people who have what we call the cardiorenal syndrome or the renocardiac syndrome. Could you just elucidate how rapid reduction of EGFR kind of is almost concurrently seen with advancing cardiac disease?
Yeah, so it's for a cardiologist, looking at GFR is very important. So once a patient hits our OPD and we see the patient is in heart failure, then we look at the GFR, and frankly speaking, the ACR recording in our cardiology OPD is not proper, and it's not up to the mark. We need to improve on that. But if someone has both the problems, if the patient has ACR of more than 30 and GFR which is less than 90, if it comes down 60-30, then chances of rapid decline in GFR corresponds very heavily with the adverse cardiovascular outcomes. So say someone has a GFR which is less 60 or 38 in this patient. Suppose his adverse cardiovascular outcome becomes more than 3 times. If he has ACR more than 30, so suppose in A2 stage of maybe 78, something like that, it's not going to be 2 or 4-fold, it is going to be exponential rise. So it will be something like 8 to 10-fold high risk of cardiovascular adverse outcome. So if both are involved, chances of cardiovascular adverse events will be very high. And there comes the role of all of us, cardiologists, nephrologists, endocrinologists, to see this patient and give proper attention. Because if the GFR and ACR both are deranged, there is a very rapid decline in cardiac function and adverse mortality from cardiovascular endpoints. Yeah.
Right. Thank you so much, Dr. Dilip Kumar. So essentially, the connection between kidney and heart is very well established. A worsening heart means a worsening kidney, and a worsening kidney means a worsening heart. May I have the pleasure of introducing Dr. Joyanto Basu, renowned nephrologist who has just joined us on stage. Could we have a very big hand for him? So, Joyanto, I will go directly to your question, which is, so now SGLT2 inhibitors after RAS blockade, first line treatment for CKD patients. Would you like to comment on the guidelines that we have now for the usage of SGLT2 inhibitors in CKD?
Yes, as you see, this SGLT2 inhibitor has been introduced as a cardiovascular outcome trial in EMPA-REG. And as a secondary outcome trial in that in 2015, we have seen that there is renal benefit in the form of decreasing the albuminuria as well as the decreasing the rate of renal decline, renal function decline. And following that, several trials have come which has particularly the DECLARE and CANVAS, they have these primary cardiovascular endpoints, but with the secondary endpoints of renal. And then the renal part, because of its beneficial effect, the renal part has come with the most important 3 trials. Those are CREDENCE for the first time with the canagliflozin, which has shown extreme benefit, particularly in diabetic patients, and that was followed by DAPA-CKD in 2020, which included not only the diabetic patients, but also the non-diabetic patients, and has shown the renal benefits in both these groups. And there, the starting point of treating those patients came as low as 25 milliliter per minute. You can start the SGLT2 inhibitor right from the from 60 till 25 milliliter of EGFR. And the then came the EMPA kidney trial, which showed extreme benefit both from the point of view of diabetics as well as non-diabetics. So when such a patient comes to us, particularly diabetics or non-diabetics, we see if the albuminuria is more than 30 or A2, then you can start this particular drug. And if there is, because as he has said, that albuminuria and the decline of GFR as estimated by EGFR is not present in all the patients. It is particularly 50% of patients, they don't have any albuminuria, but there is the decline of GFR in the form of EGFR less than 60, less than 40, less than 30, less than 20. And there you can start this SGLT2 immediately, provided there are certain contraindications, particularly the diabetic ketoacidosis, genital infections, and patients suffering from ADPDK. And when the patient goes into renal dialysis, as well as when the patient is transplanted, then we have to stop, or studies are going on, particularly in renal transplant, and we'll see to it. So
Jayanta, just interrupting you for a second. So is there any need to rule out any other form of kidney disease before we start the SGLT2 inhibitors?
No, these, the DAPA-CKD particularly, when they started with the non-CKD, non-diabetic population, they had included the IgA as well as the FSGS patients, and hypertension is almost always this particular.
As of now, we would say that anybody with any degree of albuminuria or any kind of creatinine would be a candidate.
This would be a foundational therapy for all these patients.
Foundational therapy till EGFR of?
Till EGFR of 25 in DAPA-CKD, till EGFR of 20 in EMPA-CKD.
Right. Do you foresee that this will go down further? And
yes, there are studies where they are showing that it is going further, and we can start at the very advanced CKD5 and before starting the renal replacement therapy.
Thank you, Jayanta. Just one question. What is the safety guidance in CKD when you are using a SGLT2 inhibitor?
Safety guidance, these patients, particularly when they suffer from old age, when they are dehydrated, when they have got sepsis, when they have got ketoacidosis, these are the patients that we avoid treating these patients with SGLT2
So
inhibitors.
do we, initially when we are starting these patients on SGLT2 inhibitors, it is necessary that we counsel them that's kind of like for endocrinologists, we have sick day rules. When,
Yes.
which kind of, should we start off with
These
that?
are the sick day rules that we usually see when you assess, when the patient comes, we assess the patient in that way. We see that what is his fluid status, dehydration, infection, particularly in the old age, and the blood pressure status as well.
Thank you, Jantada. We'll go to Dr. Dilip Kumar, and we will kind of talk of the discussion has moved on to volume status. Now, particularly for heart failure, I think however much we try and bring diuretics into disrepute, we cannot disregard its use, particularly in acute heart failure and thereafter also. So what is your position on diuretics being used with SGLT2 inhibitors?
So, patient with heart failure, the first priority is to get rid of excess water. And if the patient is admitted with acute decompensation, we start with loop diuretics. We see the congestion is over, the patient is maintaining oxygenation, and then we are getting away with inotropes and all. Then we start SGLT2 inhibitors. But even then, the patient comes in follow-up, we have to be very careful about the hydration status of these patients. Those patients who are elderly, not taking properly, they can have a kind of, this shifts the volume more favorably than the loop diuretics, but still there is a caution. So what happens with the SGLT2 inhibitors is they act on the proximal tubule. Unlike what loop diuretics, they act on the ascending loop of Henle. And the loop diuretics act on the sodium reabsorption, and with that sodium, potassium, the excess water is flushed out. But SGLT2 inhibitors act with sodium and glucose co-transporter, and here the shift of volume is very, very kind of benign and a little slower. And once the excess volume is released and removed, there is a shifting of volume from interstitial spaces, something like pulmonary edema, edematous tissue. From there, the fluid volume comes out and gets into the intravascular volume. So what we call with SGLT2 inhibitors, there's a shift of volume from extravascular to intravascular, and we get rid of this high, excess volume. So although a little, it acts basically with removing glucose, excess glucose, little, and the sodium and excess of kind of water is released. It's very controlled. But even then, we have to put a little brake on those patients who are dry, those patients who are losing weight more than 1 kg in very short span of time. So suppose a patient complains that I am shrinking, my body weight is a week back it was 80, now it is 75. Then we have to be a little careful. We have to get rid of loop diuretics if it was going, and we can also come down on SGLT2 inhibitors. So these are some important aspects of fluid status and how SGLT2 inhibitors work, and how to be careful about entire exercise.
Right. I will go to both Joyantada and Debmallo. Urinary tract infection, history of urinary tract infection. Is that a contraindication to usage of SGLT2 inhibitors?
No, it's not. Particularly when there is a lower tract infection and when there is few infections, then after the infections get controlled, then we can restart the SGLT2. But if the person is having a recurrent, and when there is an ascending infection, particularly in the form of pyelonephritis, we dare not to get this.
No, but will we restart?
When there is a lower urinary, particularly the bladder infection.
So if somebody has an episode of acute pyelonephritis, SGLT2 inhibitors is a no-no?
I'm a little bit scared doing so.
Right. Debmallo, would you like to differ?
Yeah, I also wouldn't be very keen to start a patient who is have acute pyelonephritis. Lower urinary tract infection, it's fine.
No, I'm talking of somebody who's had a history of acute pyelonephritis. I had a history of acute pyelonephritis in the year 2016. Will you give me a SGLT2 inhibitor?
Well, I would be definitely skeptical.
But there is no evidence. This is what I'm trying to tell both you and Joyantuda. There is no evidence of an increased risk of UTI with SGLT2 inhibitors.
But if you see, there was this one trial is there, the CVOT, Vertis CV, which actually showed an increased risk of UTI. With
yes, I agree.
That was one trial. But in practice, we do get increased UTIs as well. And lot of times we have, at least I personally have seen, because we sometimes don't question, we always ask for fever and burning sensation, but sometimes some of the like increased frequency of micturition, these are the symptoms which a lot of times people don't speak up. So you need to inquire whether they have features of UTIs. Second is, even if they have increased number of pustules, then you need to talk about that. And lot of times there are reversible causes. Like for men, it's okay, BHP, but in lot of times we also get autonomic neuropathy, the cystopathy is also there. So there, if we address in some of them, we actually do restart as well. If there is a reversible cause which can be potentially reversed. But if it is an upper urinary tract infection, a pyelonephritis, it's difficult, because we have seen patients, even for restarting again, going back to sepsis. Yeah. So that risk is there. So would be very reluctant to start in those group of patients. And especially now we have the alternatives. We have the alternatives for renocardiac protection as well. We can give them the alternative renocardiac protection. But there are very small groups. If you just look at pyelonephritis per se, that numbers will be very less, not many. Or urosepsis per se, that numbers will not be very many.
Right. But let's just put this to the audience. We've got about 7 to 8 minutes left, and that time is almost entirely for audience interaction. After I asked Debmallo a final question, saying that we've discussed UTI, and I think both the nephrologist and the endocrinologist are on the same page. What about genital fungal infection? Will you restart?
Definitely. I generally restart always. And after most of the time, it's local application of antifungal. Sometimes they require orals. Sometimes they require brief interruption, not long term, and we can again restart them. Unless, of course, it's a Fournier's gangrene, then we need to be careful. But that's very rare. But for almost all cases, we generally restart. And again, a lot of patients we find, especially in men, then phimosis has to be excluded as well. So in a lot of patients, once we have seen so many patients having undergone treatment, surgery, circumcision, and then they are again restarted back on, like a patient who is having heart failure, CKD. If they are done with the surgery, we can again restart them back. So obviously for GUIs, most of the time we definitely restart.
So I think the positives so far outweigh the negatives that there's got to be a real strong reason not to give an SGLT2 inhibitors. And as in one day I was in a meeting, and one of the speakers very interestingly said that it's so good that you almost need to mix it in tap water. So that is the kind of evidence that you have with SGLT2 inhibitors. The last few minutes of this program have been specially designed for questions and answers. Ladies and gentlemen, the floor is yours. You can ask any question you have. Nirmalanda.
Recurrent UTI, this is the point which is often asked by many of us. Now, how do you define recurrent UTI? Is there any definitive definition for that? Or it's conjectural kind of?
No, generally it is 3 or more UTIs per year. So that's the general definition which we are generally accustomed to with recurrent UTIs. And this is particularly more commonly seen, I would say, in elderly women who have recurrent UTIs. There are a subset of women, elderly women, who are more prone to recurrent UTIs. A lot of times they have underlying gynecological issues like a prolapse. That can be addressed and reversed as well. So there we can again restart back. Again, renal calculi is another thing which we need to rule out as well, because that can also be an important cause.
So if I come in here, like sir described a patient, like he had a pyelonephritis in 2016. Now we are seeing with heart failure. There could be some local reason for that pyelonephritis in 2016, and now the patient is presented without such local factor. So there should be no harm in giving SL2 inhibitors and look at the positive prognosis.
I totally agree with you.
But someone who has pyelonephritis on SL2 inhibitors, then this could be the reason, and then going after again SL2 reintroduction could be, not a welcome step.
So, yes, sir.
May I ask him a question?
Yes.
What about SGLT2? Because every day we are facing this problem in the ICUs. What about the SGLT2? You know that this is being treated for the chronic heart failure. What about acute heart failure in ICUs? SGLT2 role?
Sir, we have good trials where acute decompensated heart failure we have to start before the patient is discharged. But my practice is if I see the patient is out of inotropes and loop diuretics, I ensure that patient, the Foley's catheter is out 24 hours, then I start SL2 inhibitors in these patients. But the only one condition where we don't give is post-acute myocardial infarction. So there was an IMPACT-MI trial. This was one negative trial with the SL2 inhibitors. I think that is the only one trial which could not meet its primary endpoints. Rest all trials with decompensation or chronic heart failure, SGLT trials were positive.
And
so
if
acute
I'm not
MI,
wrong,
we are not going to start.
If I'm not wrong, Debanlo, there was a similar trial with dapagliflozin which showed the same result.
Same result. And there was another trial which showed starting dapagliflozin in acute settings, in critical care patients. That also did not improve the outcome. Probably the only area where there is a benefit in acute settings, especially at discharge also, especially which prevents readmission after discharge, is hospitalization for heart failure. That's the only setting where, otherwise we need to stabilize and then start this as well.
Any questions from the audience? Because I have a question for Joyantuda. Yes.
No, this is an urinary tract infection or genital infection. In recurrent, we don't use it. Yes.
So, Parthoda. Mike.
So, as Dr. Basu mentioned that we should use SGLT2 inhibitor in chronic kidney disease, maybe in form of albuminuria or low EGFR. I want to know if you see any patient with type 1 diabetes with DKD, would you start SGLT2 inhibitor?
No, SGLT2 inhibitor we are not using in type 1 diabetes.
Right.
Okay, Borunda.
With the use of the dapagliflozin, recurrent.
Yeah, we have used slowly of the patient.
Circumcision?
Yes.
Yeah, we have used after circumcision, we have restarted back.
After circumcision, you can use it.
Restart, yeah. I'll come to my question. I'm being a little selfish out here. But Joyantuda, we tend to have this in this day and age of having packages of reports. You sometimes get people coming in who are completely asymptomatic. But they will say in the report, pus cells 10 to 15 and E. coli greater than 10 to the power of 5 with a huge antibiogram. My question to you, two things. Patient is completely asymptomatic. Do we start SGLT2 inhibitors? Do we treat this UTI?
No, we do not treat this UTI. This is asymptomatic bacteriuria. And present day situation is, unless the patient is symptomatic, we don't treat this. But often the background is also looked for. If the patient is immunocompromised, if the patient is diabetic, then we can reconsider this. And what had been the...
Starting an SGLT2 inhibitor in this patient?
No, there is no question for starting the SGLT2
Is that you saying it for, safe medicine, or is that because,
Because there is no such trials that could give you this.
Okay.
We can recheck.
Yeah, that we always do.
One thing, what about the present data in adult polycystic kidney? SGLT2 and adult polycystic?
Still not. We are not using them. This is not being used. Not hereditary.
No, there's no
If there is no evidence of UTI, then we are.
Okay, we'll go to the next question.
Actually,
That's the last question. You can ask the specialist to.
This question is primarily for Professor Dr. Jayanta Bose, sir. We have actually 4 class of drugs to address the nephropathy issue. Cilnidipine, we have the RAS blockers, we have fidarinone, and we have the SGLT2 inhibitors. How will you grade them, or is there any recommendation or study, or as far as your clinical experience is concerned, sequentially or in combination, how will you grade them, or how should we start?
Still now, we don't have that sort of sequential pillar therapy like heart failure. But as things are coming in sequence from the very beginning, say SE inhibitors, ARBs in 93s, and SGLT2, we are using this in that particular fashion, and particularly the MRA. The first 2 drugs that we always use is the SE inhibitor ARBs and then SGLT2. If there is any contraindication for SGLT2 and if the proteinuria is very great and this is not being controlled, then we go for the finerenone or the MRAs. And the present FIND studies has given us an extreme hope that we can combine the SGLT2 with GLP-1 agonist. And I have started many patients of mine with obesity, CKD, and diabetics or non-diabetics with 4 drugs, giving an extreme good results, particularly in weight reduction and improving the cardiovascular and the renal outcomes in those patients. These are quite early, I shouldn't say, but I am getting an extremely good results because of their weight reduction, proteinuria reduction, as well as the reduction in the sort of renal functional decline.
Thank you very much, everybody. And the real success of a panel discussion is the questions from the audience. You've made it successful with so many questions. Thank you to the panelists. Thank you very much, everybody.
So, thank you, Dr. Sina, and thank you all the panelists for a wonderful session, very erudite session. Now the last session is coming up, and it's anti-diabetic related program can be complete without insulin. Now we are having once weekly insulin in the horizon, and also we are using co-formulations. May I ask Dr. P.S. Mondol to come and chair the session and take the session on.
Good afternoon. Before lunch, we had a nice discussion on GLP-1 receptor agonist and also the dual agonist, and we understand their importance in the management of type 2 diabetes. They provide cardiovascular benefit and all benefit. Now, from those discussions, it appears to us that probably insulin losing its importance in the management of type 2 diabetes, but still significant number of type 2 diabetic subjects, they require insulin to achieve good glycemic control and to maintain that good glycemic control. There is no debate about that. Now, when you talk about insulin initiation, we can initiate with any one of these, the basal insulin, premix, co-formulation, but it is always easy to initiate with basal insulin that is very much safe, effective, and also very scientific. Now, we have 3 good basal insulin. All of you know that insulin degludec, insulin glargine 300 and glargine 100 IU. Now we have been waiting eagerly for another basal insulin which can be given once a week, and definitely that will improve the adherence to the patient, for the patient, and that will improve the compliance, and definitely that will have a huge impact on the HbA1c reduction. But whenever we have any new molecule, we need to compare with the previous existing molecules, whether that has got really any significant benefit, and we also need to know what are the drawbacks of the new molecule. Now, we have this insulin degludec, which can be given once a week due to its pharmacokinetic property. And today we have Dr. Supratik Bhattacharya. I think he doesn't require any introduction. He's a brilliant speaker. And Supratik will be talking on this once weekly insulin, that what the value does it add to existing insulin initiation strategies. So Pratik, over to you.
Thank you, Parthoda, for all your kind words of introduction, and a warm welcome to all of you. Thank you, Dr. Samit Ghoshal, and the entire team, EKDGCon 25, for this invitation. My disclaimer is I had been contacted by Novo for this particular session, and I'm going to talk about something which is very exciting, but it's future. So we don't have immediate access to the insulin that we are talking about, but it's just a relief to know that we have something in our armamentarium which is going to be causing a great deal of, help to the patients that we cater to. So advancements in glycemic management and exploring the newer generation insulin. We know that we completed about 100 years of insulin, and it started with Banting and Best isolating insulin back in 1920, and then you have the first generation insulins and the true basal insulin U100 glargine. And now even the half-life changed from 5 to 10 hours to about 12 to 19 hours with U100 glargine. And then finally, we have the second generation basal insulins that we are using now, like degludec, which have a half-life of more than 25 hours. So conveniently, you can use it up to 36 hours. Variability, again, very flat profile. Very less variability with the newer generation or the second generation insulins like degludec, and hence the chances of hypoglycemia is also a rarity. Only concern is the person has to take a single prick every single day, and that means that you have about 7 pricks a week and almost 30 pricks a month. So what if we had something which can cater to that and give you the convenience of once weekly therapy, just like we have the once weekly GLP-1 receptor analogs, which can be given every Sunday. So I think that's going to be a big relief to our patients, because initially there is a fear of initiation of insulin to begin with, and then the fear of pricking themselves. So if the prick is reduced from 7 times a week to just once a week, I think that's going to significantly improve the chances of a patient being on board with injectables like insulin. So less frequent injections, simple to use regimens, and flexibility of dosing. These are the highlights of the newer therapies that we are going to talk about. And obviously, less frequent injections means that the adherence is going to be theoretically improved. The convenience of the patient is also going to be improved, and overall, the satisfaction of the patient with the injectable therapy is going to be improved. So what about this icodec? Now, icodec precursor was expressed in Saccharomyces cerevisiae as a single chain with a mini C-peptide which joins the B chain and the A chain. Now, after purification, what happens is a single chain precursor was enzymatically converted into two insulin chains, and there were modifications in both the A chain at amino acid 14 and the B chain at amino acid 16 and 25H. And it was chemically modified by coupling something fancy called N-hydroxysuccinamide activated side chain to epsilon amino group of the B chain 29 lysine. And what happened? With this, we got a few favorable outcomes, like there was a strong reversible binding of albumin together with reduced insulin receptor affinity to slow down clearance. It also ensures that the insulin icodec forms a circulating albumin-bound depot, which is essentially inactive, and from which the insulin icodec can slowly and consistently activate the insulin receptors, resulting in a long half-life suitable for once-weekly therapy. So the half-life of insulin degludec is 196 hours, and it has got a very effective glucose-lowering effect, and hence, because of the longer half-life, we can give it once weekly. So low insulin receptor binding affinity, improved stability, high solubility, slow receptor-mediated clearance, and strong reversible binding to albumin. So these are the changes that were brought to the insulin to make it once weekly versus once daily. So hexamers, which are formed, dissociate in monomers to bind to albumin, and it forms an inactive depot, and a fraction of this insulin reaches the insulin receptor at the target tissues. So not all at the same time, and that prolongs the action. Now, if you look at the PK profiles at various concentrations, there was no difference at all. Now, near even distribution within the dosing interval. So if you look throughout the week, starting from day 1 through to day 7, there was absolute even distribution without any highs or lows. If you look at the solubility, because this is concentrated insulin, so the dose that you're using is very similar to the once daily dose, so the volume doesn't change at all. So, so that ensures that you're not having to inject a whole lot of volume in one go. So that is also very convenient. And then we have the data, the RCTs to back up the use in type 2 diabetic patients called the ONWARDS trials. Now, the ONWARDS are from 1 through to 6, where, insulin icodec or once weekly insulin was compared to various basal insulins. Say, for example, ONWARDS 1, it was compared to U100 glargine. There was a switch study in ONWARDS 2, where, insulin degludec was switched to icodec. Then you have an active comparator study in ONWARDS 3, where degludec was compared to icodec, so on and so forth. So we do have a fair number of studies which had patients from India recruited, say, for example, ONWARDS 1, ONWARDS 4, and ONWARDS 6. So we have a fair amount of data coming in from India as well. So we have seen the use of icodec used in type 2 diabetes, in type 1 diabetes. We have done CGM-based studies. So all sorts of studies were done. But today I'm going to highlight about the ONWARDS 1. In this particular study, those were naive to insulin and type 2 diabetic were recruited for the study. They were on various OADs, GLP-1 receptor analogs. By default, they had to be more than 18 years with the HbA1c at baseline between 7 and 11. And what happened? You had two arms. One arm had icodec plus non-insulin glucose-lowering agents, or the OHAs or GLP-1 receptor analogs. The other arm had U100 glargine, which is used to be the gold standard basal insulin earlier. And the primary endpoint that we were looking into was the HbA1c lowering, but we also looked into certain secondary endpoints as well. Say, for example, what happens to the time in range towards the end of the study, between 48 weeks and 52 weeks. So 52 weeks was the end of the study, and then there was a follow-up period as well. We also looked into the incidences of hypoglycemia. So what came out from this 52-week long study was that there was superior efficacy with icodec versus U100 glargine in terms of A1C reduction. So you can see end of trial, A1C at baseline, which was around 8.5, came down to 6.9 with icodec and 7.1 with U100 glargine. So almost a difference of around 0.2%. But more importantly, we looked into the time in range. So we're gradually moving away from long-term variability outcomes like HbA1c, and we are talking about time in range more often. So if you look at the time in range, which is defined as the sugar staying between 70 and 180 milligrams per deciliter, that significantly improved. So what happened, there was almost a 5% difference at the end of the study between 48 and 52 hours. And you can see in here the time in range was 71.9% with icodec versus 66.9% with insulin U100 glargine. More patients reached A1C of less than 7%. So if you look at the various guidelines, less than 7% A1C is a good target. And if you can achieve that safely without any hypoglycemia, that means you have done your job. So almost 57.6% in the icodec group reached A1C of less than 7% versus 45% in the U100 arm. And if you look at the main plus the extension phase, again, around 57% in the icodec arm achieved A1C of less than 7% versus 49% in the U100 glargine arm. More importantly, we are concerned about the hypoglycemia as well. So it doesn't matter how you get there. I mean, it doesn't matter whether you have achieved a A1C of less than 7% or not, but have you done that without causing hypoglycemia to the patient? So that is very, very important to us as clinicians. And it seems that almost 53% of the patients in the icodec arm reached the target A1C of less than 7% without hypoglycemia as compared to those in the U100 glargine arm. So the incidence of hypoglycemia was very less than one event per year, and comparable duration of CGM-derived hypoglycemic episodes during all times periods. So what are the highlights and the strong pointers about once-weekly insulin, icodec? It's easy to initiate because whenever we're talking about injectable therapies, there is a strong resistance from the patients because they're thinking about daily pricks, they're thinking about the inconvenience. So that gets mitigated when they hear that it's going to be once-a-week therapy. So it's going to be much easier for you to convince your patients. Also, we are having a better safety outcomes as compared to likes of U100 glargine. The short-term variability studies or the CGM-based studies show that you have a better time in range, significant better time in range with icodec versus U100 glargine. And so now coming to the practicalities, how to initiate. So a starting dose of 10 units, what we usually use for the conventional basal insulins, corresponds to about 70 units once weekly for icodec. So you just have to multiply by 7. Okay? So when you initiate with 70 units IU and then look at the fasting levels. If the fasting is more than 130, then you go up by 20 units, just like you would. 2 units for the conventional basal units. You go up by 20 units, and if down titrate, you go down by 20 units. Okay? If it is between 80 and 130, then no change is required. So this is an AI-generated, ChatGPT-generated summary of whatever we had been talking about. If you want to take a photo, this gives you a quick snapshot about the entire presentation that I give, and highlighting all the pointers about, whether we're talking about the molecular design, mechanism, clinical implications, pharmacokinetics, etc., and the biological activity. So just looking at this slide, you got the entire gist of my talk. Yeah. So key takeaways: convenience, reduced pricks, efficacy, matching with any other basal insulin, and getting to the targets safely without any concerns of hypoglycemia, and the convenience. And along with that comes a platform called Mishti, where you can refer your patients and they will give you a virtual support to the patients, and you can do that by just scanning this QR code, and you'll be signposted to one of your counselors who would be counseling all your patients virtually via this Mishti app. So with this, thank you, and if you have any questions.
Thank you, Subhadik. We can take the questions at the end of second speaker finishes. Okay, Subhadik, you can take a seat here. No problem. Now, I already mentioned that we can initiate insulin treatment with co-formulation. All of you know that co-formulation. There's the Ryzodec. It has the two insulins. 30% is the insulin aspart and 70% is insulin degludec. There's the Ryzodec. We can initiate with this Ryzodec, and whenever we initiate insulin, we have the three steps. One is the initiation, then optimization, and intensification. We can go all these three steps with this insulin Ryzodec. We have Dr. Nilaksi Deka. She's from Guwahati. She's a brilliant speaker. You can see her CV here, and I will invite Dr. Deka to talk on initiation and intensifying with insulin co-formulation, a simple strategy. Dr. Deka, over to you.
Thank you so much, Chairperson, for that kind introduction. And Supratik has made my job easy. Thanks to the organizers for giving me this opportunity to be addressing this August gathering today here in EKDGCon. A very warm good afternoon to everyone, though I shouldn't say warm because of the heat outside. Maybe a very cool good afternoon. So as the chairperson has introduced the topic, mine is a simple topic, not futuristic. It has been with us for the past decade. It is intensifying an initiation with insulin co-formulation, that is the IDAG-ASP co-formulation, which is insulin aspart and insulin degludec together as separate molecule in the same pen, Ryzodec. So in our agenda, we have diabetes challenges and the unmet needs in India, how Ryzodec serves as an innovation for our diabetic patients, and evidences that are there, the current evidences for insulin initiation with Ryzodec, the switch from basal insulin or other premix insulin to Ryzodec, and finally intensification with Ryzodec as the patient progresses into diabetes. So we know there's an alarming state of diabetes in India with 136 million people living with pre-diabetes, 100 million people with diabetes. 8 out of 10 have uncontrolled hyperglycemia. In India, though there is a lot of awareness about insulin, yet we are still quite away from the HbA1c target. Most of the patients are quite away from the HbA1c target that we should be having. And unfortunately, insulin is initiated quite late in our country, around approximately 8.8 years after the diagnosis of diabetes. We also have certain challenges related to diet because we have a very high carbohydrate diet. Almost 64% of the energy intake, if not less, if not more, is through carbohydrate. We also have a very sedentary lifestyle. 1 in 3 patients follow the advice to diet, exercise. In fact, so much so that it is sometimes the nutritionists, they face frustration and desperation in the sense that when the patient comes back the next time, they keep repeating the same questions, but they don't follow. Their HbA1cs do not show any control, and every time they come back, oh, we shouldn't be taking jaggery, is it? Okay, we cannot be having bananas. And they'll be asking all these questions repeatedly. So whatever they listen, when the nutritionist or the dietitian is speaking, they don't register that in their mind, or they tend to overlook. We also, as Indians, have unique physiological peculiarities in the sense that we are thin fat Indians, in the sense that we may have a normal BMI, yet the abdominal obesity is quite high in our country. Also, we as Indians develop diabetes almost a decade earlier than our Western counterparts. We are more prone to develop cardiovascular disease. We progress faster from pre-diabetes to diabetes. We have high levels of abdominal fat. We also have high insulin resistance even at lower BMI. So we may appear thin, but the insulin resistance which we harbor is quite high. And also there is a early and rapid beta cell dysfunction in Indians. We have a slower insulin secretory response, more of insulin resistance at the same time. The postprandial glucose peaks in Indians are almost 2 to 3 times greater than that of the Caucasians. It is related to our unique physiology and also the diet which contributes or exacerbates the postprandial glycemic peaks. Hence, our requirement as Indians is different from the requirement of the Caucasians. So we are not at the same platform. We have unique challenges which is different from our Western counterparts. And the guidelines suggested by Western counterparts or the kind of insulin suggested by Western counterparts may not act the same or may not be the same for Indian population because of our unique physiology and because of the completely opposite diet which we consume in our country compared to our Western counterparts. The impact survey showed that 9 out of 10 HCPs preferred an insulin therapy that would cover both the fasting as well as PPG. So we want a single prick which would control both the fasting and the PPG. That would make our job so easy of convincing the patient to take insulin just once a day. And we all know how much difficulties we face while trying to convince the patient for insulin initiation on the first go. So if we have a kind of insulin which would target not only the fasting blood plasma glucose, but also if we could have something which could control both the fasting and the PPG, that would be great. And this unique requirement is served by Rhizodec, which is a co-formulation of insulin aspart and insulin digludec. So when these exist as individual IDAC dihexamers and aspart hexamers, when they are injected into the subcutaneous space, the aspart is released, aspart monomers are released rapidly, whereas the digludec dihexamers, they again form chains to form larger multihexamers which are released slowly. That leads to the slow and the peakless kind of insulin action of insulin digludec. So we have rapid acting insulin aspart which is released as soon as we take the injection, and then we have insulin digludec which is released over a period of time, and that serves to control the fasting plasma glucose, serves the basal insulin requirements which an individual has. So this insulin is also recommended by our Indian guidelines. The RSSDI clinical practice recommendations of 2022 says that we could use IDAC-AS for initiation in individual compared to insulin, other insulin, basal insulin. So this could be used for initiation also, rather than using a basal insulin alone, which will control the fasting but would have no action or would have limited action over the postprandial glycemic excursions which occur. Now, having said about the unique challenges of diabetes in India, about Rhizodec, which is an innovation where it is a co-formulation of short-acting insulin that would take care of the postprandial peaks, and a ultra-long-acting insulin, digludec, which would take care of the fasting plasma glucose or give us the basal insulin requirement which we have as individuals of type 2 diabetes. We will now look into the evidences that are there to support Rhizodec at initiation, to support the use of Rhizodec for switching over from one kind of insulin regimen to the other, and for using Rhizodec as an intensification over once daily to twice daily insulin used for intensification. Let us go through the initiation evidence for Rhizodec. Now, in this study, which was published with 296 patients, insulin naive patients with type 2 diabetes were given either Rhizodec with once a day with oral hypoglycemic agents, and in the other arm they were given insulin glargine 100, which is a basal insulin along with oral hypoglycemic agents. And this was an open label study carried out over a period of 26 weeks. And what did they see at week 26? That the HbA1c achieved was superior compared to that achieved with insulin glargine. The total daily dose of insulin required was similar in insulin glargine with plus OAD plus insulin Rhizodec used as initiation with OADs. The confirmed hypoglycemia and nocturnal confirmed hypoglycemia were lower compared to the basal insulin glargine with OAD group. So that was HbA1c which was achieved greater than that of basal insulin at the cost of lesser episodes of hypoglycemia, both confirmed hypoglycemia as well as nocturnal hypoglycemia. So we could achieve a lower HbA1c target without the risk of having an excess episode of hypoglycemia, which comes as a natural side effect of any insulin that we give. Now coming on to this CREATE study, which is a real world experience. In this adults with type 2 diabetes, around 900 of them, they received Rhizodec and they were followed up for a period of 20 to 32 weeks. And what was the objective? The primary objective was a change in HbA1c from baseline to week 20 to 32. So what they saw in this, they were switched from OADs, basal insulin or other premix insulin and GLP-1 receptor agonist to OADs plus Rhizodec as a switch from the other injectable form of insulin which they had. And post this switch, what they saw was that there was a statistically significant HbA1c reduction in both overall and the basal switch patients. And this came at the cost of lesser hypoglycemic episodes. Also, the quality of life score was much better when individuals were shifted from basal insulin to insulin Rhizodec. So it was associated with an improvement in quality of life. In fact, 78.8% or almost 80% of the patients were willing to continue with Rhizodec, and 74% of the patients preferred Rhizodec over their previous basal insulin which they had received at the end of 22 weeks. So they wanted to continue on Rhizodec and not go back to their other insulin from which they had switched on. So we discussed about initiation, we discussed about the switch to Rhizodec from basal insulin. Now we shall be discussing about the intensification of these individuals. We know one shot of insulin would not work all throughout the course of diabetes. Finally, after initiation, our job does not end there. We now have to monitor the patient so that they maintain their HbA1c target over the long course of time. And for this, we need to have intensification of insulin. So initiation is not enough. Once initiated on insulin, they will maintain the HbA1c, but then keeping in mind the unique nature of diabetes, which is a progressive decline in beta cell function and progressive increase in insulin resistance over the time and other pathophysiologic defects, the insulin requirements and requirement of other OADs would increase over a period of time. So, in such a situation, a single shot of insulin may not be able to keep the HbA1c at target. So this is when the need for intensification comes, so as to not let the effort which the patient is giving in taking a prick of insulin every day go into vain. So unless they maintain their HbA1c target, they would have no protection against the long-term complications which come with bad glycemic control. Or unless they have a good metabolic control, they cannot prevent the complications which come out of a bad metabolic memory. So we need to intensify insulin, that is the bottom line. And in this study, in this step-by-step intensification trial, around 532 patients of diabetes were included. They were divided into two groups. One arm had IDEG-ASP, which had IDEG-ASP on initiation. They were intensified by giving twice daily Rhizodec. And in the other arm, who had basal insulin, say glargine or others, they were intensified, which could be glargine 100 or 300, they were intensified by giving a shot of short-acting insulin prior to their major carbohydrate meal. So they were continued on glargine, and depending upon the postprandial glycemic excursion or HbA1c target, they were intensified by giving basal plus basal 1 and basal plus, and basal bolus insulin therapy. So, they were started on a single prick. They would go to 1+1 prick, then 1+2 or 3 shots of regular insulin and 1 shot of basal insulin. Whereas the arm on Rhizodec moved from 1 prick to 2 pricks of Rhizodec. And the results were quite encouraging. So what we saw from this trial at the end of week 26 and 28 was that the HbA1c was non-inferior at week 26. So even with 2 pricks of insulin used as intensification, they did as good as individuals who were taking 3 shots of insulin, say 2 shots of regular insulin, 1 shot of basal insulin. So which means a lot, because you save from 4 pricks, you are going on to 2 pricks. When you are giving a basal bolus insulin regimen, that is definitely the gold standard of achieving glycemic targets. But then when you look into the convenience part of the patient, you're going from 4 pricks to 2 pricks. And at the end of 26 weeks, you're achieving the same HbA1c target. Non-inferior HbA1c target, the total daily insulin dose with Rhizodec was much lesser compared to the basal bolus insulin regimen that was used. Confirmed hypoglycemia was 10% lower with Rhizodec compared to that of the basal bolus insulin regimen, and nocturnal confirmed hypoglycemia was also significantly lower with IDAC-ASP. So that was throwing light into a very important field. So from 4 pricks, you give the patient convenience of 2 pricks. So why should we give convenience to the patient? We are giving the convenience so that we can prolong their adherence and compliance to the particular insulin regimen. Otherwise, taking 4 shots becomes sometimes challenging for the patient, and they may miss 1 or 2 shots of insulin throughout the day. So that becomes convenient with Rhizodec. There is mealtime flexibility. There is also flexibility in dosing. It can be taken with any major meal, compared to the fixed dose of 3 shots of basal bolus insulin regimen. And it would also be, though it may appear to us that Rhizodec is very costly, but when we look into the overall cost of an individual at the end of 1 year, we see that cost effectiveness of Rhizodec is more than other insulin. Why? Because it saves on the patient from developing hypoglycemia, so it reduces the number of visits to the doctor, reduces the number of emergency room visits, reduces the number of days that the patient is hospitalized because of hypoglycemia. So overall, when an individual is on Rhizodec, the patient spends lesser compared to what he would actually spend if he were on other insulin regimen, because of the lesser hypoglycemia and because of the better targets achieved with Rhizodec. So to summarize, we see that Rhizodec is a very effective molecule or insulin that gives us not only fasting plasma glucose reduction, but it is also very effective in lowering PPG in the same shot or in the same prick. It leads to effective HbA1c reduction, has a lower risk of nocturnal hypoglycemia. More people achieve the glycemic levels, and more people wanted to continue on Rhizodec compared to other insulin used for intensification, because they could use the same pen to intensify rather than using 2 different pens for different meals. There was mealtime flexibility in the dosing. There was an improved quality of life. It was found to be a cost-effective treatment option, though the immediate cost may be high. And it is also a kind of molecule which is also recommended by the Indian guidelines. So considering a customized treatment for the Indian population with its unique physiology and dietary pattern, even RSSDI guidelines recommend insulin initiation with Rhizodec. We may consider Rhizodec as an option for initiation. With that note, I thank you for the patient hearing.
Thank you. Thank you, Dr. Dike. If you kindly take your seat here. And now we can invite some questions from the floor. If you have any question.
Dr. Dika,
yeah, please
now
take your
in
seat.
my practice, what I do, I give 1 degludec injection and supplement it with short-acting sulfonylurea before meal. What is your opinion about that?
We can do that, sir. Even when we are intensifying insulin and using Rhizodec twice a day, The other third meal, if the patient takes 3 major meals, and the third meal can be covered with a short-acting sulfonylurea or with a PPG controller like Voglibose or Ecarbose, along with a short-acting sulfonylurea. I think that would also work great. Because even if we are giving insulin from outside, the small amount of insulin which is secreted directly into the portal circulation from the pancreatic endogenous insulin, which is increased with a small push of the secretagogue, would help to control the glycemic levels much better than giving exogenous insulin only.
To Dr. Supratik Bhattacharya. Now, if you give this weekly injection, would you give special caution to the patient that if you develop diarrhea or vomiting within the next 7 days, you must report it to your physician immediately?
So there are two kinds. We had talked about once weekly insulin, so that wouldn't cause diarrhea or any of the GI side effects. But we do have once weekly GLP-1 receptor analogs, which can cause GI issues. So today's talk was on once weekly insulin. So the concerns with the GI side effects are not there. Okay. Okay.
Hello. If it so happens, hello. Yes.
Yes.
If it so happens that mistakenly my patient has taken a second dose in between in Icodec, what will happen?
Yeah, so that's a very good question. So dose accumulation doesn't happen with Icodec, but we have to be careful not to inject yourself twice within the same span. So that way also it's very safe. We had shown you different concentrations, the PK, and we don't have a dose accumulation with 2 shots. So that's a very relevant question, like since it's a long-acting insulin, so you can't really, change the dose on a day-to-day basis. So we need to be very cautious. And if you're using some other agents which can, cause hypoglycemia, say for example sulfonylureas, which are ongoing, then you have to cut back on the sulfonylurea doses.
Yes. In case of the hypoalbuminuria, the Icodec will be safe to give.
Hypoalbuminemia.
Hypoalbuminuria.
Will there be any difference?
No. Suppose the patient is having a hypoalbuminuria. Okay. Icodec is combined to the albumin.
Correct.
So whether it will be safe to inject the Icodec?
Yeah, so it is reversibly bound to albumin, that's one thing, and then obviously that is going to affect, but we don't have a dedicated, study looking into the renal parameters in CKD patients, but once we have that, we'll be able to answer you better. We don't have that with Icodec at the moment.
So, Supratik, from the published data, do you have any safety concern with this injection Icodec? Any safety concern? Or just I want to know more that can you use it in advanced kidney disease and during pregnancy?
So we don't have any dedicated studies in pregnant females or advanced CKD, so to comment on that at the moment, but it works exactly as a basal insulin. So I don't know. It's very difficult to comment because we don't have the data backing it up at the moment. As for the local site, inflammation or local site reactions, is very similar to any other basal insulin.
I have one question for you. As we have the premix 50-50, do you feel there is any need for 50-50 aspart 50% with 50% degludec? As you mentioned that we consume more carbohydrate, our postprandial blood glucose is high. So do you feel that?
Actually, we do feel that when we have discussed with Novo people also quite a number of times when they are coming with this aspart 50 and degludec 50 combination, but they don't have any plans in the near future. Again, going back to that question where hypoalbuminemia and insulin Icodec is concerned, it seems the amount of albumin which is required to keep the state and binding is very less. So even if you have hypoalbuminemia, it is still safe to give this thing because the reserve which is there, even at very low levels, the amount of albumin it uses, icodec, is a very small fraction. So in decimals, point something. So even if you have little bit of the amount which is sustainable for life, that much amount of albumin is sufficient for a sustained delivery of icodec. And going back to the other question of having an episode of diarrhea or having dehydration, not eating with the insulin icodec, yes, the chances of hypoglycemia are higher, but then they are still as same as degludec, because degludec also has a half-life of 36 hours. And suppose the patient takes Tresiba and has an episode of diarrhea next day, the chances of hypoglycemia would be as similar to that of icodec, but one has to be cautious in keeping the calorie intake to prevent an hypoglycemic episode, or resuscitation from hypoglycemia would not be that difficult. Just giving a 25% dextrose, as with any insulin, would be as safe.
Partha, your question,
in this case,
do we really require a premix insulin anymore?
Yes, we do require.
We do, because if you have GLP-1, which is a generic, which costs less than your degludec and your isodec, and if I have a good basal insulin, and if I have alpha glucosidase covering my PPG, do we really need a premix insulin?
Absolutely, absolutely. Now, I've got the one question. When you intensify the treatment with the isodec, we prefer to give before breakfast and before dinner. Do you prescribe before lunch and before dinner? I have seen few prescriptions that before lunch and before dinner.
6 to 8 hours is the minimum gap that you should maintain between 2 shots of Rhizodec. So even if the patient takes it before lunch or before dinner, that wouldn't really predispose the individual to having hypoglycemic episode. So it is recommended by Novo Nordisk that way, to keep a minimum gap of around 8 hours between the 2 shots, and it is safe to be given.
So I think while we are intensifying, you give it with the largest meal of the day, and then you move on to the second largest meal of the day. So if that happens to be your lunch and dinner, that should be fine. Yes. Yeah. Second thing is, obviously a-weekly with once weekly semaglutide. I think that is the future. Combinations of just a Sunday treatment for both your fasting and prandials taking. Okay, yeah.
So, final question to both of you, that what do you think that insulin is losing its importance in the management of type 2 diabetes?
I don't think, because it's a pathophysiologic defect. So GLP-1 or incretin defect is one of the pathophysiologic defects, but insulin deficiency is also true. People with type 2 diabetes, they not only have insulin resistance, but insulin secretory defect is also something which is strongly there in these patients, and we cannot overlook that aspect also. So I think insulin would be there to stay, but perhaps with the newer formulations of insulin which we are coming, newer formulations of GLP-1 which is coming, there is going to be a kind of an era where we'll require less amount of insulin, so which would give us lesser episodes of hypoglycemia also, because high doses of insulin, more frequent insulin means frequent episodes of hypoglycemia as well.
Sumit, what is your opinion?
My patient on 30 years diabetic, on basal bolus regime, 30 of prandial and 50 units of basal, with AGIs, with SGLT2, and the HbA1c is 12. Now undergoes a bariatric surgery, comes back, is off everything, is only on a metformin. Now tell me, if my insulin is entirely lost from my system, how come my patient is normal, is only on basal insulin? Because you remember, we do not have loss of beta cells. They transdifferentiate to alpha cells when we have a bad environment. But if you bring them back by losing weight, then the alpha cells transdifferentiates to beta cell. So in future, if we can use reasonable price GLP-1, not the ones we were talking about today, and along with that give a basal insulin or other drugs, I'm seeing the requirement of insulin going down considerably. It will definitely go down. There will be transdifferentiation. But as Nilakshi said, if someone is, say, around 30 years diabetic and has actually critical amount of insulin which has gone down from the system and are osmotic, they have lost weight, they are lean and thin, they are true insulin deficient patient, they will require insulin. But just reflect back, 90% of insulin is being given because the oral drugs have failed, but they are obese. We know that is because of insulin resistance, not because they are insulin deficient. So I still feel a lot more GLP in generic price should come into the system. Lot more low price GLP and SGLT2 should be prescribed. basal insulin, I think, will be good enough to manage most of our patients.
I totally agree with Dr. Koshal, and just to highlight, as Dr. Nilakshi was saying, that SID variant, the young onset diabetes who are coming with severe insulin deficiency, is one of the places where you have to consider insulin to begin with. But otherwise, if it's insulin resistance, you take care of that, you know. Yeah.
So would you not give metformin to someone like a guideline is saying? No need of metformin, start straight away with SGLT2? That's what the 2005 guideline is telling you. I completely disagree with it. You will have to give metformin.
No, so, you know, ADA has done a good job in classifying as a glycemia-based approach versus a complication-based approach. So if you are having a established ASCVD, CKD, or a heart failure, you start with the SGLT2 inhibitor with evidence or a GLP-1 receptor analog, and then you get metformin on board. But if it's a glycemia-based approach, you would have metformin.
So Supratik, where does pathophysiology then come? Now you're saying I'm starting with SGLT2, so insulin resistance is no longer in the picture?
No, SGLT2 inhibitors would also take care of insulin resistance to a great extent.
I don't think hepatic glucose output is taken care of.
Not really, but they would improve the sensitivity to insulin in the sense that they would cause calorie loss.
Largest real-life data from Denmark has been published, more than 1 lakh. Those who have been taken off metformin after CKD had a higher mortality than those who continued. So we have to be very careful in taking metformin out of the system.
Yep. One more thing that I would like to add here is that the new guidelines actually recommend pioglitazone finds a place in the new ADA 2025 guidelines for protection of ASCVD.
It is very good. It has got very good anti-atherosclerotic property. So thank you.
And CVA as well. And metformin we can safely, you know, use up to an EGFR of 30 with declining EGFR without any concerns. And if suddenly take off the metformin, you know, the insulin requirement goes up, you know. So that is always a concern. And now with this data, it seems like metformin is going to stay.
Samit, I will just like to add to something that you said. After bariatric surgery, patient not requiring insulin. So we've seen that in these physiological studies where they compared the insulin secretion in a controlled environment of athletes compared to people who had normal glucose tolerance but were obese. So they had some degree of, say in the higher range, the PPG should be around 140 for it to be normal. But those who had PPG of say 110 compared to the group who had a PPG of 134 after a particular meal. Then they saw that the insulin which is secreted post-meal in the group where there was a higher normal postprandial glucose was much greater than what was secreted in the athlete group where the PPG at 2 hours was 110. So that implies, so there is certain amount of insulin resistance, but there is certain amount of beta cell secretory defect also which comes as a result of the over-exhaustion of the beta cells in trying to compensate for the increased insulin requirement which these individuals have. And when they're shifting from a higher normal BMI to a more normal BMI, I think this insulin resistance is tackled so that even a little secretion of insulin now suffices, even little endogenous insulin secretion suffices to keep the blood glucose at the normal level. So that is where bariatric surgery, weight loss, and all these would come into play.
Okay. Any more question from audience? No, in that case, thanks to Supratik and Meenakshi for a nice presentation. Now, thank you.
The biggest round of applause for Nirmal Lodha.
Yes.
From morning, and for our delegates from the first person to enter this hall. A clap for him. He's still sitting there asking questions. And thank you for all of you for staying back. Post-lunch is the most difficult time to stay back. And thank you very much, Parthoda. Thank you, Nilakshi. And thank you, Supratik. And thank you, audience. Because of you, it was a very, very nice program. And thanks to Shuntu, who has helped me through all the programs. And also Vishal, I don't know where he is, but they have helped me a lot. And to all the pharmaceutical company, we operate in a very small space. We have only 6 or 7 sponsors or 8 sponsors we work with. But small program, give your feedback, we'll try to improve next time. But we'll definitely go for an obesity workshop in the month of May. Please follow us on our website. We'll tell you. It'll be more, close range operation from how to go from epidemiology or setting up your clinic. So we will do that very soon. Thank you very much. And certificates are ready there, so please collect it from our stall, EKDG stall.